बंद हो गया। चलो ठीक है। हेलो या
एक पूरा खाना खा रही क्या
इसमें
नहीं साफ
नहीं ठीक है, ये उसमें आएगा,
ये तो आएगा
बाद में हम मुझे नहीं करना आइए आइए
बड़े बहुत कितना दिन
Good morning. So now going to start. I want to welcome you all on behalf of the North Delhi Patient Sankranti in our part because Sankranti is today because of the sunrise. So today happy Makar Sankranti and all the other festivals we get in this period. So we have been for the last 5 years, we have been annual conferences of North Delhi Fishing Forum in the same venue. And this year we have started. Dr. Bhatia sir, please be seated, sir. And this is the first time we are having mid-term conference, and this is going to be a regular affair from the next year onwards. So there will be 2 conferences of North Delhi Fishing Forum. One will be annual in July and mid-term in January. That's what we have planned. So now before wasting any time, we'll start the first session, and that is the NDPF North Delhi Fishing Forum quiz. Last time in the annual conference we did this quiz. It was very successful, very liked by many people and appreciated by all. So today is a quiz, and we all know who is the quiz master. We have got 2 quiz masters. Dr. Mukesh Bhatia needs no introduction. He is the director of Bhatia Medical Institute. He has produced so many PG students for the medicine and other specialties. So I welcome Dr. Bhatia to please come on the stage. And the second moderator is none other than Dr. Nityan Tripathi, very well-known cardiologist. Presently, he is director and head cardiology and electrophysiology, Fortis Hospital, Shalimar. Dr. Nityan Tripathi, please, and very good friend of mine. Right, we take tea every 2 days in a week together. And the chairperson, Dr. Sunil Khetarpal, very senior physician practicing in Shalimar Bagh, very remote person. Dr. Ram Babu, very bright and brilliant physician working in Jaipur Golden Hospital. He is a senior consultant. Dr. Hemant Sharma is a professor in medicine with special interest rheumatology at Hindura Hospital. And Dr. Jagdeep Chugh, he is also senior consultant, very eminent practitioner. He is associated with Fortis Hospital, Shalimar Bagh, as well as got own hospital, Satyam Hospital in North Delhi. So now I request the moderators or chairperson to start the proceedings? Dr. Chairperson, please. Thank you.
सो कितने लोग पार्ट ले रहे हैं क्विज के अंदर? गुड. तो यू वांट सिंगल वन और कैसे टीम बनाएंगे? दो लोगों की टीम बनाते हैं, तो एक टीम ये और दो, एक टीम ये और आपकी एक टीम कर लेते तीनों की. इज दैट राइट? ठीक है, तो ऐसे करेंगे. आप लोग यहां से उठ के इस साइड आ जाओ, इधर आ जाओ, इधर आ. या तो वी हैव 5 टीम्स, टीम 1, टीम 2, टीम 3, टीम 4, टीम 5. ठीक है. डॉक्टर छाबरा, उनको बिठाना पड़ेगा. तो चलो, वेरी वेरी गुड मॉर्निंग टू ऑल ऑफ यू. सो वेलकम टू द क्विज. हमारे पास 5 टीम्स हैं. 4 राउंड्स. Round 1 will be one liner, round 2 picture, round 3 MCQs, and round 4 will be ECG. Each question has 10 marks. There is no negative marking, no pass, as we have very less time. Total 34 minutes का time दिया गया हमें, so it's no pass. Tie for first, second, third team. In case of tie, decision will be by asking question to the tie team. We will tell you how many, and we will be telling you many golden points. Of course, upcoming should be solved. When you go out, you should be enriched by huge amount of information. Decision of the quiz master, that is myself and my colleague Dr. Nityan Tripathi, shall be final. Okay, so we start with team 1, team 2, team 3, team 4, and team 5. और कोई है? Anybody else interested? चलिए. Round 1, one liner. Team 1 के लिए. You get 15 seconds for each question.
डॉक्टर भाटिया,
Yeah. जी.
पूछो. हमें क्या करना है? कोई बाकी नहीं.
नंबर दे देना. ये दिया हुआ है.
ये नंबर नहीं.
सही. हाँ, 10 नंबर.
10.
बस. No negative marks. Yeah.
हेलो.
Name any disease in which secondary hyperaldosteronism occurs without edema free. Time out. The answer is severe gastroenteritis, Bartter syndrome, and Gentleman syndrome. Okay. Team 2. Which diuretic act at descending loop of Henle? Oh, Mike देंगे. Mike पास करते रहेंगे फटाफट. हाँ. या जल्दी प्रभा. No negative marking. No negative marking. To summarize, well, the answer is none. So let's learn the basic. Basic ये है कि a diuretic is a drug which inhibits sodium reabsorption at any part of the nephron. Descending loop of Henle is the one पे जहाँ पे सिर्फ water absorb होता है, sodium absorb नहीं होता है. So diuretic is natriuresis. क्योंकि वहां पर सोडियम एब्जॉर्ब नहीं होता, तो नन ऑफ द डायरेटिक एक्ट डिसेंडिंग लूप ऑफ Henle. क्वेश्चन 3, टीम 3. Paroxysmal bradycardia is seen in which condition? माइक लेते रहेंगे साथ साथ आगे.
Enteric fever.
Little louder.
Enteric fever.
Right answer is pulmonary embolism. Golden line to remember. Most common symptom of pulmonary embolism is sudden onset of dyspnea. Tachycardia is the most common finding. Most characteristic finding is S1, Q3, T3. उस सामने इसी दिया गया है. There are many people जहाँ पे bradycardia भी होता है, and that is known as paradoxical bradycardia. Okay. 4. Which electrolyte imbalance can happen with heparin therapy? Team 4. आगे पास करते रहेंगे फटाफट. Which electrolyte imbalance can happen?
Hypocalcemia.
Say that again.
Hypocalcemia.
Hypocalcemia. Well, the right answer is hyperkalemia. Well, Golden line to remember. Side effect of heparin therapy, hyperkalemia. Number 2, osteoporosis, and number 3 is thrombocytopenia, so-called heparin-induced thrombocytopenia. This thrombocytopenia is a unique thing. Despite thrombocytopenia, there is increased clot formation occurs. Now, एक और condition है जहाँ पे thrombocytopenia with increased clot formation. वो कौन सी है? Yeah, that is जो है DIC, no, PNH. Okay. Anyway, the right answer is hyperkalemia. अभी point नहीं मिलेंगे. Team 5. G6P deficiency is an X-linked recessive disorder. So female are the carrier and males are the sufferer. By which genetic process a girl child can also suffer from G6P deficiency.
Lionization.
Lionization. The answer is right. Give 10 marks to the team. तो अभी तक एक, don't worry, अभी बहुत rounds है. So this is unique. Lionization, golden line to remember. In extreme case of lionization, the normal X chromosome could be inactivated. Okay, जैसे वहाँ पे हरे वाला है, हरे वाला get inactivated. लाल one is the one which carries G6PD. So there may be significantly reduced level of G6PD due to so-called lionization. So even a female child, despite having X-linked recessive disorder, the lady can suffer. So in fact, हमने 10 लोगों की टीम का तैयार किया था. कौन सी टीम आई है? तो never mind, we have one more. Continue करते हैं. Team 1. Binding of B12 to intrinsic factor occurs in which part of the GIT? Yeah.
Stomach.
Huh?
Stomach.
Stomach. No, answer is duodenum. Factor B12 do not be other factor in the mouth and stomach. Intrinsic factor in duodenum, or receptor in distal ileum, and the name of receptor is cubam receptor. So congenital deficiency of B12 because of the problem in the cubam receptor. Okay. Team 2. Biochemical reactions occur in which type of hepatitis? Well, the right answer is hepatitis A. A में होता है. Golden line to remember. Serum sickness hepatitis B में होती है. और hepatitis C में jaundice is mild and absent. Episodic rise of liver enzyme and cryoglobulinemia can occur in hepatitis C. Okay, team 3. In which congenital kidney disease hyperkalemia occurs due to chloride shunt?
Barter's syndrome.
Answer is Gordon syndrome. Gordon line to remember, Gordon disease, metabolic acidosis, hypertension, serum aldosterone level is reduced, and hyperkalemia is there. Next team, team 4. Delayed bone marrow suppression is a side effect of which anti-cancer drug? Quickly. Well, the right answer is carmustine, lomustine. Now they are used for brain cancer. Or once you start the drug, the bone marrow depression occurs after 4 to 6 weeks. And very important point, brain cancer which has an extracranial metastasis is medulloblastoma. एक ही कैंसर है जो ब्रेन का तो cranium से बाहर जाता है. Question 10. Which type of glomerulonephritis can occur in Hodgkin disease? Team 5. Quickly. The right answer is minimal change glomerulonephritis. Golden line, the causes of minimal change, mostly idiopathic in children, HIV, Hodgkin and rifampicin से हो सकता है.
But that is nephrotic, no?
क्या चीज? Glomerulonephritis can lead to nephrotic syndrome. Minimal change glomerulonephritis and that leads to a nephrotic syndrome. So this is round 1. Now we come to round 2, picture based. You get 15 seconds for each question. Team 1. Which this type of tongue is seen in which condition? Team 1. Well, the right answer is a myasthenia gravis. ट्रिपल फरो टंग देखेंगे एक बार फिर, ट्रिपल 3 फरो आ रहे हैं इसके अंदर. एंड गोल्डन लाइन टू रिमेंबर, एज ऑफ इन्वॉल्वमेंट, फीमेल में यंग फीमेल होती है और मेल्स में एल्डरली मेल्स होते हैं. स्नार्लिंग फेज, ये जो स्नार्लिंग फेज है, क्योंकि बायलैटरल टोसिस होता है तो फ्रंटलिस मसल टेक ओवर कर लेती है. क्लासिकल स्नार्लिंग फेज. टीम 2, व्हाट इज दिस इक्विपमेंट नोन एज, या किसके लिए यूज करते हैं? Team 2. Plethysmography is the right answer. They get 10 marks. Well, RB, FRC and TLC, सामने आपके ग्राफ है. Time कम है, so I can't explain much. So these are measured using helium dilution technique or body plethysmography. Team 3. What is seen in this sputum of a patient? Cashman spiral, no. This is Birbeck granules, so-called Birbeck bodies. They are tennis racket shape, seen in histocytosis X. और इसके CT के अंदर ये क्लासिकल हनीकॉम्ब अपीयरेंस मिलती है. Team 4. What is this name of
Pemberton
this
sign.
sign?
Pemberton sign.
Pemberton sign, the right answer. Well, golden line to remember, this is seen in superior vena cava obstruction. Lung carcinoma is the most common cause of superior vena cava, especially small cell lung cancer. Non-pulsatile rays JVP. पोस्ट ग्रेजुएट के लिए इसको भूलना दंडनीय अपराध है. Don't forget this line. Not only one condition where we get non-pulsatile rays JVP is superior vena cava. Prominent upper chest pain होती है, सामने नजर आ रही है. Team 5. MRI of cervical spine, it is seen in which disease?
Ringomelia.
Good, correct, right answer. This is soap in bubble appearance. Soap in bubble appearance आ रही है ये वाली. Okay, and classically in syringomyelia you get dissociate anesthesia. There is bilateral loss of pain, touch and temperature. Position, vibration sense, they remain normal. Okay, cape-like distribution of pain. Team 1. A young man present with acute pain abdomen and has skin discoloration. What the cause of pain?
Acute pancreatitis.
Acute, right answer is acute pancreatitis. This is a flank pain, so-called Gray Turner sign. Extra knowledge. You also get this periumbilical, this lining, and this is so-called Cullen sign. We also get Fox sign when the coloration occurs in the inguinal area. Next team. X-ray abdomen, easy question है. What is your diagnosis? Team 2. ये easy question है. मार्क भी कर दिया मैंने. या माइक देंगे फटाफट. हाँ बोल देंगे. Well, this is porcelain gallbladder. There is a calcification of gallbladder wall, and it is. The main thing is it can lead to carcinoma gallbladder. Next thing, X-ray of hands in which condition? Easy है.
Rheumatoid arthritis.
Rheumatoid arthritis is the right answer. We have a rheumatologist sitting in the dais. So this is a typical, a golden line to remember. This is ulnar deviation of finger. उसके अलावा only part of vertebra involved in RA is cervical spine. Lumbar spine is not involved. That's why low backache is never a feature of RA. Sclera is involved. Uvea is classically not involved. Uvea is involved in ankylosing spondylitis. And malignant rheumatoid arthritis, when extensive involvement of skin occurs, then we use the term as malignant rheumatoid arthritis. Team 4. Endoscopy of stomach seen in which condition? Team 4.
Watermelon stomach. Watermelon stomach, sir.
Watermelon stomach is the right answer. Seen in which condition? Anyway, yeah, बोलेंगे.
Diapholase lesion.
Say again.
Diapholase lesion.
No,
Meningeal disease.
we give the answer. You give 10 marks. This is watermelon seen in scleroderma. Scleroderma, extra point. Scleroderma is the one condition where there can be sudden renal failure. Don't forget. Very, very important line. Scleroderma is the one condition where we have systemic hypertension and pulmonary hypertension.
Dr. Bhatia, 10 or 5?
10 marks.
10.
10 marks. Commonest internal organ involved is lower end of esophagus. ये 3 बातें नहीं भूलनी. Team 5. Extravagant sin with disease.
Gout, sir.
Gout is the right answer.
Stupid.
Is the right answer. Well, golden line to remember. This is जो X-ray है, Martel sign, G sign or red white sign. Golden line, acute gout is known as podagra, and grade 4 tenderness occur. Now, question open to all these 10 people who are. How do you do the grading or tenderness? How do you do grading? जो बताएगा उसको कप ऑफ कॉफी मिलेगी, नंबर नहीं मिलेंगे. हाँ. Anyway, partly right है. चलिए grading और tenderness ये आपको आना चाहिए. Grade 1 pain on touching. Patient cries on touching. Grade 3 he withdraws. Grade 4 he won't let you touch. He won't. And the causes of grade 4 tenderness are gout, septic arthritis, and arthritis occurring in rheumatic fever. Don't forget. So now we come to the third round. Oh, sorry, ये extra चीजें हैं. Yeah. Now we talk about round team. Team 1. Earliest feature of diabetic nephropathy. Team 1.
Raise GFR.
Raise GFR is the right answer. Microalbuminuria is the most common wrong answer. Right answer. Well, extra बातें. Capillary basement thickening is the classical feature of diabetic nephropathy. Diffuse glomerulosclerosis is the most common, and nodular sclerosis is the most characteristic. Team 2, most specific eye signs in Graves' disease. Quickly.
Widening start appearance.
Wide staring appearance.
Answer is chemosis. ये जो चारों हैं, lid lag, lid retraction, wide staring gaze, they are seen in all cases of thyrotoxicosis. But seen in Graves' disease are chemosis, proptosis, diplopia, proptosis, bulging of eye, chemosis, red eye. They are seen in Graves' disease. Team 3, which is not a feature of Cohen syndrome.
It's the edema feet.
Edema feet, right answer, correct. Cohen syndrome के अंदर extra बातें. Polyuria occur due to nephrogenic diabetes insipidus, which lead to hypokalemia. And hypokalemia से देर occur polyuria, और hypokalemia की वजह से muscle weakness होती है और distension abdomen. Best initial test to diagnose Cohen syndrome is plasma aldosterone concentration versus plasma renin activity is the best initial test. Team 4, alpha thalassemia is best diagnosed by. Team 4.
B. Nestrov.
No, Nestrov, no. Right answer is DNA analysis. So, alpha chain, there are 2 alpha chain, but 4 genes. अगर एक जीन नहीं है, चारों है तो नॉर्मल. एक जीन नहीं है, we call it silent thalassemia. 2 जीन नहीं है, we call it thalassemia trait. 3 जीन नहीं है, HBH, और चारों नहीं है, hydrophilialis. These patients don't survive hydrophilialis because there is no alpha chain. Feature of sickle cell trait. Next team.
Isosthenuria.
Eh?
Isosthenuria.
Isosthenuria is the right answer. Sickle cell trait, golden line to remember. यहाँ पे there is fixed specific gravity होती है and hematuria. Normal blood picture, no anemia. लेकिन with hypoxia like scuba diving or going to Himalayas, they can lead to venous thrombosis, especially in splenic vein. Okay. Next team, which is not now team 1. Am I right? Team 1 ही है दोबारा ना? ठीक है, sequence. Team 1, triad of UTI में क्या चीज नहीं आती? Easy question है वो. Quickly. Well, the right answer
Sir,
is
fever.
fever. No, you are late. You are late. Fever. हाँ जी. चल ठीक है. Fever, ठीक है. तब दे दिया. Team 2. Which of the following drug may be needed when we are treating a case of pernicious anemia with vitamin B12 folic acid? Team 2. Well, the answer is aspirin. Because when we treat B12 folic acid for pernicious anemia, that lead to thrombocytosis, that can lead to clot formation. और उसके लिए we have to give aspirin to prevent the clot formation, and hypokalemia is a well-known complication when we are treating with B12. Team 3. In which condition type 3 respiratory failure occurs? Quickly.
शॉक में सर बी में.
Oh, well, no. Answer is atelectasis. Atelectasis occurs in the post-op period. So that's why it's also known as perioperative respiratory failure. Type 4 occurs in any shock. और type 2 kyphoscoliosis और flail chest में type 2 होता है. Question 9. Carolus-sinus in which of the following condition? Team 4.
BMR, sir.
MR, no. Right answer is TR. TR, tricuspid regurgitation. If you read 12th edition Harrison, उसमें लिखा है Carolus-sinus tricuspid stenosis. If you read 14, 15, 16 edition, उसमें लिखा है Carolus-sinus early TR. If you read 18, 19, 20, 21, Carolus-sinus TR. थोड़ा Harrison में भी फर्क रहता है, but as of now, the right answer is tricuspid regurgitation. The last question. Say again. इसका टाइम कम है, इसे prominent V way.
Prominent भी.
TR. अच्छा. And the last question. इसके बाद ECG round. हाँ. In which organ mixing of arterial and venous blood?
लिवर सर.
है?
लिवर.
Liver. पक्का. Sure.
हाँ सही है.
Confident.
Yeah.
लॉक किया जाए.
Lock किया
आंसर लिवर है. ये जस्ट टू टेल यू बेसिक कंसेप्ट. देखेंगे ये रही वेन, पोर्टल टाइट में ये आर्टरी, ये जाके साइनोसाइड में मिलते हैं एंड अल्टीमेटली दे गो टू सेंट्रल वेन. ओनली ऑर्गन, यूनिक थिंग, nowhere else in the body where mixing of arterial and venous blood occur is liver. So this is my show. Sir, score क्या है so far? Now next round ECG का है and my colleague, कुछ और क्वेश्चन थे मेरे पास.
टोटल लगाओ सर.
Okay.
टीम ए का राउंड 1.
My colleague Dr. Nityanand Tripathi.
At the end of 3 rounds,
हाँ.
team 1 is 30,
30. Team 1
Team-
30. हाँ.
team 2 is 10,
Team 10.
team
Don't worry.
3 is 20,
20.
team 4 is 20,
हाँ.
and T5 is winner till now it's 40.
Okay, fine. ठीक है जी. So please.
Sorry for
participate.
interruption.
10.
There's an announcement. There will be prizes for the quiz completion.
Okay.
The 3
So-
prizes.
So team 5 is a winner.
Which will be rewarded after the inauguration. Thank you.
और वन मोर थिंग, इन एपिकॉन हो रहा है अहमदाबाद में 26, 29, 29 तारीख को मेरा क्विज है, वो 5 घंटे का है. आई विल मेक यू रिवाइज द होल मेडिसिन. अभी तो यहाँ 30 मिनट, यहाँ तो खाली 20 मिनट मिले हैं. ओके, तो ऑल आर कॉर्डली इनवाइटेड एंड मस्ट स्टे ऑन 29th मॉर्निंग. कौन सा? वो आपका वो पूरा ठीक नहीं था, आपका पार्टली ठीक था बोला सर. ठीक है.
So this is ECG in round 4. So I think the better thing will be any team can answer.
No, we go by sequence.
Then it will be difficult. I think that will be
चलो,
good.
what he want, any team can answer.
Any team can answer.
Done.
The team which recognizes first should
ठीक.
raise their hand.
Good.
But
Yes.
sir,
Tell me.
this will be pass कर दियो और it should be system 1 2 3 4 और अगर नहीं तो pass कर दो क्या दिक्कत दूसरा
That's
है ना?
that
अगर
can-
suppose मान लीजिए
So
5
we go
people
by
है
chair.
5 भी अगर आंसर देंगे तो this is
Right, sir. We
difficult.
go by chair.
टीम वन देगी,
So-
नहीं तो यहाँ पे पास अलाउ कर दो।
Team one, can you recognize it? If not, then passing.
Then pass.
30 seconds.
Pulmonary embolism.
No.
डायग्नोसिस क्या है?
What's the diagnosis? This a young man in shock came with a chest pain.
नहीं,
Wrong.
Wrong. Team B. Team
Team
D.
three.
Team C. Team D. And Team E.
Yes, please.
Ventricular tachycardia.
Pardon?
Ventricular tachycardia.
No. It's acute interval MI with RBBV. Young man with chest pain and shock, you can see there is ST elevation. Here you can confuse with the broad QRS, but when you see the QRS here, it's hardly 120. Here QRS is not 120, it's more than that. So that means the ST is merged with in the QRS, and in fact QRS is this much only. And this is ST segment elevation, this is ST segment elevation, this is ST segment elevation, and this is RBBV. So RBBV with ST segment elevation in all anterior leads, this is extensive anterior wall MI. And since right bundle branch is involved, that means deep septum is involved. So it's a patient is sick, the patient is in cardiogenic shock, and this is anterior wall MI. What is catching point? You can see the QRS here, the narrowest part of the QRS here, but here QRS is very wide. So QRS cannot be wide in one of the leads and can be narrow in another of the leads. If QRS is wider, then it will be wider in all of the leads. And this is the ST segment, because you are not able to see ST segment anywhere in these leads. While ST segment is here, you can see it clearly. So it's a ST segment elevation MI with RBBV. Obviously, this is sinus tachycardia. So when you are analyzing the ECG, I suppose that you know how to analyze. Go by rate, rhythm, axis, QRS, PR interval. Then there is any other findings, like in the previous one there was RBBB, and typically it is known as QRBBB. You can see a Q wave just before the RBBB, and when QRBBB is there, that's a typical sign of the this extensive infarct. And the diagnosis is acute ST segment elevation anterior wall MI with QRBBV indicating extensive infarct. So team 2, what's the diagnosis? This person presented with palpitations in ER.
किसके लिए सर?
Palpitation in ER.
सर किसके लिए कुछ?
Emergency room, young man presented with palpitation. No, it's not it. Team 3. Go by rate, rhythm, axis, any extra findings? Speak loudly.
So this is
So-
left axis deviation with no P wave visible. And
Same is, tell me the diagnosis. You are MD.
See, what the question? Question is the palpitation and was also given.
so atrial fibrillation is the most common.
No. See, atrial fibrillation typically have
Next team,
irregular
next
heart
team.
rate.
The junctional tachycardia.
No.
P wave,
Junctional tachycardia.
No,
yeah,
no, no.
somewhere near. So it's
Team 5, team 5.
Can it be hypothermia?
hypokalemia.
Hypothermia.
Time up.
So hypokalemia will have UF.
Time
So
up.
time up. So it's a
Postponed wave, sir.
PSBT, AVN RT. Why AVN RT? PSBT, why? Because you can see the rate. The one small square, two small square, it's 150. Rate is 150. There is a RBBB, small notch on the R. There is something here.
Isn't
These are the
postponed wave?
the retrograde P waves. So it's AVN RT. AVN RT, why? There is the retrograde P wave is within 70 milliseconds. 70 milliseconds means 0.07 seconds of the QRS, last part of the QRS. If it is within 70 milliseconds of the last part of the QRS, it is AVN RT. When it is more than 70 milliseconds, it becomes AVRT. So it is AVN RT, patient presented with the palpitation in the ER, and the typically the aberration is RBBB. Why RBBB? Because right bundle is thicker and it tends to fatigue first compared to the left one. That's why whenever there is a tachycardia, usually you see the RBBB, right bundle branch blocks. And because P wave is merging with the T wave, so you might see the ST segment depression in chest leads. So ST segment depression in chest lead again goes in favor of the AVN RT. So this man is AVN RT, and what is the treatment in ER? You give the adenosine or diltiazem. What is diagnosis? Team 3.
Team C.
PSVT.
हो गया, B से शुरू हुआ था.
Speak loudly.
PSVT.
Yeah, good. PSVT. Can you? It's normal. It's good, but can you specify further? We just discussed. If you can identify.
AVNRT.
No, it's a AVRT. It's a PSVT, AVRT, RBBB remains the frequent findings. But when you see this is the P wave, this one is the P wave, this one is the P wave, because this is changing. Here this is the P wave, here this is the P wave. These P waves are like, they are more than, they are almost 80 milliseconds after the QRS. So it becomes the AVRT, though it might be present in atypical AVNRT as well. So it's very difficult to differentiate absolutely clearly that patient is whether AVRT or AVNRT. But once you can see the P wave clearly, then it's a AVRT. So this patient is AVRT. It's electrophysiologically proven AVRT, and previous one also electrophysiologically proven AVNRT. The
Team C.
Team 4.
First,
What is the diagnosis?
Dr. Tripathi, what would be marks for last questions?
So team
He
3,
also made PSBT.
PSBT.
So,
PSBT.
but yeah, so 10.
10, yes.
Yeah.
So diagnosis. C23 AVF, patient is young,
Team 5.
around 10 years of age, female. C23 AVF and V1.
Team 5. No. Team 1. 2.
I further give a hint. Yeah, can anyone recognize?
Sir, inferior wall MI.
No. So it's something congenital heart disease. 10 years old female will not have an MI. Pardon? Yeah, AST is somewhere near. So why septum secundum? You are right. Okay. This is Crottage sign.
Sir, it is
Very specific for ostium secundum AST. RBBB, it's a RB overload in AST. So you usually get the RBBB. It's a Crottage sign. This is Crottage sign.
Crottage sign, sir.
Yeah. the top of the ROV is not. And it is 98% specific for ostium secundum ST. So very good.
Team three is on. You answer the question?
Yes, sir.
We are going to give you
This
marks.
this is what you saw already. So what is your diagnosis? Team 5. Patient 37 years male, presented in ER with chest pain. Chest pain of 2 hours duration.
Pericarditis, sir.
Team 1, 2, 3, 4.
Chest pain, 2 hours duration, 37 years.
Sir, hyperacute T waves.
It's a if it's the anterior LMI, you can see there is a ST depression, hyperacute T waves, and this sign is typically known as De Winter's sign. And De Winter's sign is ECG abnormality described by De Winter in 1998 recently, characterized by 1 to 3 millimeter ST depression and upright symmetrical T wave. This is the most important. Changes are dynamic, and if you wait for another 1 hour, there will be frank ST elevation here. It's the suspicious of proximal LAD, very typical, and represent approximately 2% of LAD occlusion recognized as a STEMI equivalent. And you have to take this patient either thrombolize or take for a primary PDCA. It's a De Winter sign in acute anterior LMI, very specific. What is this? Team 1 again. There are 5 teams. Team 1.
Dr. Have we got time to
Team-
continue
team
or
one.
should we stop here?
Team 1.
Left bundle branch block with LV strain.
Left one. No.
Sir, inferior LMI.
No.
Team
See more
second,
closely.
team 2,
Sir,
3,
WPW syndrome. Sir.
It's a WPW syndrome. You can see delta waves. It's short PR, short PR, short PR, short PR, delta waves. It's a delta wave. And when there is a tachycardia, it will mimic as a inferior or anterior LMI or LBBB or even mimic as a VT. This is typically confused with the VT when you see it. Typically confused with the VT. And I think this is the left posterior septal pathway. And what is diagnosis here? This ECG has many findings. This is 7, no? So 5, 6, 7. Team 2. Go by rate rhythm.
team 3,
If you don't go systematically, you will get confused for sure. This is very simple ECG. Go by rate rhythm.
team 4,
Team 4.
team 5. 10 seconds for any team.
Pardon?
First degree heart block.
My clinic.
No, wrong.
Sir, next.
So
Sir.
it has multiple
Sir, excuse me.
multiple findings.
Excuse me, sir.
Team,
Sir, prolonged QT syndrome, Romanov word.
so time is less. So we will go. I will explain you. This has multiple findings. You can see deep symmetrical T inversions in anterior leads. The T wave character is changing, and there is a P wave. So this P wave is same. It's a 2:1 block with hypertrophic cardiomyopathy, typical of the hypertrophic cardiomyopathy. Typical of the hypertrophic cardiomyopathy with 2:1 block. I said you go by whenever you see a ECG, and if you go by impression of the ECG, you are going to miss the findings, and you are going to make a wrong diagnosis. Go by rate rhythm axis, and then QRS, PQRS relationship, and extra findings. this is
Team three.
Team 3. Huh? Team 3. Go by rate rhythm QRS. This is 58 years male presented with the syncopal attacks.
Third degree AV block.
Near to it is the high degree AV block, 3:1. 1, 2, 3. So there can be like the same P wave can be exactly 1/3 of the QRS, even then it can be complete heart block as well.
Second degree AV block, Mobis type 2.
Mobis. Yeah, it can. It's okay. Fine. It's acceptable.
This is the last.
Points, sir.
So
Someone
of
answer
this
the question?
diagnosis.
Last question.
Dr. Tripathi,
Last.
someone answered the question?
Team
or not?
4.
Team 4. Anyone can answer. So I think there is a less, we have very less time, so I will answer you. It has multiple findings. Anyone? So there are multiple findings. You can see this is one, this is one, this is one, this is one, this is one. So there is bidirectional VPCs. This is a fusion beat. This is a fusion beat. This is the VPCs. This is what I intended to show you in this ECG. Fusion
Tamponade.
beat, multiple fusion beats and bidirectional ECG.
Last slide.
This is most important slide. So what is diagnosis?
Anybody, raise your
Anybody?
hand. Any team? We got less time. Any team?
Chest pain for 2 hours duration in and percentage in cardiac shock.
Interval MIs.
Pardon? It's multivessel disease. It's known as AVR sign. You can see there is a ST segment elevation in AVR. There is a multiple ST depressions in almost all leads. It's a typical for multivessel disease or left main. This is known as AVR sign. So,
Okay, sir. That's all.
I think the participants should not get discouraged. All these easy are level of DM cardiology. We are not even ready in MD and MBBS.
Chalo ji,
Don't
this
get discouraged.
all is well.
Final score.
So
Dr.
we
Hemant.
tell the score. So thank you so much all the participants for a very good participation. Thank you, Dr. Tripathi and Dr. Mukesh Bhatia for the wonderful presentation. At the end of the score, at the end of the quiz, the winner is Team 3, score 50. Second is Team 5, score 40. Third is Team 1, score 30. And fourth is Team 4, 20. And last is Team.
Anyway, all of you have done very well. Thank you very much for participation. Congratulations to all of you. Next one. Kisko subject?
ले ली बच्चों को बच्चों को ले ली now request the chairpersons to honor our moderators Dr. Tripathi and Dr. Mukesh Bhatia. We'll have a photograph of all the participants with the chairperson and moderators. Please come this side. ठीक है फर्स्ट क्लास अब दिख रहा है गोयल उधर दिख रहा है ठीक अब ये दिख रहा है ना स्क्रीन अब स्क्रीन दिख रहा है ना स्क्रीन ब्लॉक हो रहा है ये स्क्रीन मेन स्क्रीन ब्लॉक हो रहा है हो गया ठीक अब ठीक है ना सर So by the time this photography session is going on, we'll start the next session. The next session is challenges insulin therapy. This is a workshop, very interesting workshop. And the moderator is Dr. Deepak Khandelwal. He needs no introduction. He's a very renowned endocrinologist practicing Paschim Bihar, has got a very renowned clinic and is very young and very dynamic endocrinologist. And the panelists are Dr. Saket Kant in person. Dr. Saket Kant, senior endocrinologist working in Max Hospital, Shalimar Bagh, as well as Action Balaji Hospital. And we have got two eminent panelists, Dr. Shashank Joshi, No need of introduction. He is a great cardiologist practicing in Mumbai. He has been past president of API, RSDI, and a very renowned international endocrinologist. And Dr. B.M. Makkar, our own member, he is the president of RSDI at the present and practicing in Paschim Bihar. So they will come online, Dr. Joshi and Dr. Makkar, and physical is Dr. Saket Kant. And I request Dr. Nitin Dahiya to please come and join as a panelist. Nitin Dahiya, please. Now I request Dr. Deepak Khandelwal to start discussion. अच्छा, there is an announcement. We are going to poster presentation. So who are participating in poster presentation? Please go to the stall and give their posters. And there will be prizes. There will be 3 prizes for the poster presentation also. That will be given after inauguration. अच्छा ये लाइन पे हैं डॉक्टर जोशी एंड डॉक्टर मक्कर. आपने लगा आपने दूसरा तो उनको आपने एक बार दबाएंगे तो वेलकम कर देना.
Very good morning to everyone. Sincere thanks to NDPF, Dr. Chavda, Dr. Jha, and everyone for this wonderful opportunity. And I think it's a very interesting hybrid panel discussion or symposium on challenges in insulin therapy. So we have one of the panelists, Dr. Saket Kant, sitting here, and I think 3 persons are joining online. We have Dr. Shashank Joshi joining all the way from Mumbai, very renowned endocrinologist. We have Dr. Sanjay Kalra sir from Karnal, again, very renowned figure in the field of endocrinology. And we also have very renowned diabetologist, Dr. B.M. Makkar sir, also joining online. So, can we have our panelists also? Can we see our panelists who are joining online? So the topic is challenges in insulin therapy. So, Dr. Saket, would you like to let us know the 2 most common challenge that you encounter in your day-to-day practice regarding insulin therapy?
Thank you very much for that question. So what basically in routine clinical practice, the most common challenge is the patient is going to come to you and ask you whether insulin therapy once started would be for lifetime or not, because they are very much concerned about this. They may say that they have seen their relatives on insulin therapy, who had nephropathy later, who had cardiac disease later, and they link all this to insulin therapy. Whereas you have to explain to the patient that it is the other way around. When you have some diseases like nephropathy, kidney disease, or when you have some pneumonia or any infection, UTI, the insulin therapy may not be, it may not be permanent, it may be temporary, it may be given for some time, and then the patient can be on OADs again. The second most common challenge would be the phobia of needles and insulin. That can always be taken care of if you demonstrate insulin therapy at the clinic itself. And then, of course, the risk of hypoglycemia and weight gain, that is both a concern for the patient as also the physician. So counseling, I guess, is very important whenever you start insulin therapy. Tell the patient it may not be lifelong for many patients. For patients for whom it is lifelong, let them know at the offset itself. Demonstrate the first injection at the clinic itself. You can always demonstrate yourself so that you can decrease the risk, decrease insulin and needle phobia, and counsel regarding hypoglycemia as also weight gain. How can they minimize weight gain?
Thank you. Just a correction. We have got chairpersons for this session of the workshop. Dr. J.K. Sharma. Dr. Sharma, sir, please come, sir. I'm sorry for the... He is a well-known physician and he is presently president of RSDI Delhi chapter. Dr. Anish Gupta, renowned endocrinologist practicing in East Delhi. Dr. Rajiv Diwan, he is a senior consultant, Saroj Hospital, Rohini. Thank you. Please continue.
Thank you. So I need to confirm if any of the panelists has joined online. I think Dr. Kalra sir has joined. Any Dr. Makkar or Dr. Sasank Joshi, have they joined? Okay, fine. So I think Dr. Saket Kant highlighted two important challenges. One, patients believe it is going to be the lifelong treatment. Second, needle phobia. So if Dr. Kalra is there online, sir, because you are practicing in, in Karnal, Haryana, and you have been practicing for so long time. So has the practice has changed over a period of time in the last 3 decades, meaning whether the insulin initiations has become easy or more acceptable, if you are able to answer. Maybe Dr. Gupta sir, you want to take this question. Dr. J.K. Sharma or Dr. Anish, you want to take this question. Whether in the last 3 decades, the insulin initiations has it become easy or more acceptable?
Decades, what has happened is that people have become more aware that insulin is not the last resort therapy. It can be the first resort therapy for the patients. And of course, we always blame Google for a lot of things. But with the learning, the journey of the patient has become better. Also, what has helped is that earlier insulin used to be always a painful therapy. So every time that we were guiding the patients that you have to start on insulin, they had the memory of their granny or their grandfather taking injections of insulin. The delivery mechanism of insulin has improved. Now we are using pens. Those pens and the needles that we are using today has almost made insulin therapy quite painless. And once we demonstrate the patient that, this is the therapy that we are going to use, we are going to use the pens, the things have become slightly easier. The delivery devices, the technology that has come in, usage of insulin, delivery of insulin, prescription of insulin, that has improved a lot. And probably that is one of the reasons that has helped in making the patient more compliant with insulin also. And also in the initial insulin conversations, now the patients are knowing that insulin is not the therapy which is going to make their life lesser. Because earlier there used to be a myth that, it's a last resort therapy. Once we are going to start it, there is not going to be any medicine. Now the patient comes to us. Sometimes the patient is so much aware, they say that I want to start insulin because it is good for me. And that's the way the journey has become a little bit easier.
So I think important points highlighted by Dr. Anish Gupta, awareness has become better. The insulins, they have become better over a period of time. And the delivery mechanism for insulin, they have also become better over a period of time. So maybe Dr. J.K. Sharma, sir, I can take this question from you. Once you decide that, this is a patient of type 2 diabetes, you want to start insulins. So how you initiate insulin conversation with your patient?
Thank you. When we decide that this patient needs insulin initiation at the earliest, if the patient is coming to us for the first time, and if the HbA1c is more than 9 or 9, at the initial stage, we should convince the patient for insulin initiation. And we can explain the patient that maybe for 2 to 3 weeks to overcome the acute glucotoxicity, we should start with insulin. And once we spend little time with the patient, convince the patient, it becomes easy nowadays, as Dr. Gupta said, with the good quality pen, state-of-the-art devices. And I don't think that many patients refuse for this. The basic thing is that counsel the patient properly, tell how we are going to initiate, what we are expecting out of this, and then it becomes easy.
So I think important message from Dr. Sharma, good counseling. And, the counseling of the patients and the family member is very, very important. Dr. Saket, we have often patients in practice, they don't want to start insulins. And, if I was discussing yesterday with Dr. Kalra, कि OPD में 3 तरीके के patients आते हैं. मैं इंसुलिन नहीं लूंगा, मैं इंसुलिन नहीं लेना चाहता, और मैं इंसुलिन नहीं ले सकता. So we can have 3 kind of patients. I will not take insulin, I will not like to start insulins, and I cannot take insulins. So the first category, please, would you like to address? I will not take insulin.
I guess it is very important to sit back with your patient and counsel your patients. Tell them that insulin would be temporary for most of the patients. They would agree on that. Demonstrate, I guess that is what I was talking about, demonstrate the first injection in the clinic itself. That would, decrease the phobia of needles and insulin. Let the family be there when the patient is being counseled. And you always have to explain the process of insulin, that if you take insulin for this time, probably your medications that are basically not working because of glucotoxicity and lipotoxicity would start working, and you've got a lot of therapies now. You've got a lot of oral drugs that are very useful, but at times when you have very high glucose levels, you can always tell them that if they are losing weight, for example, that they'll start gaining weight. Insulin is the safest therapy at that time. So I guess sitting back and counseling a patient, even if the patient is adamantly refusing insulin, would take care of that in just about 99% of your patient. So you'll have to give 15-20 minutes of your time to that patient, counsel regarding the benefits, counsel regarding the side effects, tell them that it is not always permanent that the patient is going to take insulin, counsel regarding hypoglycemia, counsel regarding the weight gain, and probably you're good to go even in patients who are adamantly refusing insulin.
So I think what Dr. Saket Kant is again emphasizing, we need to sit with the patient. We need to discuss with the patients and their family members. We need to address their concerns, and counseling and more counseling. I think that is the answer. Dr. Diwan, one more category I was talking about, मैं insulin नहीं ले सकता. And there can be some, reasons for that. So how would you like to take those kind of patients?
Actually, if you have to go into the background of why patients are taking insulin, there are two main reasons. What I have seen in my experience, there are two main reasons. If you see 95% of patients, why they don't want to take insulin. One, they say that if you start the insulin, it will be lifelong. Number one, the doubt they have in the mind. Even if you start insulin for a short time, for example, hospitalized patient or patient come with glucotoxicity very high, we tell them that you give you insulin for a short time, then shift to oral drugs, but they will not take. Number two doubt in their mind is that if they start on insulin, it is the end of the life. Because the people around them, patient, they will say that, oh, you are on insulin, now your life is numbered. These are two basic questions in the mind of the doubt in the mind of the patient. If you address to these two questions, most of the patients, they take insulin. I have seen that. Because they have this in the mind, oh, now my life is finished, I am on insulin. What will the people say? If you ask them in detail, they will say these two things. So I always address these two questions, and many of them, they agree. Because unless we solve these two issues, they will never take insulin. That is why they say, I will not take insulin.
So thank you, sir. So I think what, again, Dr. Diwan is trying to emphasize, they have certain myths in their mind. They have listened to certain things. And I think, again, addressing their concerns and proper counseling is the answer. Among the audience, anyone has any doubt regarding, insulin initiation, or any questions you want to have with the panelist? Anyone? So, Dr. J.K. Sharma, sir, you have, I want to, because you must have so many of patients who were very, very difficult to start on insulins, and eventually you should have, you must have started them on insulins. So any good examples from your practice you would like to tell the audience where the patient was very difficult, but eventually you were able to start on insulin?
The very much phobia, the needle phobia is very important. And if you give the first dose of insulin at your clinic, either by our educator or by our nurse, or even you can give yourself to your patient the first injection, and that is really giving satisfaction to the patient also, to ourselves also. And in that case, patient starts with the insulin. Second thing is that availability. They have an apprehension that suppose with insulin my sugar levels go down, and any episode of hypoglycemia once in lifetime of the patient is really scary, and it becomes difficult to continue insulin in such kind of patients. So be available to the patient. Maybe initially he may ring you 3 times, 4 times. And if you ask your patient that do the SMBG and report to me, at every time, it hardly takes half a minute to satisfy the patient, to guide the patient that, look, this is your blood sugar level and this is how you should react or behave. And that becomes very easy. And this is the practical tip which I want to give. Please spare some time for your patient in the initial stage when we start insulin. That is what I want.
Thank you, sir. So I think very important messages from Dr. Sharma. One, if the first dose can be given in your office, whether you want to inject that insulin, whether your nurse or educator or someone, the first dose, I think almost 95% of fear of the patient goes when the first dose is being given into the clinics. And then second, as he very well highlighted, they have fear of hypoglycemia. So in the same line, Dr. Hanish Gupta, sir, one, when you are using insulins in your practice, one, how can you minimize the risk of hypoglycemia? Second, the hypoglycemia is eventually a reality when the insulin therapy is there. So how can you minimize the impact of hypoglycemia?
And that's a very good question, Dr. Deepak. So what I want to say is that education about hypoglycemia at the very beginning of any kind of therapy, whether oral hypoglycemic agents or insulin, is the pivot by which you can establish a trust with the patient. When we are treating a patient of diabetes, we are all dealing with a double-edged sword, because all medicines are diabetes are meant to bring down the blood sugar. And sometimes the patient's response to the medicine is going to be very varied, because there is no thing like exception in medical science. You can always encounter exception at any nook and corner. And whenever the patient is encountering a hypoglycemia, an educative effort by you from in the very beginning that the patient is going to have such kind of episodes is going to save a lot of effort from you later on, because we always get calls from the patient, frantic calls that my blood sugar has touched 50 or 60. So if we have already guided them that this is a situation that might happen, then later on we might not have the trust deficit from our patients. On the other aspect, I also want to say that reason of hypoglycemia is the reason behind the inertia that all of us have towards insulin. We start not with a robust dose of insulin, despite knowing that this patient is not going to have benefit with 10 units or 20 units. We start with a very low dose. And sometimes that is what, makes the patient lose the patience. We start with a very low dose of insulin. The patient comes back to us and says, Doctor Sahab, isse to kuch bhi nahi hua. So my take on this is that you should always start with a robust dose of insulin to begin with, because if the patient is going to have very good blood sugar control at the very beginning, then its patience is not going to waver. We start insulin, we are starting with a low dose because we are also having inertia. We think that hypoglycemia is going to happen. And then the patient who was coming to us, say around at 300 milligrams, he has come down to say 250 or 280. He says, Doctor Sahab, aapne insulin bhi prescribe kar diya, isse kuch bhi nahi hua. And then he says, isko hata do. And then we don't have an answer for that. So whenever you start insulin, educate the patient about the risk of hypoglycemia. Always start at a balanced, robust dose so that you can have good winning streak at the beginning. The patient might have a very good blood sugar control. His confidence in the insulin therapy would grow, and that would be the reason that he would continue on the insulin therapy. We start with very low doses, and later on the patient starts blaming us. So don't fall in that cascade.
Thank you, Dr. Hanish Gupta. So, Dr. Sakit, I think there is a important message as Dr. Hanish Gupta was talking about, and I think it is important in practice also. Patients, you initiate insulins maybe 1 year back, they keep on taking the same dose of insulins. Follow-up is, you can see the poor in practice. And after 1 year की सर अब हम 1 साल से इंसुलिन ले भी रहे हैं, अभी भी मेरा HbA1c 9 है या 9.5 है, तो इससे तो मुझे क्या फायदा हुआ? So what can be the reasons why, in spite of taking insulins, now still the glycemic control is poor? What went wrong? Whether we were wrong or whether the patient was wrong, and what could have been done?
I guess equally important as initiation is up titration of insulin. You have to up titrate insulin to achieve your targets with minimal risk of hypoglycemia. So your up titrations can be physician based. That would be very difficult for you, but you can easily teach your patients also to up titrate, because now if you see, most of our patients would be on a basal insulin because of the plethora of drugs that we have to control the postprandials. So not many of our patients would be on pre-mixed insulins or basal plus. We don't have many. We used to have many patients on these therapies 5 years back, but with the advent of newer therapies for postprandials, especially GLP-1 receptor agonists, DPP-4 inhibitors, the good use of AGIs now, probably most of our patients, I guess you'll agree, that would be on basal insulin. So it's very easy to up titrate basal insulin. That can be taught to the patient based on the half-life of the insulin that you're using. So I guess the better regimens that are there are regimens of up titration 1 unit per day, but I don't go in for that. 2 units every 3 or 4 days make more sense based on the half-life of the insulin that we are giving to our patients. So tell the patient that it is not only initiation that is important. Initiation is just to decrease the risk of hypoglycemia, to make you acquainted with the insulin therapy. Up titration to achieve your goals is also very, very important. And up titration, you can always teach the patient, and you can make yourself available for if there is any confusion in up titrations You can just give support to the patient for the initial 4 to 5 weeks regarding that, and then the patient will up titrate. So many of my patients who are basically taught up titrations, they do well, they come back to you. And the second is they have to have good follow-up. If they come back after 1 year on the same dose, I guess that does not make sense.
So I think the important message given by Dr. Hanish and Dr. Saket Kant, that optimal titration does not happen in practice. And probably, it may not be always feasible at the level of physician. We need to taught our patients and their family members the optimal importance of titration and how to titrate insulin doses. So any questions from the audience? You have expert panel sitting. Yes, sir.
Strata patients. What about the poor people from Juggi Jopri? They are also having HbA1c in the range of 11, 12, and self-monitoring is not possible with them, and they are not educated enough. So how to deal with such strata of patients?
Very, very, very important question. And Dr. Ivan, would you like to take this question?
This is a very valid question and a very good question for this forum. We have to address the fact that the people who are living at the fringes of the society, they are lean and thin also. And lean and thin patients, they require insulin more than the patients who are coming to us with a high BMI. And these patients, when they are coming to us with a HbA1c of 10%, as you pointed out, 10% or more, sir, SMBG is not something that is very much required. Of course, it is very valid, and sometimes they don't have the education to deal with it, but they can be asked to come frequently to the clinic for the titration, number one. The second thing is that they should be explained that they are going to lose a lot of body mass, they're going to lose a lot of muscle mass, their own survivability is going to become problematic, and the multi-organ dysfunction and the multi-organ problems that they're going to face, that is going to be enormous. So these are the patients who require insulin more, and also not just for the organ preservation and for their body preservation, but also for the fact that sometimes these patients, they cannot afford the new medicines like SGLT2 inhibitors, like oral semaglutide, which is available, or the DPP4 inhibitors, or the cascade of medicines that we are having. So insulin therapy becomes less expensive for them. If you go for the conventional insulin, insulin therapy is much less expensive for them than the whole cascade of medicines that we are going to prescribe as oral hypoglycemic agents. So if we bring these factors to them, we have a proper insulin workshop, not workshop, but insulin backup in our clinic. There is a nurse or there is a diabetes educator at the clinic who is always in coordination with them. Then I believe that we may sort out their problem. And as doctors, we have a responsibility for those people as well, not just for the higher class of the society, but those people as well. And if we are able to treat them, the results are absolutely gratifying. They're much more gratifying because they are probably the only bread earners of their family. And if we are saving them, we are saving a family, not just a patient, but the entire family. That's my take on it.
I think very, very important point, very important question, and very well answered by Dr. Hanish, and I would actually agree with him. And in fact, in most of the government hospitals in Delhi, all conventional insulins, regular insulins, NPH insulins, and even pre-mixed insulins, they are available free of cost in form of vial and syringes. Vial effective. There can be some issues using them, but if you train your patients, their family members, they can very well take that. All conventional insulins are equally effective. Your modern insulins may have lesser risk of hypoglycemia. That can be the only advantage, but all conventional insulins are equally effective. What is really important, whenever you are putting any patients on insulins, hypoglycemia should be explained to the patients and the family members. The most common problems arises because they are not able to recognize hypoglycemia. 5 days back only, one of very renowned dermatologist of Paschim Vihar, wife is also a doctor. I was treating them for last 1 year on insulins. When they had hypoglycemia, they actually went to emergency, got first thing the ECG done, and then somebody said, get the RBS done. It was 40, and they were not able to even recognize that why this sweating and everything is happening. So let me tell you, because the main challenge is that people are not able to recognize hypoglycemia. You must tell them any acute symptoms in a patient in diabetes. The first thing that should come into their mind is hypoglycemia and correction of hypoglycemia. And as Dr. Hanish Gupta rightly said, sometimes they may not have available glucometers or something like that, but if they feel symptoms suggestive of that, they must take measures to correct hypoglycemia. So I think any questions from audience? Yes, sir. Yes, sir. Agree.
Is not very costly. Is a cost effective they do at home. But only thing I would to impress upon them that they should do it.
Thank you, sir. We have Professor Richa Devan sitting here. Madam, any comments from your side?
The panelists have given all the key features which should be done. I really thought that it's important to recognize these acute symptoms, especially hypoglycemia at home only. And as doctor said, that we can test it at home. And a lot of our patients, they're able to make a diagnosis themselves. Like if they're educated, they are able to do it, and they can also reach they take treatment and they also reach the hospital.
Thank you, madam. If we have any of the panelists who have joined online now, we can have comments from them. Otherwise, I would request Dr. J.K. Sharma and Dr. Saket Khan to give the concluding remarks. We have Dr. Kalra, or you can see if they are there online.
If there's nobody, I would like to add.
Yes, sir.
Still have a very significant role. Maybe worldwide, they are ignoring premix now, no more. But for a country like ours, still premix has a role to play, and that's very important. 4 times insulin may not be possible basal bolus. So premix has a role, and it's cheaper also.
100% agree, sir. In fact, 4 years back, only we were looking for the data, and 2/3 of the patients in India who are taking insulins, they're actually taking premix insulins. The most common prescribed regimen in India as of now, still, date is premix insulin. So any concluding remarks from?
I just want to add one thing that as sir has rightly said, every patient who is prescribed insulin, they should be actively counseled to buy a glucometer and also a pack of Glucon-D. What I do in the practice while they go home or they go to house. Because if there's hypoglycemia, what they do that they start eating some toffee, something like that, and waste time, or start calling the consultant. And the time is lost. Sometimes they're going to coma, they're going to land up in emergency. So I always tell them, whenever you have symptoms of hypoglycemia, first take the Glucon-D, then to call anybody else. This saves many patients I've seen. And glucometer, everybody has to be educated to how to check the glucometer, the sugar. First thing they have to check the sugar, then to think of something else. So many of the casualty admissions can be avoided by this.
So we can see Dr. Sanjay Kalra, very renowned endocrinologist from India, from Karnal, Haryana. He past president of Endocrine Society of India. So, sir, any important messages from your side and any concluding remarks, sir?
What has been said is very right.
Sir, please be little louder, sir. Louder, sir.
I would just like to reinforce what everybody has said. The first thing is that insulin, of course, is a science, but it is an art as well. So we should learn how to communicate. We may think we are good orators, we may think we are good communicators, but who will decide whether we are conveying the message properly? That is the person in front of us. And sometimes our younger boys and girls get frustrated because we see our patients going to alternative care, to complementary care. The reason is that those people are better communicators. So first message is, I think we should all become a bit humble. Just like in the quiz, I was humbled. Our teams did a great job. They were able to answer all the questions. For me, everything went over the head. So first of all, we should be a bit humble, and we should accept that we need to learn communication. And then we need to keep on practicing throughout life. That is one message. And second message is we should be able to use insulin in a safe and smart manner. So using glucometers, practicing glucovigilance, teaching our patients hypoglycemia awareness, being in touch with them, this is important. And this is a topic which I continue to struggle with. I'm sure the other senior members will also agree. Even after 2-3 decades of experience, it is still tough to get your patients to initiate insulin and then to get them to continue on that.
Thank you, sir. I think little issues with the voice, but I think 2 important messages from Dr. Kalra's side. One, we need to sit down with the patient and the family members. And I think one-to-one counseling is very, very important, and use insulins in a safe and smart way. These are the 2 important messages from his side. So I thank you, everyone, Dr. Sanjay Kalda, sir, all the panelists and organizers. And I think I hand over back to the organizers. Thank you.
Before that, I would like to give one comment.
Yes, sir.
For all our healthcare professionals, there is nothing like sliding scale management in insulin. Please do not follow, because it has nowhere written in any guideline, any textbook. Sliding scale insulin is nowhere. Decide what is there in the last 24 hours, and accordingly you do. Either you decrease the dose or you increase the dose, but there is nothing like sliding scale. So this is for the young professionals who are going to join our profession. Thank you very much.
Thank you. Thank you, sir.
Excellent moderation, Dr. Deepak.
Thank you, sir.
Thank you, Dr. Deepak, and all the chairpersons and panelists, especially Dr. Sanjay Kala to coming online. So I request all the chairperson and panelists to please honor Dr. Deepak Khandelwal. And I invite Dr. Pitang Gupta to honor the chairpersons. Come this side, sir. In the meantime, we'll start the next session. Niche. Come this side. Next session is very, very important session because we have a very eminent speaker, Dr. Randeep Guleria. Doesn't need introduction. Earlier he was the director of AIMS. Now he is associated with Medanta. And the topic is medicine practice and art. And presently the chairman, Institute of Internal Medicine, Respiratory and Sleep Medicine at Medanta, Gurugram. And the chairpersons are Dr. Richa Diwan. Dr. Diwan, madam, please. She is a professor and presently associated with Sir Gangaram Hospital as a senior consultant. Dr. A.K. Malhotra, very senior physician. He is associated with Max Hospital, Shalimar Bagh, and presently he is the vice president of our North Delhi Physician Forum. Dr. Sunil Khetarpal. Dr. Sunil Khetarpal, sir, please come, sir. He is the director of AHPI, very active member, and he was earlier director in Rajiv Gandhi Cancer Institute. Dr. Sunil Khetarpal. And Dr. Pitang Gupta, sir. Dr. Pitang Gupta, sir. Dr. Pitang Gupta. Come as a chairperson for this session, sir. And Dr. Pitang Gupta, he is a very senior physician, member of Knowledge Physician Forum. He has been past president of API National, and presently he is senior consultant at Fortis Hospital, Shalimar Bagh. Now I request the chairpersons to introduce Dr. Deep Guleria and the topic. Chairpersons, please. And for the concluding remarks, we have Dr. K.K. Parikh. Dr. K.K. Parikh, sir, please come, sir. He is a past president of API National. He has come from Ludhiana.
Kota.
Kota. He has come from Kota, Rajasthan.
Good morning, everybody. I have been asked to introduce Professor Guleria. He needs no introduction. He is currently working as a chairman in pulmonary medicine and sleep disorders at Medanta. He had been director of All Institute of Medical Science, and prior to that, professor and head pulmonary medicine and sleep disorders in All Institute. Well, to know about his honors and medals which he has received, it's very difficult to count them, but the few of them, the very important Dr. B.C. Rai Award 2014, Padma Award 2015 by President of India, and our prestigious award of API, that is Dr. Jeevrat Mehta Award 2019 in Agra. In addition, he has got national and international awards and honors. Professor Guleria has done a marvelous job during COVID era. As you all aware, whole of the public used to sit to listen to him when he was on television. He was an authority and still an authority who used to take a lot of virtual lectures for the doctors to teach us about the updates, the management, and the issues regarding the COVID. Well, with these words, I introduce Professor Guleria, who is a master teacher, excellent orator, clinician par excellence, to deliver his talk regarding how the medical practice is an art in addition to skill. Dr. Guleria, please.
Thank you very much, Dr. Gupta, for your kind words. Thank you. I'd like to start by thanking the organizers, especially Dr. Chabra, for inviting me, and it's a pleasure to be here. I'm going to be talking on medicine. Is it still an art, or has it been replaced by science? So times are changing. The last 60 years has seen more changes in medicine in the last 2 centuries. We're living through a revolution as far as medicine is concerned. We've seen major advances in the field of pharmacology and technology. During my time, the changes, we had limited number of drugs available. Now we talk of biologicals, we talk of immunotherapy, there's CAR T cell therapy. So such a lot of new things happening, not only in the field of oncology, but in all areas of medicine. Technology has also come in medicine into a big way in terms of the way that we are able to diagnose and use technology for various interventions. So genomics, phenotyping, functional imaging are changing therapeutic practices like never before. We are living through what is known as the 4th industrial revolution. And this has led people to question how medicine will be in the future and how the practice of medicine will change. If someone asks me what will be the doctors of the future, how will doctors practice medicine 10 or 20 years from now, I think it's a very difficult question to answer right now. You will have virtual reality, you will have artificial intelligence, wearable devices, all will guide how medicine is being practiced. And therefore, what is happening is that we are living through a revolution where there is a blurring of lines between physical, digital, and the biological spheres. We have mobile devices, everyone can monitor ECG, we have patients who diagnose AF based on the Apple device that they have on their watch. We have the Internet of Things which is available. We have basic advances like 3D printing, which is now being used quite extensively, big data analysis to predict events even before they happen, and a large number of other things as far as teaching is concerned, including augmented reality. So starting from the 1st industrial revolution, where we had the steam engines, to the assembly lines, which came in the 2nd industrial revolution, to the 3rd industrial revolution, where computers, internet came in, to now the 4th industrial revolution. So healthcare is one area which will really change dramatically with this industrial revolution. And there will be digitization as far as healthcare is concerned. And this is going to create a lot of change in the interaction between patients, caregivers, and even government and stakeholders. Even now you have patients who will do a great research thanks to the internet and Google as far as the disease is concerned. The implementation of these technologies is leading to disruptive innovations in healthcare, enhancing patient-centric health policies. And therefore, the core changes that we'll see will be new methods of treatment and diagnosis, new methods of monitoring our patients as far as health status is concerned. We saw that during COVID, you could monitor your patients, even e-ICUs was used extensively during COVID. Teleconsultations were done both for COVID patients when home isolation was proposed, but even before that, for those who were not willing to come to the OPD when OPD was shut down, a large number of patients with non-communicable diseases were managed at home. Even patients with diabetes were managed at home using teleconsultation. And there is going to be innovation in the management and organization of the health system, and access to healthcare using remote sensors and devices will actually happen. So what is going to happen? We'll have artificial intelligence, the Internet of Things, augmented reality, genome editing, robotics, 3D printing, big data analysis. All of this is going to really change how medicine is going to be practiced in the future. And therefore, science and technology is going to change medicine right across the human lifespan. From IVF, embryo selection, to genomic interpretation of newborn diseases, right up to looking at mental health, using artificial intelligence to diagnose radiological images. We have a whole program now by the government where one is looking at artificial intelligence to be able to diagnose chest x-rays, x-rays of bones to pick up fractures, even in remote areas where a physician is not available, ECG interpretation. pictures of skin lesions to be able to diagnose dermatological disorders. All of this is going to happen and going to change how medicine is going to be practiced. So therefore, the core question that comes up is there still an art to the medicine, or has it been overtaken by all of this science that we have seen happening in the last 2 to 3 decades? My take on this is that the role of a doctor hasn't changed much over time. And even if we accept all the advances in science and the fourth industrial revolution, the basic premise of a doctor remains the same. So no matter how much technology there is, when you're ill, you will still want to go to a doctor you can trust, who understands you, who's able to interact and communicate with you. So despite all advances in science, it is important to understand what the patient doesn't tell and understand the patient's expression, insights that technology will never be able to offer. Therefore, the role of a physician is more than just what science is able to offer right now. And I'll give you one example. This is a lady I saw many, many years ago, a 13-year-old girl who came from Ajmer. She had episodic cough and breathlessness since 2007, and she was diagnosed with asthma, and she was on long-acting beta-2 agonist, inhaled corticosteroids, and was also on anticholinergics. But she had increasing breathlessness over the last 1 month. She had inadequate control, and she was seen by a physician there and referred to us to consider giving her biological therapies. Now we have new biologicals for asthma, anti-IgE therapy, anti-IL-5 therapy, anti-IL-4 and 13 therapy. A lot of new drugs are available. She had bilateral polyphonic bronchi. Her history, she had eosinophilia. Eosinophil was 14%. Her father told me that her eosinophils had always been in double digits. And she was seen in the OPD by the resident and was referred for consideration of biologicals. So the resident brought her to me for a second opinion. This young girl sat quietly during the entire presentation, seemed agitated and unhappy at the resident, as the resident gave the history, and her father nodded along. I asked her if she was all right and if she had anything to add. And she looked at me and she said that she had so many other problems which were totally ignored. She had developed a maculopapular rash 3 years ago and was seen by a dermatologist, was diagnosed as a drug rash. She also felt decreased sensation over her right foot, which was passed off as functional. And when I examined her, she had some wasting of the right leg, and there was decrease in the sensation. She had eosinophilia of 22%. Her CTD workup was negative, but nerve conduction study and EMG showed sensory motor neuropathy of bilateral median nerve, right tibial and sural nerve. She had mononeuritis multiplex. Echo showed MR with the left ventricular ejection fraction of 42%. This is the X-ray she was carrying, and the X-ray that we got done showed this. And she basically had eosinophilic granulomatous with polyangiitis, Churg-Strauss syndrome. The diagnosis was missed for so many years because no one actually listened to what the patient was saying. And that is the art of medicine that science will not be able to give us. And there is a paradigm shift that we're seeing in medicine. But I think in this era, there is still a great importance of clinical medicine when you look at investigative medicine. I myself have so many examples that I think I should write a book on the importance of clinical medicine in this era of investigative medicine. Because technology has changed the way we practice medicine. We become more and more dependent on reports than on the patient's clinical issues. Listening to and examining a patient has become less common. Many residents will first tell the patient to show all the reports, look at the X-ray rather than actually looking at the patient or asking for the patient's complaints. And that is what we're losing out. We're losing out on the art of medicine. And this is what we see in papers nowadays. Doctors in India see patients for just 2 minutes. In Ireland, you have doctors who will interrupt the patient and say, look, I know what you have, so you don't have to tell me your history. As a matter of fact, the data suggests that doctors will interrupt the patient while he's telling the history in less than 30 seconds and will make a diagnosis based on that. So I think it's important that we understand that we are not listening to our patients. And are we really listening to our patients? To hear with thoughtful attention. So there's a difference between hearing and listening. Hearing is accidental, involuntary, effortless. Listening is focused, voluntary, and intentional. Listening for total meaning, the content and underlying emotion is very, very important. And I think this is something that the younger generation needs to really focus on. Responding to feelings. Sometimes the real message is in the emotion that the patient really tells you when he gives the history rather than what the complaints are. Note all cues, not all communication is verbal. And reflecting, demonstrating that you have heard what the patient has said is also very, very important. So in my mind, active listening is difficult work. We listen not only with our ears, but with our eyes, our mind, our heart, and imagination as well. This is what is very, very important when we really talk of the art of medicine. William Osler said, listen to your patient, he tells you the diagnosis. And I would just add to that is observe the subtle behavior of a patient. It may give you the diagnosis. A small tremor that the patient's hand may have while he's talking to you, which he's trying to ignore. A little bit of alteration in the patient's gait when he walks into the OPD is another thing that will give you a diagnosis. So these are important things that you need to observe. And that is the art of medicine. This is what was given by Charles in a book of Expression of Emotions in Man and Animals, saying that just looking at the patient's emotion, and these are basically expressions of grief, will give you an idea of what the patient has, the patient in discomfort, or the expressions on the patient may give you an idea. So the art of medicine involves understanding each presenting problem, its evolution over time, relevant antecedents, medications, allergies, family, occupational, social history. And what actually the art is basically shifting, probing, weighing each response given by the patient, judging when to drill down and ask in more detail about the history and when to pass over to the next issue. This is an art which all of us have to really learn, and this is more important than the science of medicine. Medicine may have changed over the ages, but for human beings, the need and expectation from a doctor have largely remained the same. Someone they can trust, someone they can reach out to. And the goal of medicine has always been to relieve human suffering. And even the word patient comes from the Latin word patientum, which means suffering. And relief of suffering and empathy of a fellow man is what medicine is all about. Even if you look at the WHO's definition of health, it says it's a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So I think it's important that we really understand that our aim as physicians is not just to get away with or the disease of the patient, but it has to be a complete physical, mental, and social well-being that we're looking for. Even if you look back at the book written, which is attributed to Hippocrates, The Science of Medicine, it sets out the goal of medicine in comparable terms, the complete removal of the distress of the sick. The science of medicine suggests that students look at the subtleties of each patient, the quality of the voice, whether it is clear or hoarse, the respiratory rate, whether it is quickened or slowed, as well as the constitutions of various fluids of the body. This is an art in itself. Effective physicians integrate their patient's choice of word as well as their body language. They observe what the patient leave out of their stories as well as what they put in. And that is also something very important. Sometimes the patient may not tell you something because of the fact that he may be shy or not wanting to really come out with all of that. That is something that you have to pick up, and that is the art of medicine. So the art of medicine is a skill that can be learned only at bedsides and not in books. These skills can be communicated only by examples, not by precept. You cannot learn these skills out of books or in lecture halls. And I think this is something that we need to really focus on, because currently a lot of focus has become on looking at things like YouTube or looking at the social media and being able to learn medicine. So the art of medicine is like being a detective, Sherlock Holmes. Sometimes you see, but you do not observe, and you have to learn how to observe what we see. And to a great mind, nothing is little. So sometimes it's very, very important for us to understand that even something very small may actually be the clue to the diagnosis, and that is the art of medicine. So the art of medicine involves empathy for patients, an art which is more than just a science. How do we communicate and show that you are concerned about the patient's well-being? Getting the patient's confidence and trust. This is an art rather than a science. We give medicines, but rarely discuss lifestyle modification, diet, nutrition, exercise specific for the patient, and assume one size fits all. This is an art rather than a science. And I would just add one more thing, that learning the art of medicine, if you do that, the patient will be there for you for life. And I would just again like to quote what William Osler said, the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Often the best part of your work will have nothing to do with the potions in the powder. So the best part of medicine has nothing to do with the drugs that you give or the injections that you give. It has something to do with this art of medicine and how you communicate with your patients. More than 2000 years ago, Hippocrates said there remains as much an art in medicine as there is a science, and I think this is still important right now. William Osler said, if there's not the great variability among individuals, medicine might as well be a science and not an art. So each individual is different and each individual expresses himself in a different way. Each disease behaves in a different way. And that is something that we need to understand. More recently, Martin Tobin said the same thing. Martin Tobin is a person who's well known in the field of pulmonary and critical care medicine. And this is an editorial he wrote in 2014 in the American Journal of Respiratory and Clinical Medicine, Generalizability and Singularity, the crossroad between science and clinical practices. Focusing on a single person versus grazing upon a large number of persons produces a radical change in perspective. Most trials look at a large group of people. RCTs look at a large group of people and give out your results. But you're looking at an individual, and that can be sometimes very different. Two human beings are never precisely alike, even twins originating from the same ovum. And as we saw, that as far as diseases are concerned, similar disease states are never identical, even when it's caused by the same agent. Classical example is COVID. You had asymptomatic COVID, you had mild COVID, and you had severe COVID, which led to even extrapulmonary manifestation. And a patient considers his complaints as one of the great peculiarity and craves for personal attention. And this is something that we need to understand. And therefore, physicians need to alternate between scientific principles and individualized care. Scientific principles gained by research are collective, whereas the clinician's grace is concentrated on a solitary patient. And I think this is what we need to really understand. When we look at data, it's more based on collective data of a large number of individuals. But when you're looking at a patient, it's just that one patient that you need to look at. And this involves the art of medicine. Therefore, I would just like to conclude by saying that the science of medicine has made remarkable progress over the last 60 years. I think we have seen changes which we never thought that were possible. When I was a resident, we had just a chest X-ray or an X-ray, and we would have various views of the chest X-ray. We started seeing ultrasound, CT scan, PET, MRI. All that has happened in just one generation that we've seen. And we've seen that dramatic change happening as far as treatment was concerned. But as the practice of medicine changes, the relevance of the art of medicine has become more and more important. And this is an art which cannot be learned in textbook or lecture halls. And therefore, I think for us, it's very important that from a patient's perspective, they need a doctor who understands their complaints and empathizes with them. This is the art of medicine that we really need to really focus upon. And as has been said, a good physician treats the disease. A great physician treats the patient with the disease. And I think that is what makes it the art of medicine. Thank you very much.
I think very well said. And I feel as long as there's a physician treating a patient, not a computer, the practice of medicine will always remain the art. And you very well said, during COVID, the fright, the fear, even when those people who were not infected or who had mild COVID, there was so much of anxiety, and they would come and meet you, and that is where you could help them. So as long as there's a human being, a doctor helping the patient using the science, the practice of medicine will always remain an art, I feel. I agree with you, Dr. Guleria.
Excellent, sir, as usual. And very well said. We as a doctor and in the generations to come, we have to adopt the science and the developments given by the science, but a touch of a doctor and the personalization cannot be replaced by online consultation or the developing technologies. Thank you, sir.
Thank you, Dr. Guleria, for an excellent presentation. Medicine, we always say that medicine is a science of uncertainty and art of probability. See, when we treat a patient, we should have a holistic approach towards the patient. Your core competency, your professional knowledge will always remain. But how you receive a patient, how you greet a patient, how you behave with the patient, your behavioral skills, communication skills, as Dr. Guleria rightly mentioned, that listening skills are very important. Listening skill is the most important part of the communication skills. And secondly, the doctor should be aware about respecting and protecting patients' rights. And your observation skills, very important, empathy. And we have to, while treating the patient, we have to also safeguard our interest, to prevent complaints from the patients or the litigation by the patients. And technology, of course, has a greater role to play today. And, digital health is the buzzword today, but still the personal touch, I would say, actually it is losing now. So unless you speak to the patient, you touch the patient, you talk to the patient, you listen to the patient, I think the essence is lost. So I think that's very relevantly pointed out by Dr. Guleria. Thank you so much, sir. Thank you. So these are my comments.
Thank you, Professor Guleria, for excellent talk. But I would say there are three things important for if any physician or any practicing doctor. That is competence that that we get through the medical books, the journals, and the Google these days. Second is the communication, as rightly said, listening and discussing with the patient. And third is compassion, that is empathy, which is not available in any textbook. It is an art. With these words, I request Professor Parekh to give his concluding remark. He is from Kota. He has been past president of National Association of Physicians of India. Dr. Parekh.
Thank you, Dr. Pritam Gupta, and congratulations and compliment Dr. Guleria for an excellent lecture. And I also congratulate Dr. Chabra for keeping and the organizing committee for keeping this lecture, because this is you all are very senior persons and you know much about art of medicine and how a good practicing person should be. But for the younger generation who are forgetting the art of medicine, we know that for last so many centuries, this art of medicine is being practiced. So, but as the science is advancing, we are losing, as Dr. Guleria said, we are losing the human touch with the patient. So this has become more important, and as Dr. Guleria said, it is not you can't read in books. There is nothing in the literature about art of medicine, but you learn by seeing your seniors, how they are doing, how they are behaving the patient. So human touch is most important thing, I think. And I say the art of medicine and science, they run together. So science is also very important innovation, but art of medicine is more important. Patient satisfied with your how you communicate with the patient. Communication skills are very important for a doctor. So not even in your family, among your friends, your doctors, communication skills always pays you. And for the doctors, it takes you out from difficult situations, legal suits, and so many things. So you must communicate with your patients, with their relatives, so that they feel satisfied and they say, then doctors are bahut acha kaam kar rahe hain. So I think the basic need should be a good human being. A good human being is a good physician. And the listening, as Dr. Guleria said, is the most important part of your practice and your consultation. Because if you don't listen and you just tell your judgment, then patient doesn't feel satisfaction, and then it creates a lot of problems. So listening, as he said, is very important. Communication skills. The feedback is also very important for a doctor. Feedback tells you that you are doing a good job, and if there is negative feedback, you have chance to improve. So never fear with the feedback. मरीज क्या कह रहा है मेरे बारे में, गलत बता रहा है. Try to understand and try to make it things make in a proper way. I think it is more important for the younger generation. What I feel that they are losing, they do not know ABCD of art of medicine. They are more focused on science and more focused on the new things and innovations. So I think for the younger generation, it is very important. And who will tell them? When they are working under you, they can just copy, they can understand what they see in their mind, that how he is doing. Just a touch to a patient gives him a lot of satisfaction. We can understand that touch is the most important thing. I think there is a lot of things to talk about art of medicine, but I think Dr. Guleria has said very important things that we should keep in our mind.
And thank you, Dr. Guleria, for an excellent lecture. Thank you. Thank you very much, sir. Please give big hand.
Thank you. Thank you, Dr. Guleria, for such excellent deliberation and all the chairpersons. I request all the chairpersons and panelists to honor Dr. Guleria. And I request Dr. Aram Chabra to honor the chairpersons. Now we'll have inauguration ceremony. Before that, there was some announcement is there. After the inauguration, there will be prize distribution for the quiz competition. And there's another session. After 2 sessions, we have got another Kaun Banega Cardiology star. There also there's a prize money for the 3 prizes are there. 5,100 for the first prize, 3,100 for second prize, and 2,100 for the third prize. So you all be please ready for the prizes and Kaun Banega Cardiology. And for the poster presentation, we have a prize that will be at the end of the session. There will be 3 prizes for poster presentation. First, that is also 5,100. Second prize is 3,100. And the third prize is 2,100. So we'll have an inauguration ceremony. For an inauguration ceremony, we all know we invite Dr. Rakesh Sood, is the president of Nord Delhi Fish Emporium, to please take the chair. And Dr. Aram Chavda, he is the founder president and the main brain behind this Nord Delhi Fish Forum. Dr. Aram Chavda, please. Dr. Ramdeep Guleria, sir. Please again come to the stage, sir. Dr. Ramdeep Guleria, sir. Please come on the stage, sir, for the inauguration ceremony. Come this side. Dr. K.K. Parikh, sir. Dr. Parikh, sir, please come, sir. Dr. Pritam Gupta. We all know all of them. Then our Vice President, Dr. A.K. Malhotra. Dr. P.K. Goyal, our Finance Secretary of Nord Delhi Fish Forum. There are few stalwarts for this inaugural function. Dr. Y.P. Munjal, due to his health conditions, he could not make it. Dr. A.K. Agarwal, he had family bereavement. His mother-in-law died yesterday. Dr. Nutan Mundeja, DHS, Delhi government. We are trying to contact her. There are some technical issues. And I think online we have Dr. Shyam Sundar. Dr. Shyam Sundar, dekhna. Online. He's come. Dr. Shyam Sundar, he is presently president of API National. He is joining from the Varanasi. So I request Dr. Rakesh Sood, please give the opening remarks. Dr. Rakesh Sood, president of Nord Delhi Fish Forum, and we all know him. He is the senior consultant at Fortis Hospital, Shalimar Bagh. Dr. Rakesh Sood, please.
Good afternoon, everybody. It's our privilege to have this midterm session after we had 5 successful annual CMEs, which were very well attended, and we had Glexio people delivering their lectures. And on lot of demand from the people who attended our previous conferences, so we were forced to have this midterm conference. And in this conference, we added a new chapter for our residents, so that we can have more of their interaction, and they are the basically budding up the doctors who have to take care of us, the old age physicians in the coming years. So we have to really train them. Nowadays, more of them, they are busy in the exams, so they have less of clinical time. So we thought we'll have a quiz for them. We'll have few sessions which will be of interesting for them. And this time we had privilege of having Dr. Parekh, Dr. Guleria with us, and we missed few people because of the link problem, like Dr. Joshi, and then we were thinking having Dr. Amrish Mittal also. And we hope that all the residents who are attending this conference or the delegates, they will benefit from. Thank you.
Because of the paucity of time, we are running late. So I request Dr. Shyam Sundar, API Nurses President, to give few words. Dr. Shyam Sundar, sir. Can you hear me, sir? Online लो यार, आवाज नहीं आ रही है. Can you hear me, sir? Hello. वॉइस नहीं आ रही, देखो यार, बोलो, फोन करो. So please unmute yourself, sir. It's a mute. Hello, sir. Can you hear me, sir? इधर से अनम्यूट नहीं करना है. Sir, please unmute yourself. आप करो नहीं यार, आपके एंड से नहीं हो रहा है.
बोलिए. Chabra, Dr. Rakesh Sood, Dr. Jha, Dr. Goel, and other dignitaries on the dais, Dr. Pritam Gupta, Dr. Guleria, Dr. K.K. Parikh. It is a great pleasure to be part of this meetup conference organized by New Delhi Physicians Forum. And I think I must congratulate the people at the helm of affairs of New Delhi Physicians Forum. And particularly, I want to congratulate Dr. Chavda for his unwavering enthusiasm and really the man behind the movement of Physicians Forum in Delhi. So I congratulate him. I see that the topics are very relevant, and you started with insulin, which is so very relevant to everybody practicing medicine. So with these few words, I wish the program a great success. Thank you very much.
Thank you, sir. Thank you for the wise words. Now I request all the dignitaries, please come for the lamp lighting, please. Dr. J.K. Sharma, Dr. Chug, Dr. Ram Babu, all please come. Dr. Sureka, Dr. Hemant Diwan, Dr. Diwan, Dr. Kamal Karnani, you please come. I Dr. Rajiv Gupta from Gurgaon. Please come, sir. Please come for this. Nice, wonderful. Dr. S.K. Rora, Dr. Stogi, Dr. Neil Jain, all please come for the lamp lighting. Okay, thank you. Special guest, please come on the dais, please. अब क्या? Thank you, all the guests. Please come on the dais. Dr. Guleria, sir, Dr. Parikh, sir. Solve. Now I request Dr. Preetam Gupta to honor our chief guest, Dr. Randeep Guleria. Stalwarts of medicine. Okay, first of all, Dr. Parikh. And I request Dr. R.M. Char, our founder president, to honor Dr. Randeep Guleria, please. तो आपके लिए रिजर्व आपके लिए वो स्टारवर्ड आपके लिए रिजर्व है. Thank you, sir. Thank you. Thank you. So the announcement for the prizes, Dr. Ram Babu, please. Right, sir. Thank you, sir.
आप प्राइज दे दो, यहीं से बुला लो, यहीं बुला लो, टीम वाले को दे दो, प्राइज भी दे दो.
Prizes. Announce कर दो.
Good morning, everybody. So this is the prize for morning quiz of ECG and medical questions. So first prize goes to team third. First prize go to team third. Congratulations. Please come on desk.
अभी सर्टिफिकेट और पैसे.
अभी नाम. Come please.
जब तक साइकिल भी डिक्लेयर कर दे, कोई जा रहे हैं.
Congratulations.
आप दोनों सर दोनों.
The first prize of 6100 to be shared by the three doctors, and the name is Dr. Dev Chaudhary, from Dr. Sachin from Hindura Hospital, and your Dr. Jasmita. She is sitting at home at the moment. Second prize. Second prize, bolo. इसके बाद में है ना.
And winner of the second prize, for second prize, team fourth.
Team 4, please come.
Please come on stage, team 4.
And the prize is of 3100 to be shared by 2. What's a good name? Ishan Aneja from Gangana Hospital. Yours? Narula from Sabhang, Narula from Gangana team. Third prize.
And third prize will go to team 1. Please come,
This
team
prize
1.
of 2100 to be shared by
Where is team 1 candidates?
I think team
Gone.
one is also. Anybody, Dr. Dev, you can collect on behalf of the team 3 if you know them. If you know them, because there's a cash prize.
Sir, बाकी team ले रहे थे.
Now Dr. Rakesh Sood will be felicitated, honored by Dr. A.K. Malhotra. Dr. Rakesh Sood is the presently of NDPF.
Did a lot of work.
So thank you, all the dignitaries. We are going to have next scientific session. Next session is symbiosis among robotic surgeons, laparoscopic surgeons, gynecologists, and physicians. And the moderator is Dr. Surinder Dabas. Hi, sir, please, sir. Moderator Dr. Surinder Dabas. He is a robotic surgeon for head and neck surgery at Max Hospital, Shalimar Bagh, and also BLK Max Hospital. And the discussants are Dr. Kiran Gureria. Madam Kiran Gureria, she is a gynecologist and is a professor in GTB, UCMS, GTB and UCMS. The chairperson is Dr. P.K. Bhardwaj. I think he could not make it, Dr. P.K. Bhardwaj. Then Dr. Yoginder Gupta. Is he present, Dr. Yoginder Gupta? Then बुला लेते हैं. Dr. Sanjay Dhar is also out of station. And Dr. Rajiva Gupta, he is a senior consultant medicine. Dr. Rajiva Gupta, please. He is a senior consultant. Earlier he was in Ashok Vihar and North Delhi. Now he shifted to Gurgaon. Dr. Anil Gombat, please. And Dr. Akash Jain. Akash Jain, please. He is the associate with Saroj Hospital. He is a senior consultant and he is the colleague of Dr. P.K. Bhardwaj. He is representing Dr. P.K. Bhardwaj. So I request the chairpersons to introduce the speaker and the topic. And online is O.P. Yadav. He has come, Dr. O.P. Yadav. He is a very well-known figure. He is a cardiac surgeon and senior of National Heart Institute. So welcome, Dr. O.P. Yadav, sir.
Thank you.
Dr. G.S. Bounder is Dr. G.S. Bounder. I think will be joining online subsequently. So I request the chairpersons to introduce the speaker and the topic. Thank you.
Thank you so much and good morning, everyone. I would like to say thank you to Dr. Chabra and Dr. Sood for inviting a young surgeon among the stalwarts of medicine here. And so topic today is symbiosis between robotic surgeon, laparoscopic surgeon, gynecologists and physicians. So nowadays we are talking a lot about robotic surgery and it is a new, I will not say a new technology. This technology came in 2003 in India in AIIMS, Delhi. But the invention of robotic surgery started way back in 1999 in US. And then maybe after 3-4 years, India started doing robotic surgery in AIIMS, Delhi. And in last 20 years, till today, we have only 100 robots across the country and maximum in Delhi. So in past, we were talking about Mumbai was the medicine hub, but now we talk about robotic surgery, then Delhi is the hub of robotic surgery and people in Delhi are training rest of the country. So now what is robotic surgery, how we do robotic surgery and why we need robotic surgery, this we will explain in this 20-25 minutes. So any query from the audience and I will try to answer that, what is robotic surgery. So when a patient comes to us, if this patient of cancer is an operable cancer, we always give 3 options to the patient. One is open surgery, then laparoscopic surgery, and nowadays we say robotic assisted surgery. So traditional open surgery, we are all aware that we need a big incision for surgeries and the recovery is delayed And maybe in cancer, we require further treatment like chemotherapy and radiation therapy that may be delayed because of wound infection or wound healing is not good. Then maybe around 40 years back, we came to laparoscopic surgery and we termed it as minimal invasive surgery in terms of less morbidity, rapid recovery, less blood loss. And it started with laparoscopic gallbladder surgery, then hernia surgery, then a lot of even advanced surgery, even oncosurgery weren't done laparoscopically. But now you see the picture how a laparoscopic surgeon does surgery using only two hands and having one or two assistants holding the camera and rest of the assistant ports. But now when you come to the new era, robotic assisted surgery, so this surgery is a master slave technology where robot is not doing surgery himself. It is totally controlled by the surgeon and in a way that you cannot do any mistake. So people ask us, can robot do mistake? Yes, it can do mistake if the surgeon does mistake. Robot cannot do anything by its own. It is totally surgeon control innovation. So there are three parts of robotic assisted surgery. One is a surgeon console. So like open surgery and laparoscopic surgery, we are standing at the patient and doing the surgery. Either we do open surgery or laparoscopic surgery. In robotic surgery, we are sitting away from the patient on a console and a single surgeon is controlling all forearms of robotic system. Like in traditional surgery, open and laparoscopy, we can use only two hands. But in robotic surgery, we can control four arms. Even the camera and all rest three arms helping you in the surgery. Assistant can use one or more ports so that it becomes 6-hand surgery. Any surgery, it is benign or malignant, does not matter. So the first component of robotic assisted surgery is the surgeon console, where the surgeon sits and control all robotic arms. And with the help of chopsticks, I will show you what are the chopsticks. We control all robotic arms which are on the patient. Second component is the vision card, which displays the three-dimensional view of inside and used by the assistant to see where to assist. The last part is the patient card, the most important part, having all four arms, Da Vinci XI system. These all arms are inside the abdomen of the patient where we are doing abdomen or thorax, where we are doing the surgery. And all these four arms are totally controlled by the surgeon. So this is innovation of robotic technology. This is a contact innovation where you have to put your forehead into the contact and you see three-dimensional view and then you can perform surgery. If you take out your head from the camera, robotic arm will not move. And three-dimensional view, 10 times magnified view helps in performing complex surgery, maybe deeper surgery like pelvic surgery and thoracic surgeries. And the last picture shows how we are opening the instruments and closing the instrument, sitting away from the patients. We are not standing at the patient. So this is a video. Just to show how we perform robotic surgery, because a lot of patients ask us, even the doctors ask us how the robot performs surgery. So this is a typical port placement, the way we do in laparoscopic surgery. Then the patient cart having 4 robotic arms comes on the patient side and we attach the robotic arms to the ports, and this we say docking of the robot. And once the robot is docked, then we say targeting. We have to target the organ where we are doing surgery. So we have inbuilt system in this. We have to target the upper abdomen. We have to target the lower abdomen. We have to target the thorax. We have to target the head and neck. So targeting is done so that we can focus on the area where we're doing the surgery. So once the docking is done, targeting is done, then the surgeon sit on the console and start doing the surgery the way we do laparoscopic surgery. But again, 4-arm surgery, surgeon controlling everything in the camera and all ports. Unlike in laparoscopic surgery, where surgeon is just using 2 hands performing the surgery and camera is with the assistant. And you're always saying the assistant, please yahan dikhao, please wahan dikhao. But in robotic surgery, it is with you. So you have to see where you want to do the surgery. So now you sit on the console and start performing the surgery with the help of, you are taking help of your hands and feet both. So your cautery system, your instrument motions, everything is under surgeon control. So if now a surgeon does mistake, robot will do mistake. But if surgeon is not doing any mistake, the robot will not do mistake. So now one more advantage of this technology is no tremors. Like in laparoscopic surgery, open surgery, sometimes long surgeries are there, maybe 8 hours surgery, 10 hours surgery. You become fatigued and tired and you start tremoring. But in this, there are no tremors. The tremors are filtered in this technology. So tremoring at your hand will not be transmitted to the patient. So this is how you move the instruments at patient cart. And assistant is only using a single port, helping us to just deliver the cotton gauzes and sometimes some clips and all. So now this technology has everything. You have staplers, you have clip applicators, you have vessel sealer, harmonics. Everything is inbuilt in this technology. Every 5 years, a new robotic system comes and having advantages of some new technology like vessel sealer, harmonic, and we are coming with more instruments, more flexible cameras and instruments. So this is the latest system available in India right now, which is DaVinci Xi4 forearm system. But in US and Korea, we have a single port system also with flexible camera and flexible arms, like we say snake robot. And it has all flexible things. Till today, not in laparoscopic surgery, there were no flexible camera. The camera is just looking at straight. But in single port system, the camera is just moving like a snake. So you can go deeper into the planes. So now what is the advantage of this technology? Why we want to do robotic surgery for patients? This is one thing, very controlled surgery, because total control is with surgeon. Precise surgery because it's a three-dimensional surgery, and the robotic instrument has endorest instrumentation. We say that it can rotate into 7 degrees of motion, not like our hands. We have some limited motion in our hand, but in robotic camera instruments, we can rotate in 7 degrees of freedom, or we say 540 degree. Accurate. Why accuracy? Because you have instruments which can bipolarize the small vessels, cauterize the small vessels, three-dimensional view. You can have the depth perception. So the tissue dissection is better. It becomes more accurate surgery. And again, there are few new technology. We say firefly technology, where we inject some dye and we can see the course of vessels. We can see the course of bile duct. We can see the course of ureter, so that you are not doing injury to the adjacent structures and you give better outcomes to your patients. And one more technology benefits in this. You can see in the picture, there are two surgeons sitting on the console. We say dual console. So I will say that a future generation of ours is not going to be so physically active as we used to be in our days. They will not do surgery for 5-8 hours standing on the patient. Now they are just playing video games and everything. So, and this technology where you can teach your fellows or junior ones is the best benefit of this technology. We say dual console adaptability in this technology. You ask the surgeon to sit on the console besides you, start doing surgery, and you can give the control to the surgeon whom you want to train. If something wrong happens, he is doing something wrong, you can take the control immediately and start performing your own surgery. Assistant will control on that. So like in laparoscopic surgery, the learning curve was very steep, but in robotic surgery, the learning curve is smooth. So now, today we always talk about training and training. We have to train our young generation. This is the best technique where we can train our generation without harming our patients. So these are few new innovations into robot, firefly technology, vessel sealers, staplers. We have new and new instruments every 1 or 2 years, so that we are giving best benefits of this technology to our patients. In previous time, when you are doing surgery, we were ligating with sutures, then harmonic came, then staplers came, and surgery became easy. It is not the surgeon became great, but the technology came and they made surgeons better. Blood less filled, faster surgery, faster recovery. This is all because of technology, not because we are great surgeons. So this is a picture, I'm just showing picture about the people doing surgery by robot in US. So general surgery was one which started the last, but now doing maximum number of surgery by robot in US. Even they are doing gallbladder surgery, hernia surgery with robot. But it is reverse in India. Even general surgeons are not doing surgery with robot. So why? Because in US, it is all covered under insurance. In India, it is not covered under insurance. So people are not preferring that because of the cost. Now, India urology is the one which is having the highest number. Then I can say GI and thoracic and gynae and head and neck. But general surgery the last. And this is the frequent question asked by our patients. Sir, robot galti to nahi karega. So at each and every point, this system is controlled by the technology, checking around 1300 checks per second to detect any potential fault in this technology. Each part is being checked by the system. And it is inbuilt, there will be no inbuilt error in this technology until unless your surgeon does mistake and harm any structure. So it is following the surgeon's movement, not doing anything by its own. So you can use this technology from head neck till the pelvic area, except I say brain and bone. We are performing every surgery with robot, but again, robot does not make cancer curable or operable. It is an operable cancer where you need surgery, then you can use robot. You cannot treat cancers until they are not curable or they are operable. You cannot use this technology. So people comes up with very advanced stage 4, sir, can you do robotic surgery and cure us? No, we cannot cure you because your cancer is not curable. So this is a technology where surgery should be advisable, then we can use robot. So we can use in urology, we can use in gynae, colorectal, hepatic surgery, head neck and thoracic. And it is a surgeon who will take decision, this patient will be best benefited by this technology. Not all patients will require this technology. So now we talk about few things about gynae. This is not gynae onco, this is general gynae. And pelvic area is basically a difficult area to treat because we have a lot of structures, vascularity to treat. We have ureters, which is a nightmare for many surgeons. So you should not do mistakes. And there are a lot of problems in that area, like in gynae, endometriosis is one thing which is very difficult to treat and you have multiple deposits. So now in this technology, we have some firefly technology. We can find out the endometriotic deposits elsewhere and you can treat them. So you need good clearance in endometriosis. It's not a cancer case, but again, needs a good clearance. Sometimes you find very dense adhesions and you can't see the course of ureter. With this technology, you can just see the course of ureter and just safeguard the ureters, because if there is ureteric injury, life becomes in hell. So in benign gynae, endometriosis, and I will say the big fibroids, mainly in young patients, need this technology. Why? Because we want to preserve the fertility also. And when you do laparoscopic surgery, we are having only 2 hands and doing this surgery by blind method. But when you have robot, you have 3 instruments which are helping you, and you can just give retraction and take out the fibroids. I will just show you the picture. And you can take out the tumor completely, and then suturing is so easy with this system. So having more arms is more helpful to the surgeons and doing a good surgery, which is bloodless surgery. Fibroid or myomectomy, we say, is one of the most, I will say, complicated surgery where a lot of bleeding can happen. This is a vascular tumor. But once you have good control of vessels, with the help of 3rd instrument, you can have a avascular surgery for young patients and preserve their fertility, because you have to see the endometrial cavity also, and you need to preserve the fertility, you have to save the cavity. So by 3-dimensional view and 10 times magnified view, you can save the structures. So this is how we use robot into oncology or in general surgery or in gynae. So advantages of laparoscopic is there with the added cost. So now cost part, 5 years before, no insurance company, no government panel were covering robot into this curriculum. But nowadays, even CGHS, who are the retired patients, are getting approval for robotic prostatectomy free of cost to any private institute also. So CGHS approved them by them. So nowadays, each and every process is getting approval from the government also to get free of cost. Insurance companies started covering robotic surgery into their insurance schemes. Few things are left, but cost part will be taken care in maybe next 5 years. And what in our group, I work in Max Group, and say we are charging 1.35 lakh extra over the conventional charges, which is the charge of the instrument. Basically, we can say that. So I will not say it's a costly affair, but
for future generation to be more precise, accurate, and controlled, we have to focus on the technology which can give best benefit to our patients. And I say the training part is what we say is the best part of this technology, where we can train our surgeons without asking them to be standing for long hours, because nowadays we can see even our residents or our trainees, they work from 9 to 5. They say, sir, we are over. They are not working like 36 hours or 48 hours. In our times, we were not asking for post-duty off. They're asking for post-duty offs. So this is the way we can train them better so that we are not harming our patients. So I always say for next generation, yes, this is the technology, but yes, we need to invest into this technology and learn this technology. So I'm open to any of my panelists and any of my faculty, any query about this technology, where to use, where not to use. Thank you so much.
Yeah, so very good presentation. So I have a few questions. One is the incremental advantage of the robotic surgery in terms of cost. Incremental advantage means a particular procedure has to be done conventional method versus by robotics. What we understand from our patients only, because this is a very new thing. And one patient came to me, her husband had to get a laparoscopic colorectal cancer surgery, and he was suggested to undergo robotic surgery. Then they sort of checked around, and the impression which was given was that the incremental advantage of robotic surgery over that would not be significant. Vis-a-vis the cost escalates almost tremendously. That is one. Second is the outcome data over the time, because nowadays we practice evidence-based medicine. Okay, there is a procedure A, there is a procedure B. So at the end of, say, 5 years, 10 years, what is the outcome of those versus this in terms of morbidity or whatever complications? Then third is the training of the personnel, because I don't think it is part of the curriculum as yet in the surgical specialties. So as you said, it is a very, it's a short, the learning curve is smooth, but actually is it really that way?
So I will divide your answer in two parts, sir. So the application of robot in head neck, initially we used to treat our patient with chemo plus radiation because it was too morbid, open surgery was too morbid. So people were left doing surgery for like tonsil cancer, base of tongue cancer, and laryngeal cancers. They were just referred to chemo radiation, and there are a lot of side effects. Patients were not able to eat and speak well, and the chance of cure was less. So now when robot has come, it can go inside and take out the tumor with good margins. So your cure rate are improved and your functional outcomes are better. So here robot has given us an edge in clinical benefits, yes, with cost. And when you treat this patient with surgery by robot, you are staying in hospital for 4 or 5 days. But with chemo radiation, you have to come for 50 days in the hospital for treatment. So 5 days versus 50 days treatment is there. Either you treat with surgery or with chemo radiation. That is one benefit of robot into head and neck. Now we go to the rest of the part where laparoscopic versus robotic surgery we discuss. So we discuss the complication of laparoscopic and training in laparoscopy. So complication in laparoscopic surgery, I say when you're doing Whipple surgery, Whipple's is one of the biggest operation for pancreatic cancer. It takes around 6 hours to 8 hours in open surgery, and maybe in laparoscopy the same time. But with robotic surgery, if you're a trained surgeon, it takes around 4 or 5 hours. But the benefit of suturing of pancreas to jejunum is so easy because magnification and endurance instrumentation makes your suturing simpler. And this is the anastomosis which makes your life hell if it leaks. And the morbidity and mortality of this process is 30%. 30% patients die after your surgery because of the complications. So now you have to find a technology which can give you benefit in terms of clearance plus less complication in surgery. Again, when you do any oncology surgery, you have to do a lymph node dissection. You talk about rectum, you talk about stomach, you talk about pancreas. So all these lymph nodes anywhere in the system is very close to your vessels. So the lymph node harvest, in many studies, you have multiple thousand papers. They say the lymph node harvest is better with robot as compared to laparoscopy. Because in laparoscopy, you are doing blunt dissection like this. In robot, you are doing a fine dissection with scissors. You have a scissor, you can see in the video sometimes. You have a scissor, and this scissor has cautery system attached. So you can cut, bipolarize, cut, bipolarize. So this way you can do a fine dissection. So lymph node harvest is better, means your oncology outcomes are better.
Now you talk about pelvic area. Pelvic area means laparoscopic surgery becomes very tough sometimes. You cannot handle the structures. I'm doing surgery with 2 hands. I want to lift the uterus. So what do people? They do take sutures, lift it up, then they start doing. Now in robot, you have 3 instruments. 1 can lift up, 2 can do surgery. So there are a lot of technical advantage, but you will learn this advantage only when you're doing it. So explaining theoretically becomes difficult, but yes, we have an advantage. And now you are the one who's controlling all instruments. Now you know where to hold and just give a traction and then do the surgery. So oncologically, yes, we have benefits. Training part, yes, till now there's no training curriculum for robotic surgery. But I'm just telling you today, we are starting our training program from 15th of Feb. We have a dual console in our hospital, BL Kapoor, and we are starting 1 month and 1 week fellowship. 1 week for the people who are trained surgeons in laparoscopic open, and 1 month for the people who are new MCH candidate who have done their MCH, and they can see how we do and they can train. But not today, maybe in 5 years, that there's so many robotic systems has come up now. 5 companies are making robot, not 1 company. And many people are talking about this surgery. If you don't train them, they can't learn. So training is easy on this. So this system I'm showing is a system which is closed. Now the system are coming with an open vision. You can sit on the chair and see the screen like you see in the TV, and then you can do the surgery. And training becomes easy because your surgeon, your assistant sitting behind you and then see how you're doing it. So like it's like a video game now. So maybe in future, this is an AI-based technology. So AI is coming in everything. So you are driving the car, now they're saying the driverless car. So maybe you are using the robot today, I'm controlling it. Maybe in future, the robot will not ask me to come and do the surgery, he will start doing the surgery. So this is future, you never know what new things will come. But yes, training part will come.
Yeah, thank you so much. I think that was very interesting. And you had a very excellent basic talk about the use of robotic assisted surgery in the various fields of surgery. And I think as far as gynae is concerned, there are definite evidences now in certain areas, especially because pelvis being a very complex area, and certain surgeries are also called as like complex pelvic surgeries. Their robotic system definitely has lot of advantages, which you have already highlighted, like the depth perception and going in 360-degree, which even with our 2 hands, we can't do that. So there are certain areas which you've talked about, like doing a myomectomy.
Yes, ma'am.
Then there is for surgery for endometriosis. And then there are like big uterus, where the expected weight of uterus is more than 700 grams. And also the oncosurgery, especially the C endometrium.
Yes.
That has, there are evidences now to say that robotic assisted surgeries are much, much better in terms of not only safety and reduced intraoperative complications, lead blood loss, but also better post-operative outcome and survival benefits. Yeah. So that is the thing which I think it is coming as a great future, and especially in gynae. Actually, gynae is one branch which has taken up robotics very fast.
Yes, ma'am.
As
That's why I showed the graph
Dr.
of
Basu, you
US.
have-
Yes.
Urology is 1, gynae is 2.
Yes.
In India, it is urology 1.
Yeah.
And
So I
gynae
think
is
what I
still-
like,
still not-
maybe in future they will not need
because
any
we don't have training
gynecologist,
program.
surgeons,
That's why that's the reason.
or urologists to do surgery, I think.
Because
Robotic,
urology got trained since a long time. So there's so many urologists. So everybody in urology, like prostate cancer, they will talk about only robotic surgery.
Yes.
They don't talk about laparoscopic surgery or open surgery.
The post-operative outcomes are very good and survival benefits are there, then obviously people would like to go in for that. The only thing I think currently is the cost, and which if you can handle with doing so many surgeries, and there is symbiosis between the various surgical branches, then probably it will become much more cost effective also.
So ma'am,
And-
it's like laparoscopic surgery was covered after a long time in TPAs. The same, then now the TPAs are covering robotic surgery, but they say that your TPA should be maybe around 10 lakhs. If your insurance is 3 lakhs, they will not cover that. So you have a good insurance, they will cover.
And another thing which I find in amongst gynecologists is those who are trained in open surgery, they know how to do a good open surgery. They take up robotics within 3.5 days training.
That's why I'm saying laparoscopic
Going
Rather
from
than,
open to robot is easy.
yes.
Going from laparoscopy to robot is difficult because their arms movements are tuned like tearing like
So that
this.
is, I think, one of the thing which is encouraging a lot of them to take up robotics much more easier as compared to, transiting to the conventional laparoscopy. So I think that was very good, and thank you so much. And I only have one thing to ask you. I think there are some studies on the what is the effect of doing robotics on the surgeon, their ergonomics, and versus the conventional laparoscopy. Are there any problems which surgeons will face specifically when they are doing robotics versus they are doing conventional laparoscopy?
So maybe in last 15 years of my, because I'm doing surgery since 2010, robotic surgery. So if you have a long arch surgery, your back start aching because this robot is like this. But now you have within robot coming with an open console where you can just relax and sit like you're sitting on, you're just lying on a swimming pool, you can do the surgery.
What
So
about
maybe
eye strain?
ergonomics are going to improve in future. Till now, you are not able to find the best ergonomics where you can sit and relax and do the surgery. But in future, it will come.
But what about eye strain?
No, there's no eye strain. Because you can see, you are doing surgery for 1 hour, you can sit, you can have coffee, then you again sit. It's not like that you are harming the patients. You can relax in between also.
And how does
And
it
you don't
feel
need to
be
watch for
away
it.
from the patient?
Yes, ma'am.
How does it feel to be away from the patient?
How you feel? Okay.
I
So,
mean,
ma'am, when you are doing
is there anything
3-dimensional,
at the back of your mind, ki my patient is getting operated there and I'm outside there?
so when you're doing 3-dimensional surgery, you always look you're doing the surgery inside only. The 3D surgery. So like you're watching a 3D movie, it comes on your head. So the same way you feel, same feeling that you are doing the surgery and you are inside.
Yeah, because of the
Okay,
paucity
thank you,
of
sir.
time, we can stop it here. We can stop it here because paucity of time and other speakers are on the dais. How precisely normally takes a surgeon to go into a precision surgery?
Dr. Yadav is with us. He's a cardiothoracic surgeon. And sir, regarding this system or this robotic surgery, I want your views on this new technology into surgery.
Well, thanks a lot. Morning, ladies and gentlemen.
For the
That
concluding
truly
remarks.
was a great and wonderful, eloquent exposition of both the art and science of robotics. And, we all know 3D imaging, the endo-wrist, as Surinder mentioned about, the haptic feedback that we are now beginning to develop. All these things are extremely important, and the surgery is becoming more dexterous, and we're able to reach areas which we couldn't reach earlier. And in fact, even though it was not included in your list, there are cardiac applications also. Now, whenever the heart can be immobilized, for example, open heart surgeries, when you go on the heart-lung machine and the heart goes into asystole, then these procedures can be done with absolute immaculate precision. So, left to right shunts, AST and VST closures, valve replacements, they have been doing wonderfully well. Today, even coronary artery bypass surgery can be done using temperature-controlled nitinol clips. There is some problem with beating heart surgery because obviously it stands to intuition when the heart is moving, that precision is a little problem. So there are cardiac applications also. But ladies and gentlemen, let me play a devil's advocate. See, there are two terms which are very important when any new technology is introduced, and we must differentiate between the two. One is called efficacy and second is called effectiveness. Now, efficacy is in randomized controlled trials with the mavericks, the kind of Surinder Dabas is doing a procedure. And effectiveness is when a bourgeois class surgeon starts doing a procedure. And as far as I'm concerned, I still feel efficacy of robotics have been demonstrated, effectiveness and hard endpoints are yet to be demonstrated, or what little has been demonstrated is still tenuous. So that's important. And the question I have for Surinder for you is, you mentioned that repeatedly that nothing can go wrong with robotics. Now that somehow I have some reservations. After all, there are mechanical parts involved, there is software involved, and things can go wrong. And what about your comments about the latency? Suppose there is a complication. just that latency between your order and the computer carrying out your orders can lead to increased problem for the patient. Otherwise, a wonderful, wonderful lecture, and I really enjoyed and learned a lot. Thank you.
Thank you so much, sir. So, sir, one part is like effectivity will come with training. And I will say that if you compare the training in US and in India, there's hell of gap. They are trained in a robotic lab where they are trained on cadavers. And it's not for us only, it is basically for other countries also. So US and Korea has a very good training program. They train their fellows on cadavers, and then they come to the robotic system. They are doing the live surgery. But what is happening in India is you are certified for 1 day training, and then you say, I'm a robotic surgeon, I will do the robotic surgery. No, it's not. The effectivity will not come like this. So you should have training programs across the country and then ask your people to do live surgery on human beings. So human beings life values a lot to us. In US, it matters. But for us, 1 day training, I'm a robotic surgeon, let me do the surgery. No. So we lack a lot of training in robot, and because this robot was made by US companies, so they have some pre-planned programs, and they were selling the robot in India. So there were no training program in India. So till today we are fighting for it. We should have a training program in India if you are selling your robot. One.
Thank you,
Second, sir,
Dr.
the
Yadav.
robot
Dr.
can do
O.P. Yadav,
mistake. Yes.
very well depicted about the cardiology. He is one of the legend in the cardiology, and I would like to have one very quick query. How much time normally a precision cardiologist to become a precision
Effective
surgeon?
cardiologist.
Sorry, is that...
How precise normally it takes time for you to grasp this robotics?
See, it again depends on the generation. If you ask me at the age just going to touch 70 soon, am I going to get the hand-eye coordination? The answer is clearly no. But if it is for the younger generation who are used to hand-eye coordination through their computer games and video games, then I do agree with Surinder that it's not all that unsurmountable a problem. Even we were given a demonstration of practicing robotics on a slave console, and I tell you, you just doing whatever you do on the operating table, the same movements you are doing on the console, and they are being translated into the patient. So it is not that you are doing a new technology. The way you hold a forceps and way you hold the knife, and everything is done in the same way as you do on the operating table. So I think it's not too difficult a technology to master or fathom.
Thank you so much, sir.
Thank you, Dr. Abbas, Dr. Yadav, and one of the legends in the field of cardiology has given us the insights of robotics, and we conclude the session here.
Thank you, Dr. Gumba. And I thank the speaker as well as the chairperson. Now I request chairperson to honor Dr. Dabas and Dr. A.K. Sureka to honor our chairpersons. Now next session is Kaun Banega Cardiologist Star. So in this quiz, it's a sort of quiz. The star will be given, first star will be given the prize of 5,100, second will be given the prize of 3,100, and third is 2,100. And the panelists for this session are Dr. Rajiv Chawla will be joining online, Dr. Naresh Pamnani. Naresh Pamnani, sir. Dr. Naresh Pamnani is a senior physician and is the director and owner of Bhagwati Hospital, Rohini. Second chairperson, Dr. Sunil Mangla, sir, please come. He is a senior consultant physician working in Fortis Hospital, Shalimar Bagh, plus he has got his own clinic in Shalimar Bagh. Dr. Aditya Sarda. Yes, sir, please. Dr. Aditya Sarda is a senior physician in West Delhi. And Dr. V. Rastogi. Dr. Rastogi, please. Ajo, please, Aji. To be the chairperson and panelist for this pulmonary cardiology. And the moderator is Dr. Naveen Bamri. He is not new to this society. He is a very renowned cardiologist, presently the director and head of cardiology, Max Hospital, Shalimar Bagh. Dr. Naveen Bamri, please. And I request the chairpersons to introduce Dr. Naveen Bamri and to conduct the session, please. You on it? Good morning, everyone. Dr. Chandrasekhar? हम फास्टेस्ट फिंगर खेलेंगे पहले तो फास्टेस्ट फिंगर में दो ठीक है सर
15 सेकंड में कौन आंसर ये
रेडी है
So good morning, everyone. First of all, I would like to request everybody to come inside the hall to make it more energetic, to make this program. So Dr. Chavda, where is Dr. Chavda? Respected senior friends and my dear colleagues, it is gratifying to see all of you here again, and I am deeply honored to welcome you all. So after the last successful event turned the tables, I am again here with a new twist, that is KBC, that is Kaun Banega Cardiology Star. I would like to explain all the rules before we will start this again. So I would like to ask one thing, how many of you are Bollywood fans? Raise the hands, please. Only few one? Oh, okay. So let's check your knowledge of Bollywood heroes and heroines.
और इसको वो करो ऑन करो क्रॉस है क्रॉस है इसको हाँ ऑन करो अब दोबारा से दबाओ और फुल कर दो वॉल्यूम प्ले कर दो दोबारा स्पीकर ऑन करो
15 सेकंड में कौन उठाता है 2 क्वेश्चन करेक्ट
नहीं चलता
आ गया
चलो नहीं आया
हमारे तो सारे गानों में
हम लोग इधर देख लिया
ये उनका हिडन टैलेंट है जो आज कर लगेगा
क्या कर
सामने स्क्रीन पे आना चाहिए
सर को पता नहीं होगा मैंने ये उनका हिडन टैलेंट है जो किसी को नहीं पता
वीडियो में कराएगा First is here. Everybody knows who is the heroine. Noora Fateh. Now the again next question is, what is her waist circumference? Can you judge?
0.
So this is how the questions will go on. So I will ask, first is fastest finger first, in which I'll ask two questions. One is from the cardiology side and another is non-cardiology Bollywood related. There is two questions in one set. You have to ask both the right answers, then you are eligible to come on the hot seat. Okay, so I will ask 4 set of questions to pick 4 audience to come on the hot seat. There will be a 15 seconds for the 2 questions. So I'm going to start with the first question. Are you ready? So the first question is here. Guess the name of the actress. Yes. The twist is now here. Guess her age and height. Everybody knows who is Sapna Chaudhary. 5'6". So panel will decide who is going to answer, who is the right one. 5'5". This is the first answer from Dr. Atul. 5'5". And the next is cardiology question now. What is the clinical diagnosis? So, but 2 questions. Who has given the 2 questions? Answer of 2 questions.
How was that? Pretty good.
Dr. Atul. So yes, Dr. Atul is eligible for the hot seat. The height is 5'4", but he is near to 5'6". He is close. Correct answer. 5'6", yeah. एक इंच का फर्क पड़ गया सर. Now the next set of fastest finger first. Guess the movie and the year of release.
79.
Which movie?
Pani 79.
Qurbani 79. Sir, आप
80.
Qurbani and 80. Anybody? Next question from cardiology side now. What is the clinical diagnosis? This is an echo. Yes. So, Dr. Malhotra, pericardial effusion, and 1981 Qurbani, 82 Qurbani. Anybody? Sir, I have also given the answer.
80 का मैंने बोला था. Cardiology का तो पता.
So panel will decide who is the winner from this round. Nearest is 1981.
1980 is the correct answer.
But the echo answer was given by
Large pericardial effusion.
पेरिकार्डियल इफ्यूजन किसने बताया था? वो तो कार्डियोलॉजिस्ट है, उसको नहीं मानेंगे. दोनों करेक्ट आंसर किसने दिए? किसी का नहीं है? Nobody has given both the correct answer. Now there will be a one question again, that is the tiebreaker question. Ask the tiebreaker question. वो ECG वाला, this is. What is the clinical diagnosis of this ECG? VTAC, then cardioversion, and then right. Yes. So Dr. Dinesh has given the right answer. So he is eligible to come on the hot seat. So this is VTAC, and then patient has AICD. AICD say anti-tachycardia pacing and normal rhythm. So welcome, sir, on the hot seat. Now this is the third question.
आपकी मनपसंद बिस्किट शिवा स्वीगल अरे आज शिवा स्वीगल नहीं ब्लैक डॉग हो तो लाओ वो भी हाजिर है सर ये देखिए फैंटास्टिक बोलो श्योर अमर यार आज क्या हो गया तुम्हें शिवा स्वीगल की जगह ब्लैक डॉग
डायलॉग सुनो
जिस
पहले।
दिन मैं कोई गोरी तितली देख लेता हूँ ना माथुर मेरे खून में सैकड़ों काले कुत्ते एक साथ भौंकने लगते हैं उस दिन मैं ब्लैक डॉग पीता हूँ क्या बात है यही आपकी मनपसंद बिस्किट
So the answer, Bollywood answer is, and the movie,
शहनशाह
किसने बताया? सर ने. Now the next cardiac question.
यही आपकी मनपसंद
What is the clinical diagnosis? What is this sign called? Yes. Who's the one dancing carotid? किसने बताया? Sir. Yes. Dancing carotid. This is Corrigan sign, dancing carotid seen in aortic regurgitation. Right. Sir, आपने बॉलीवुड वाला भी आंसर ठीक दिया था? नहीं. कम सर, आप आ जाइए. सर, नहीं, we are happy there. Anybody else? Or I will ask another question. Ask another question. Next. Tiebreaker question. Can you guess the name? And actors? Actors.
Leonardo DiCaprio and Kate Winslet.
Yes, you are right, sir. Come. Finally, he did it. Good.
बहुत बढ़िया सारा पिक्चर का आंसर
सही दिया था.
कुर्बानी 1980 perfect got
Now this is the next last question. Yes, this.
तो मेरी रानी का छल्ला निशान
अल्लाह क्या है?
मेरी रानी का छल्ला निशान
राजा अब आर्टरी, राजा रानी की कौन सी आर्टरी में छल्ला डालेगा? नेक्स्ट क्वेश्चन. सी द आर्टरी. आंसर. रन इट अगेन. ये छल्ला जो गायक ने दिखाया वो रानी की किस आर्टरी में डलेगा? दिस इज विच आर्टरी? एलईडी. किसने बोला एलईडी? आप बोला किसने? आपने. सर ने. सर कब? आप तो सर, आप तो सब आता है. Yes. So we have 4 doctors. Sir, आप सबको you have to introduce again, once again. Dr. Rajiv, Dr. D.K. Gupta, Dr. Atul, Dr. Arora. So now we will play second round. We will ask 5 questions from each participant. There will be one lifeline. You can ask the expert, Dr. Chandrasekhar, or anybody else, or you can ask any of your friends, but there is one lifeline only. So 5 questions. The person who will ask, who will give the maximum answer, he is the winner. The first prize is 15,100, second is 31, third is 2,100, and last is 1,100. So the first set of question goes to Dr. Atul. He's the first winner. So first set of questions. Let's start with the first set of questions. Question number 1. What is PCSK9? Can you tell the full form of PCSK9? You can use the lifeline also.
Yeah, you're correct. It is a lipid lowering agent. So it is a kind of protein which is
Protein convertase. Protein convertase celestin kinin 9. This PCSK9 is it is a enzyme found on the liver LDL receptor. So PCSK9 inhibitor is used for lipid lowering or the LDL cholesterol reduction. When there is a statin intolerance or if you cannot lower the LDL, you cannot achieve the LDL with the help of statins, then you can use the PCSK9 inhibitor. So first question, there will be an expert opinion, so 10 marks to Dr. Atul. Next question, Dr. Atul. 70-year-old lady presented to the emergency department with heart failure and preserved ejection fraction. She was on drugs used for the heart failure. What is this ECG signify? 30 seconds. Hyperkalemia. Right. He's right, sir?
he's correct. He's correct.
There is a tall tented T wave. There is a loss of P waves, white QRS, short QT, there is a hyperkalemia. You are absolutely right, sir. 20 marks. Next. What is the likely diagnosis with this chest X-ray? Any other differential diagnosis? Same pericardial effusion. What else you can see in this X-ray?
On the right side, there is a, you can say, a mediastinal widening. So it could be a.
Yes. You are going on the right.
Yes, it could be a, you can say, a SUL like lymph node, because it's not in the continuity of the vessel.
So I'll give you the 10 marks because one differential diagnosis is pericardial effusion. But in this X-ray, you can see there is no pulmonary artery dilatation, no pulmonary venous congestion. So this is decreased pulmonary blood flow. And this is the right side pathology because you can see the right side dilatation. So the most likely differential diagnosis is right-sided lesion, that is pulmonary stenosis with pulmonary regurgitation, PSPR. And the second most likely diagnosis is pericardial effusion. And third one is Epstein's anomaly. You can also.
Right.
So you're right, sir. 30 marks. This is not a medius widening, sir. This is the enlargement of the
RV
right
type
side.
affects hypoallergenia and RV type affects
Right.
RA enlargement. So it's most likely a combination of low output with
Low output state. Yeah. Right side.
Right.
Low output state. Right. Next question. A 54-year-old male admitted to ICU with ST elevation in V2 to V4. After thrombolysis in the emergency department, what are the indications of successful thrombolysis? All these include all except. So what are the signs of successful thrombolysis except?
Absence of troponin elevation.
Right. He's absolutely right. You are going. I think you. He's right. Next question. So when there is a drop in cardiac output, which of the following is a normal compensatory response? Increase oxygen extraction, decrease oxygen consumption, decrease heart rate, increase oxygen delivery. Fifth question for a tough rakha hai.
There is an increased oxygen extraction.
He is absolutely right, sir. So he is 5 out of 5. 50.
Thank
Great.
you.
Great, sir. So now there will be one question, next set of question to Dr. Chawla, Dr. D.K. Gupta. Are you people enjoying this? So question number 1. Name a condition where two apical impulses are visible. One lifeline, and your time is. You cannot discuss with your colleagues. Your time is over. Your time is up. So anybody else from the audience? Yes, exactly right. Hypertrophic cardiomyopathy. So one pulse is normal and another is of asymmetrical septal hypertrophy. Yes, sir. The next question, a 60-year-old man, known case of mitral stenosis, complaining of progressive dysphagia. Which chamber enlargement is most likely the cause of this situation?
Left atrium.
Right, sir. LA enlargement, you're right. 10 marks. Question number 3. Identify this condition from this diagram, pictorial diagram.
Of PDA.
PDA is there. Yes, PDA is there, I can say.
PDA.
But the exact diagnosis.
Lifeline.
Okay. So Dr. Chandrasekhar.
This is a diagram depicting the pulmonary artery, which is arising from the chamber, which is red in color. So most likely pulmonary artery is arising from LV, and the aorta is arising from the chamber, which is in blue. So it is arising from RV. So there is transposition.
Yes, this is the transposition of great artery. Yes.
Transposition great artery.
TGA, yeah. Next question. What is the likely diagnosis?
Dextrocardia.
Full diagnosis.
Dextrocardia with situs inversus.
Why situs inversus?
The right side diaphragm, this one, shadow on the right side. Stomach shadow on the right side.
Right. He's absolutely right. 10 marks to Dr. Gupta. Last question. So above panel, there is an ECG and below there is a JVP.
Complete heart block.
And this waves are called in the JVP? The arrow mark. This. What is this wave called?
Osner wave.
So you have given the right answer. This is complete heart block, and this is a Canon A wave in JVP.
JVP, no?
Yeah.
Okay.
So full marks to sir also. 40 marks, I think. He's full 40 marks. So next to Dr. Chawla. Dr. Diwan. Dr. Arora. बॉलीवुड का भी पूछेंगे सर आपसे. 40-year-old lady hypertensive has been treated with drug X. Following is one of the adverse effects of this drug X. Identify the drug X.
Minoxidil.
Yes, absolutely right, sir. Minoxidil. This is hypertrichosis. Minoxidil.
Next.
Question number 2. What is the first line pharmacological agent used for the management of hypertrophic cardiomyopathy? First line management.
Beta blockers.
Yes, sir. You are right. अब पढ़े लिखे आए हैं. Next. Identify this condition. This is a normal one, the first one, and second one is abnormal.
Helpline.
Lifeline.
Lifeline.
So this is showing interruption of IVS. So VSD is there, and aorta is overriding the VSD, and the pulmonary artery origin is looking thin. So it is atresia. Together with, if you compare the two sides, hypertrophy of RV is there. So it is typical of tetralogy
This
of
is
palate.
cough, tetralogy of palate. So, yes, lifeline, 30 marks, yes. Question number 4. Identify this image. This image is calcific MS, CT scan in AS, bicuspid aortic wall, or MR image of aortic wall.
तुक्का लगाऊंगा. Fourth one.
No, sir, you're wrong. This is an echo image of calcific mitral stenosis. No point. No, don't worry. Next, there is one more question. Which technology is used in this plaque modification device during angioplasty? What is this device called?
Rota something.
Yeah, you're right, sir. Right, Rota. So I think sir has given 4 answers, right? 40. Now the last, Dr. Diwan. Fatafat. Time is. Question number 1. Which of the following condition with heart failure can false negative BNP values? Myocardial infarction, dilated cardiomyopathy, mitral stenosis, mitral regurgitation.
Stenosis.
Yes, you are right, sir. Because there is heart failure, but there is no LV involvement. Mitral stenosis. Next. ECG diagnosis.
Inferior wall MI
And?
and complete heart block, I think.
Yes, sir. You're right. Inferior wall MI with complete heart block, there is AV dissociation. Next question. Peak incidence of atrial fibrillation after cardiac surgery is on day 1, day 2, day 3, and day 8. You have to guess it.
इसमें guess करना पड़ेगा ये तो. Day 1 कहूँगा, day 1.
Day 1 is wrong, sir. आपके पास lifeline है, sir.
Lifeline, sir. Lifeline.
Day 2 is the correct answer.
Day 2 is the correct. Next question. Next. So which of the following antiarrhythmic drug used in the treatment of long QT syndrome? Codron, atenolol, flecainide, propafenol.
Flecainide.
No, sir. The beta blocker.
That's a beta blocker.
Flecainide can cause prolonged QT. Atenolol. Done? All 4? All 5? This. Name the drugs used in heart failure that can cause this side effect. What is the side effect and which drug is
This is
responsible?
gynecomastia because of spironolactone.
Right, sir. You are right. I think 40, 40, 40, and 50. So first is Dr. Atul, and rest all are runner-up on the same. You want a tiebreaker question for runner-up? Yes, one tiebreaker question. Last. So this is the tiebreaker for next 3. Which of the following is not a pathway involved in the pathogenesis of pulmonary artery hypertension? Endothelin, nitric oxide, prostacyclin, and pentose phosphate pathway. Yes, he's right. Done. So he's the second one. First, second, and there is 2 candidates on 3rd position. So I think एक और क्वेश्चन टाइम नहीं है टाइम नहीं है नीचे पूछ लेता हूँ आके सर थैंक यू एवरीवन सर थैंक यू आई ट्राइड टू
Wonderful. Dr. Naveen Bhamre, you have really conducted the session so nicely. It was so interesting for all of us.
Thank you, sir. Thank you. Thank you, sir. Thank you, sir. Thank you, everyone. Thank you.
Now I request all our chairpersons and panelists to be on the right side of the dais, please, for felicitation ceremony. We start our next session. Next session is by.
Thank you to Dr. Bhamre, and sorry, anybody wants more, but we are sorry we have no time. And thank you very much, Dr. Bhamre, for a wonderful session. Thank you.
Wonderful. It was so interesting. The session was really wonderful. And for our next session,
I invite Dr. Nitin Agarwal, Senior Interventional Cardiologist from Sri Action Balaji Hospital. He is going to talk on clinical approach to a case of dyspnea in OPD and its management. Dr. Nitin Agarwal, please. And the panelists for the session are Dr. Sandeep Datta, Dr. B.K. Agarwal, Dr. Rajiv Arora, Dr. Praveen Bhatia, and Dr. Amit Johri. Please come on the dais. And the concluding remarks will be by Dr. Chandrasekhar, who is again a senior interventional cardiologist. Dr. Rajiv, is he here? Dr. Rajiv Arora? Dr. Miglani, please join them for chairing the session. Pointer into. चल रहा है? Slides कैसे? Up and down slides, up and down. तो दूसरा वाला दे देना. ये up down. ये हो रही है, ठीक है? चल रहा. ठीक है? हाँ, फलक मत दे दो. नहीं आवाज नहीं आती, उधर घूमेगा. उनके पास है, डॉक्टर हम
Hello, hello. Can I have a mic, please?
For this, to cover this topic, we have Dr. Nitin from Action Biology Hospital. He's senior consultant cardiologist with the hospital, and he's going to give his expertise on this topic. Welcome, Dr. Nitin.
Thank you, sir. Thank you for a nice introduction. A very good afternoon to all. First of all, thanks for the nice introduction, sir. And I would like to wish you all a very happy Lodi and a Makar Sankranti. And also, it's a very honorable and proud moment for me to stand on this platform of NDPF to speak on this topic, which is close to my heart. And a special thanks to Dr. R.M. Chavda, sir, Anand Jha, and whole NDPF team. Today, I'm going to present a topic on how to approach a patient with dyspnea. This is a case of a 62-year-old gentleman presents in the OPD with chief complaints of shortness of breath since last 10 days, which increased on lying down and climbing 2 flights of stairs. He has a history of hypertension, hyperlipidemia, and a history of stenting 5 years back. His current home medication includes amlodipine, atorvastatin, Lasix in a single dose, and a dual antiplatelet therapy. So on examination, he's a tachycardic with a BP of 100 and saturation of around 92% at room air. So how to approach and what to examination on this step? So how to make the diagnosis? What are the 3 physical tests, or what are the tests and what lab tests and imaging we can do? We are sitting in the OPD and this patient presents, so we have to make the diagnosis. Rule of 333 should be remembered. We need only 3 physical examination. We have to see it, we have to feel it, and we have to hear it. We have to see the JVP, we have to feel the pedal edema, and we have to hear the LVS3 gallop. These 3 can make our half of the diagnosis. Now the 3 lab tests, KFT, creatinine, sodium, and potassium. These are the hallmark for diagnosis and treating the acute heart failure. BNP, as we all know, nitrogen peptide, and troponin. 3 test imaging, ECG, X-ray, and echo can all give about the diagnosis. As we all know, third heart sound and LVS, JVP is a subsequent development of heart failure with patients with asymptomatic LV dysfunction. This is the chart, and it shows LVS3 and neck vein distension positive in almost 100% of cases. If we found these 2 things, we can have a certain diagnosis that a patient has acute LVF. We must give respect to sodium and potassium because both of them are the interdependent as well as the independent predictor of mortality in case of hospital as well as outpatient setting.
We all give utmost importance to KFT and potassium, but sodium has been left out. Hyponatremia in congestive heart increased mortality. As we can see in this diagram, a patient with a sodium of 135 and as compared to lower sodium has an increased mortality and lower chance of survival. So sodium should be given the utmost respect and should be treated accordingly. Natriuretic peptides, as we all know, BNP is the marker for the heart failure, is a sign of volume overload. A BNP level of 100 or NT-proBNP level of less than 300 usually rule out our diagnosis of heart failure, while the level of greater than 400 and 1000 usually rule in the diagnosis of heart failure. So BNP should be taken care of in account. And every patient whom we are suspecting the patient has raised GAVP, LVS3, NT-proBNP can be ordered and the results are out in half an hour or 1 hour. Echo. Echo is the most dynamic test in cardiology. No machine, no instrument can diagnose our LV function without echo. And what are we all discussing today? Heart failure with reserved EF, heart failure with rule out EF, and reduced EF. It can all be diagnosed by the echo. So in our patient, the investigation comes physical examination. We raise JVP, S3 gallop, and 2+ pitting edema. Laboratory showed a BNP level of more than 5,000. And other troponin and metabolic panels are normal. Chest X-ray showed plethoric lung fields with Curley B lines, and EC show AF with LBF. And echo shows the LVF of 30% with the dilated LA and a mild MR. So we almost reached the certain diagnosis of heart failure with reduced EF. What may be the cause of decompensation in this patient? We just need to remember this mnemonic of failure. Whenever we are taking the round or when we are sitting the OPD, why the patient has come this time? Just remember the mnemonic failure. For my DNB students and all other colleagues, F for failure to take medication. सबसे पहले से पूछना है कि आपने दवाई ली है कि नहीं ली? You have missed any doses? A, patient has sudden blood loss, arrhythmia or AF. L, I, ischemia or infection. We can rule out by ECG changes or troponin. Patient को कोई new development of ischemia है या कोई infection हो रहा है. L, lifestyle and disease. Patient usually take water intake more, or they miss the doses, or their salt intake. So lifestyle discretion is much more important. Any upregulation like pregnancy or thyrotoxicosis. Renal failure, the serum creatinine may rose up, embolism or the stenosis. So failure mnemonic we should always keep in mind, and we rule out almost all the diagnosis. And we can order the test accordingly. If you are suspecting anemia, you can order CBC, TSH for thyrotoxicosis. So this matter, failure mnemonic should be taken into account. So our patient is taking amlodipine, atorvastatin, Lasix, and dual antiplatelet. My next question, would you like to stop some medication? And what will the treatment study next? हम इन चारों में से कुछ बंद करना चाहेंगे? Very rightly said, but why, sir? Okay, good answer, sir. Always respect the blood pressure. Always respect the blood pressure. Spend your blood pressure in heart failure wisely, like you invest money in the stock market. Amlodipine has not shown any benefit in any heart failure trial, whether it is morbidity, hospitalization, outpatient setting. तो हमें अपना blood pressure बचा के रखना है कि हम आगे हमारी जो drugs हैं उन पे use कर सके. So amlodipine like drugs or nitrates like that should be taken off. Now comes the fantastic four. As we all know, the four drugs, the four pillars of the treatment nowadays in the failure of heart failure with reduced EF. Beta blockers, RAS inhibitors, MRA, and SGLT2 inhibitors. These four drugs are the cornerstone of the therapy, and it should be taken into account. I will just take a 2 or 3 slides for selecting each of one. But how beta blockers act? Beta blockers increases our LVEF by decreasing all the things. इतना याद रखना है बस. हमारा LVEF बढ़ाती है, सब चीज को डिक्रीज करती है. It decreases ischemia, decreases arrhythmia, decreases myocardial apoptosis, sympathetic stimulation, and left ventricular size. अगर EF बढ़ जाए हमारा और बाकी सब decrease हो जाए, what we want? We are here for that only, to increase the LVEF, to come out the patient. It has shown the remarkable benefit. Next question, which beta blocker? Carvedilol or metoprolol? In heart failure, it's a study of more than 1 lakh patients. And it showed at 6 years, the survival probability was almost 56% in the carvedilol group as compared to 50% in the metoprolol group. So carvedilol definitely has the edge in heart failure with reduced EF or LVEF. RAS inhibitor, ARNI. I still remember the date in 2014 when I was giving the Viva for DM. My examiner has asked, "This is a new drug. Are you using nowadays for heart failure?" No answer in that because just the paradigm trial has been published in August of 2014. And that the remarkable drug, only one name was there, Entresto. That is not available in India at that time. And it is the almost eight years down the line. And it has changed the paradigm shift in the management of heart failure. And the revolution, what I can say, only earlier trial which has been done with the placebo and the ACE inhibitor is the WellHEF trial. Valsartan has been taken. After a 10-year gap, this drug has come, which has changed the paradigm of treating the heart failure. Now we have a 5-year, I don't get a 7 or 8 years data, but we have a 5-year data of paradigm HF. There's a 5-year journey. And it shows almost all remarkable benefits. And the important is the health-related quality of life, which we can see. All parameters are very, and importantly, the ED visits for heart failure are significantly reduced by using this drug. So ARNI is the revolution, or we can say a remarkable drug in this journey. What is numbers needed to teach? It is defined as the inverse of absolute reduction. अगर किसी ड्रग का नंबर जितना कम है कि मतलब कितने पेशेंट को हम दे रहे हैं और कितनों को फायदा हो रहा है, वो ड्रग बहुत अच्छी है. So its number should be close to 1 or less than 1. It should be close to 1 or as small as possible. Now we can see by this diagram. The ACE inhibitor has an NNT of 18, beta blockers has an NNT 8, and ARNI as 11 or 21. So as compared to the ICD or CRT, what we are implanting device, beta blocker has much more benefit. It can reduce arrhythmia and chances of cardiogenic collapse are less. Sudden cardiac death are less if you're using the beta blocker. So don't stop my beta blockers. Whether the patient presents in the heart failure with a BP of 100 or 90. Beta blockers in the low dose has shown much more benefit as compared to the others. And second is the ARNI. It has also NNT of 11, 8 and 11. These are remarkable. अगर हम 10 लोगों को दे रहे हैं तो उसमें एक की जान बच रही है. And no drug has shown like this benefit. Lastly, the MRA, aldosterone antagonist. This is the unrespected drug. Itni purani drug hai, but we have not taken care of that. Still, we are not using very much because of the fear of potassium or creatinine. It doesn't change creatinine much. Yes, we have to respect potassium also, and we have to take care of. But it has shown significant advantage, and it has been shown to improve outcomes in terms of hospitalization, as well as in mortality in setting of ischemic as well as the non-ischemic heart failure. This diagram I must want to show and emphasize on that this is the epinephrine emphasis trial. The remarkable benefit starts from the day 1 as compared to placebo with epinephrine. The mortality benefit, hospitalization, all are reduced. So it should be used with the LVF of 40% or 50%. But in 50%, the heart failure preserved here, it has not shown so much benefit as compared to the heart failure reduced here. Now comes the wonder drug or the charismatic drug of this era, that is the SGLT2 inhibitor. Can anyone remember this? No, he is not the inventor of empagliflozin or dapagliflozin. He is not the inventor of any SGLT2 inhibitor. Yes. He is Lawrence Block, an American crime writer, who is much believer in the serendipity. Look for something, find something else, and realize that what you have found is much more suited to your needs than what you have thought you are looking for. मतलब हम चाहते कुछ थे, मिला हमें कुछ, और जो मिला वो उससे भी बढ़कर था. So nothing can describe this drug like that. It has more than dozen of mechanism of action. I don't go into this. I can simply say a magical molecule with amazing results. There's a recently published trial in September of this last year, which compares the almost major 5 trials, deliver, emperor preserve, DAPA-HF, and consists of 22,000 population. SGLT2 inhibitors reduce the risk of cardiovascular death, hospitalization, irrespective of ejection fraction or care setting. So what we are waiting for? We should add SGLT. No drug till now has shown benefit in heart failure preserved EF except SGLT2 inhibitors. So every patient of dyspnea with a EF of 50%, 55%, and less than much, that should be given the benefit of this magical drug. Next question: how and where to use it first?
कौन सी ड्रग, सबसे क्वेश्चन आता है कौन सी हम चारों दिन के लिए कौन सी कैसे ऐड करें. These are rapid evidence based sequencing given by McMurray and Packer. These are the two strategies, conventional sequencing and rapid sequencing. It has been conventional में क्या किया उन्होंने कि पहले एज लिमिट को किया and they have taken 6 months. 6 months तो पता नहीं पेशेंट कहाँ पहुंच जाएगा. But in rapid sequencing they have taken 4 drugs in 4 weeks. हमें चारों ड्रग ऐड करनी है at least minimum doses in the 4 weeks period. So rapid sequencing is a novel strategy that has shown the tremendous benefit and improved the implementation of treatment that reduce the morbidity and mortality in patients with HF, heart failure. So in all the groups, if the patient is de novo heart failure, we have to initiate with these drugs and initiate interferon, SGLT2 and MRA. Chronic heart failure, stop ACE, ARB, continue with and add MRA and RNA. Acute heart failure, stop ACE and ARB. We have to put RNA in context. So 4 drugs on board in 4 weeks. अगर हम 1 month में उनको कुछ भी benefit दे पाए, it's a wonder. We prevent morbidity, mortality, hospitalization. This is a recently published article in Lancet, just almost less than 1 month, December 3. It shows the safety, tolerability, and efficacy of up titration. It's a strong HF trial. It shows an intensive treatment strategy, reduce symptoms, improve quality of life, and reduce the risk of 180-day all-cause death or heart failure readmission compared to usual. So what are the absolute contraindications? I am right? Hypotension, renal failure, hyperkalemia, UTI. No, sir. There is no absolute contraindication. We are not treating numbers. We are, if the patient able to not to tolerate, withhold the med, stabilize the patient, treat the condition, and again add in low dose. But don't deny the amazing benefits of these drugs. These are the wonderful. After a long time, we have got 4 drugs, which can be patient can't be given devices. We can give these drugs to add them. So my take home of message: heart failure is a purely a clinical diagnosis based on physical examination, routine labs, and imaging, which do not require any fancier test. Optimal quadruple therapy is the way to go with the ABCD mnemonic. No one remembers. A for aldosterone antagonist, B for beta blocker, C RB or SIDMAS, D for dapagliflozin. These medicines are incredibly well tolerated, make patient feel better, less likely to be hospitalized, live longer, and may have significant improvement in cardiac function. Thank you. But I stand, health is the crown on well person's head that only ill person can see. So we should try to make our patients healthy and fruitful and prevent hospitalization by adding these medicines. Thanks a lot.
Wonderful presentation, Dr. Nitin. I would ask the comments from the chairpersons. Dr.
Thank
Amit,
you,
please.
Dr. Nitin. It was a really fast and quick session, like fastest finger. So, few points which you have covered, all the points you have covered, but I would like to highlight 2 or 3 points only because the topic was of OPD. So, what I have seen in last 25 years of practice is that what is said is usually not followed at various levels. Even in US, 50% of the prescriptions do not follow the standard guidelines as devised by them only. So what would be happening in India is certainly no big thing. But you see that obvious clinical signs which we obviously miss, like you said in 3x3x3, is very important. Whenever we think of dyspnea, we think of lung condition first. Especially in the smog, full winters, Delhi, smog, everything, and patient always gives history that so you are confused. So must look for the first three clinical, then the next 3 clinical lab and the imaging. If possible, imaging is very good. Then we come to the titration. Now this I have seen in last few years of practice, the titration, the person is on the same dose for years and years and years together. Unnecessary usage of amlodipine, yes, it should be curtailed whenever you think of, say, patient going into either preserved ejection fraction failure or the residues. That is must. So titration is very important. We usually miss that thing. Risk should be explained to the patient very clearly. That if you are up titrating a beta blocker, what could be the result? If he can get significant bradycardia or a syncope-like system, and the ARNI related risk as well as the SGLT2 related risk of UTI. Although it is not a contraindication, but if the patient has to stop that drug because of UTI, because of the trouble he or she might be getting, then it is very important. So, and SGLT2, as you said, that is a smart diuretic, more of a smart diuretic than the OHA. So yes, it should be used much often. And ARNI, I think the cost has come down now as with the SGLT2s. I do not remember the exact cost. I think it has gone down from the 50 rupees Viamada and Zedmus to less than that. So yes, a very good presentation, very crisp, that how we deal in the OPDs. Thank you so much. Thank you.
For the,
Any comments, Dr. Miglani?
for the general physician, basically jumping directly to the cardiac dyspnea, the history of respiratory problems, like for the bronchial asthma, like episodic or COPD, or the bronchiectasis where the sputum is copious, or associated copulmonale, when the S3 may be there with the associated respiratory chronic disease with the copulmonale and congestive heart failure, and the contributing factor like the anemia, thyrotoxicosis, he has mentioned about this can aggravate the heart failure. And the S3 and S4 sometimes can be physiological also, like in athletes or in a elderly, S4 can be there. So, and the auscultation at the basis for the especially fine end respiratory cracks can help you to find that it's a left heart failure or it's a heart failure. And just a minimal auscultation at the mitral area or the just areas cardiac mentioned cardiac area to exclude the valvular pathology. This simple 3-4 points, if you take care of in OPD, you can conclusively reach what is the cause of the dyspnea. In this case, the cardiac dyspnea, heart failure has been conclusively covered by Dr. Nitin. I congratulate you.
Thank you. Thank you.
I want to ask one question. So do you think when the patient is in decompensated state and he's not on beta blocker, I think we are doing more damage than good because we are destroying his adrenergic drive. So I think first of all, the patient should be dry and then we should add on drugs.
Yeah. So definitely.
So the diuretics comes a very important role, which the guidelines are not talking.
But diuretics had not been given any guidelines for acute decompensation. The diuretics and the CPAP or the positive pressure support is must in an acutely decompensated state. After the patient becomes dry, that's why we have classified into 4 groups: dry and warm and wet, warm and cold. So we have to classify these patients in these 4 groups. Then accordingly, we have to manage according to loop diuretics or the CPAP. Then only we can add subsequently these drugs.
And I think, sir, hemoglobin is also important marker.
Exactly,
We should,
sir.
every person should go for a hemoglobin also, because sometimes I have seen people are going fluid overload. They're having weakness and they're taking extra fluids in their home.
Very rightly, sir.
So,
concluding remarks from Dr. Chandrasekhar.
Must congratulate Dr. Nitin for a fine, crisp presentation.
Thanks.
And the mnemonics he has given, that failure is very important in any patient who is coming with decompensated heart state. So we have to be careful. And one point he very well conveyed, that doses are very important. The outcome trials he quoted were based on the maximum doses when being given to such patients. So you have to escalate the dose to the maximum tolerable possible level. So to achieve a number needed to treat around 8, you have to give maximum possible doses of beta blocker, to 11 to maximum possible doses of ARNI. So that we have to understand. Again, I must congratulate. Nice.
Thank you. Let us give him big hand to Dr. Nitin. Thank you. Please join us for felicitation on the right side of the dais. All chairpersons and Dr. Nitin, please. So our next session is from nephrology. And for this, I invite our moderator, Dr. Manoj Arora. He is senior nephrologist from Max Hospital, Shalimar Bagh. Clinical challenges in managing anemia and CKD, a very important topic and relevant for physicians, general practitioners, for everybody. And the panelists for the session are Dr. S.K. Arora, Dr. Ashok Pansari, Dr. Yogesh Chabra, Dr. Abhishek Garg, and Dr. Manoj Agarwal. I invite all of you on the dais, please. So the floor is yours. Dr. Manoj Arora, please conduct the session.
Good evening, everyone. So today we have made this session to make it interesting, and there are no slides. We'll go with the questions and the answers with that, so that you are in the day-to-day practice, how you should treat the CKD and anemia, you should be known to you. So I will invite all our panelists are here. I think they all are renowned, and sir has already taken the name. So we will start once you comes with the patient with the anemia. Let's start the journey with it, and what are the challenges, and then how in day to day you have to manage them. So my first question to Dr. S.K. Arora, sir, how you define anemia in CKD, and is there any disease correlation with the stages of CKD?
Usually we define anemia if in a female HB is less than 12.5 grams, in male it is less than 13.5 grams. But in CKD, usually less than 12% is taken as the anemia. As the disease progresses, the amount and severity of anemia increases. Most of the time from the stage 3, it starts increasing.
Right.
And like in stage 3, it is mild to moderate, and stage 5, it is relatively severe anemia that you find.
Right.
In 1 and 2, you may find or you may not find.
Right. I think, and the prevalence of anemia has been seen from 15% to 54% as the stages increases. That is an NS study. But in India, it is much, much more common. And it has been seen that the anemia prevalence is around 60% in stage 3. And once it reaches to stage 5, one study stage, it may be up to 90%. Another point is if the patient is diabetic, in all diabetics at any level of GFR and any level of albuminuria, they are more anemic than the non-diabetics. So this we have to keep in mind once you are treating anemia in CKD, especially the diabetic population, which takes a major chunk of this patient. Now, the next question to, I think, Dr. Yogesh, I'll ask, what test you advise once you see a patient with anemia in CKD before starting ESA? So here we'll go stepwise. ESA is the later on. So what comes to your mind if they comes and the test you will advise?
If we are seeing a patient with anemia in patient with chronic kidney disease, we would like to go ahead with iron studies, which should include the iron level, iron saturation levels. And also we would like to see the iron stores by looking after the ferritin levels. And also we would be actually focusing on other parameters. We should be actually ruling out the pancytopenia. We should be looking for the peripheral blood smear in this kind of patient. And in fact, before we start the ESA, we should be clear that the ferritin levels in the patient who is already on dialysis should be more than 200, who is not on dialysis, the ferritin level should be more than 100.
We will come to iron and iron, but these are the just 1, 2, 3, 4, 5 steps. Once the patient you see with the anemia, and before we don't want to start ESA or before starting, what other tests will you raise? I'll just add on. We will go for the absolute reticulocyte count, iron, as is told, iron profile, vitamin B12, folate levels, and peripheral smear. They all are very, very important before you jump to starting to ESA, because they all are manageable. And with that, you can delay the putting the patient on ESAs. So first, these 4 or 5 tests should be in your mind once you see a patient with the anemia and CKD, and then jump for the ESA.
In fact, actually, I would like to mention here that
I was about to ask, what is the role of EPO level? Shall we?
There's no level. There's no point of doing an EPO level because it's a kind of a relative EPO deficiency. Although the levels would be on a higher side, but it is not sufficient for the bone marrow to work in an adequate manner.
Yes,
then there's no point to go ahead with the EPO level.
Yes, because there is a oxygen deficiency and the kidney adapts to it. So the EPO levels keep on secreting because of because of tissue hypoxia they maintain, but at a lower level also it keep on working. So EPO level has no role whenever you prescribe ESA in any of the patients. So there is no need to get an EPO levels done. Now, I'll ask Dr. Manoj Agrawal. He's a very good colleague and a very good physician. What is the impact of low hemoglobin in CKD patients?
As we know, most of the CKD patients are having many comorbidities associated. If there is low hemoglobin in CKD patients, the cardiac has to work more. So the cardiac has to produce more stroke volume. And because of that, there is further decrease in the renal blood flow. And because of that cardiac blood flow, they can be cardiomyopathies or they can be other cardiac diseases also. Also, because of the low HB in CKD patients, there is also increased incidence in the strokes also. So both the cardiac as well as the cerebrovascular diseases are increased in CKD patients if there is low HP.
Yes. The other thing is, if you encounter any patient complaining that he has cognitive impairment is there, he is very much fatigued, this iron deficiency alone can explain these symptoms. So there is no point jumping to ESA and high-five drugs. First, you treat the iron because or anemia, and these all general symptoms are very common in CKD patients where they come with the letharginess. then the risk of infections is very high if you don't treat the anemia. Then there is a mortality, cardiac mortality has been seen very high because of anemia. So treating anemia in a CKD patient is a very, very, very important task. And it has a huge impact on cardiology impact as well as general as well as the renal. So all need to be taken care. So that's why anemia correction is very, very important. Now, the next question I will ask again, Dr. Yogesh. This is very important pertaining to CKD. What is absolute iron deficiency and what is functional iron deficiency, which is relative only in CKD patients, and it is a very good relevance in that.
In fact, something out of that, some points have been discussed earlier, that once we look for the iron studies, we actually go ahead with the iron saturation values. We look for the ferritin levels. The ferritin levels tell us about the stores which are present in the body, and the iron saturation tell us about the mobilizable iron. But we have to remember one thing here, that CKD is a stage of inflammation. Is a kind of inflammation is going on, and hepcidin levels actually leads to increased ferritin level, because the iron is not getting mobilized from the tissues and it is not getting adequately utilized. So we find a higher ferritin levels. In fact, in some studies, iron levels have been found to be more than 1000 as well. And we have to be clear here that the relative iron deficiency is one thing which we actually see in most of the patient. We also have to look for the iron saturation values. If the iron saturation values are less than 20%, even though the ferritin level, even up to 800, we have given IV iron to replace the iron stores. And we have to replenish the iron stores before we actually go ahead with the erythropoietin therapy.
Yes. So functional iron deficiency is very important, in which you will find a low TSAT, but the ferritin will be high. Now, what to do in these cases? Shall we go for the iron replacement or not? Yes, in our patients of CKD, functional iron deficiency needs to be taken care. And if your ferritin levels are less than 500 and TSAT is less than 30%, we can go ahead with the IV or the oral preparation. And if some people now studies say that up to 800 nanogram per ml ferritin is acceptable, because CKD is a stage of inflammation. So there is no fixed criteria regarding ferritin. So don't get biased. Here the stores are high, but functional deficiency because the TSAT is low. Why the ferritin levels are high and that iron is not able to mobilize? Because hepcidin helps in moving out the iron from the reticuloendothelial cells and mobilizing the stores. And the hepcidin level is very, very high. So that's why there is a immobilization, and then keep the stores are high, and we get the ferritin values which are so high in CKD patient. Now the next question to my colleague Dr. Abhishek. Oh, I think I'll ask this to Dr. Yogesh, because he is continuing with the iron. So when you will start oral iron, and what are the indications for IV iron?
If we actually see, the oral iron is actually less expensive. It is readily available. It can be given to most of the patients. Even in non-dialysis population, we would like to prefer it over the IV iron, because patients don't like to go ahead with some intravenous injections. But nowadays, since the advent of ferric carboxymaltose and isomaltoside, we can give a higher dose of IV iron in a less duration. Then we are actually preferring IV iron over the oral iron in these cases. But we have to remember one thing: in oral iron, since the advent of the liposomal iron, the availability of the oral iron has improved, the gastric side effects have reduced, and the patients are more tolerable to oral iron as compared to the previous oral iron like ferrous sulfate, and which were available previously. Now we are actually going ahead with IV iron also, because we can give a rapid dose of IV iron in a less duration. We would like to prefer IV iron where there is severe iron deficiency. It is going to take a longer time to replenish with the oral. Then we would like to prefer the IV iron over the oral iron. And in fact, if the deficiency is in a mild to moderate side, we would like to prefer oral iron, specifically in a non-dialysis population.
Right. So this is very important. In the early CKD, you can definitely give a trial of 1 to 3 months of oral irons. In dialysis patients, oral iron is not recommended, because that does not work. Why? Because the gut microbes are affected in the CKD because of uremia. Secondly, because of the hepcidin levels, which are too high, they prevent the absorption from the duodenum. So that is another factor where you won't get the iron results if you keep on giving oral tablets to many months. So it's always preferred, when the patient is on dialysis, must go with the IV iron. If patient is in early stage of CKD, it's your choice. If very severe, go for IV iron. Intolerant, go for IV iron. Otherwise, you can definitely give a trial of 1 to 3 months. But if the iron levels do not get increased, or you don't get your TSAT and ferritin in your value, then definitely you have to switch to IV preparations. Now, how frequent you would like to monitor the iron levels once you have given it? or when you will like to do more frequently the iron levels?
If we have already if the patient is on iron therapy or the patient has the low iron stores and we are actually going ahead with erythropoietin therapy in this kind of patient, we would like to monitor iron maybe every month, or we would like to monitor hemoglobin every month. But if the stores are replenished, then we need not actually monitor the iron stores very frequently. We can monitor it maybe in 3 to 6 months, and hemoglobin can be monitored maybe in couple of months or every 3 months as per requirement if the stores are adequate and the patient is stabilized. But in the patients where there is iron deficiency, where there is hemoglobin is on the lower side and we are replenishing it, we will have to monitor it on a frequent basis.
Right. Whenever you start a ESA or you increase the dose of ESA, your monitoring should be high. You should be more frequent. And once you have established that, you have achieved that, then monitoring should go down. Another thing is, what is the other harm with the IV iron? We are prescribing so many. The anaphylactic reactions still are reported. The cost is still very high. You need an emergency or some doctor supervision, which are not required with the oral iron preparations. So only writing IVs, but we have seen many reactions with the IV, though they are very less, but yes, that reaction is not seen with the oral iron. So there are advantages and disadvantages using oral and IV, but choose your patient rightly. And if there is no response, IV is definitely much better than oral. So the next question to Dr. Abhishek. Do every patient of CKD need ESA, or what should be the target level of hemoglobin that you should achieve? And role of ESA will go to next. Yes.
As far as target levels are concerned, in CKD patients, we don't target HB above 11.5. If it's around 11.5, we are more than happy with it. And
so when you like to start ESA?
Starting ESA, the ideal thing is we should not let the hemoglobin fall below 9 to 10. So if the hemoglobin is around 10 and 9.5, 10, so either you can first of all correct all the reversible causes of anemia, and then if it does not respond, then you should add on ESA therapy. And the target levels you have to adjust so that the anemia hemoglobin level doesn't go more than 11.5. So that will be the target range, 10 to 11.5 basically.
In what dose you like to prescribe ESA once you start it?
If you go by the book, the prescription dose is actually very less. It will be around, in a 60 kg person, it will come out to be around, 2,500 to 3,000 international units per week. But most of us, we generally prescribe at a higher dose because that is limited by the availability of the vials and the cost effect. So we generally practically started in the 5 to 10,000 units per week. So which is slightly on the higher side, but then we gradually taper it down or increase it as per the response, which we monitor every 15 days or to 1 month, the rate of rise of hemoglobin.
Right. So starting ESA in a dialysis patient, it should be started once the hemoglobin is around 9. 9 to 10 it should not go below 9. And in a normal CKD patient not on dialysis, you can wait up to 10. If it is going below 10, some people say 10.5, some say 10, but never achieve a hemoglobin of more than 11.5, and do stop or reduce it, because there are many harmful effects seen with the higher dose, which I think Abhishek will answer later. But this is the point I want to make. Once the hemoglobin is 11.8, then no role of ESA. Just stop it and then monitor after 2 weeks or maybe 4 weeks. And if it is again going down to less than 10.5, then reconsider of doing that with the lower dose, because he has responded well. So what are the Dr. Abhishek, what are the drawbacks for excessive use of ESA?
So the side effects of ESA basically, they are either related to the increased doses of ESA, because when the anemia is not getting corrected and we keep on increasing the dose of ESA. So
till how long you can increase it?
No.
What is the recommended dose?
No. Ideally, you should only be increasing it, like if the initial dose is around, let's say 3,000 international units per 50 units per kg body weight per week. So you can increase by the 50% increments in 2 doses. That means you can go up to 100 or maximum 125 units per kg body weight. But to be honest, practically we end up using doses more than that.
Yes. And so what are the drawbacks for that? I'll come to the again question.
So the drawbacks will be, sir, there is increased incident of thrombosis, graft vascular access thrombosis, stroke, or even cardiac issues will be there. Patients are more prone to develop hypertension. They can subsequently land in heart failure. And there are some other, you can say, many people, they have flu-like syndromes also with the EPO.
Right.
And so those are the main issues which will be there.
And in which patient you should not use ESA?
ESA, if there is history of stroke, then you should be very careful.
Yes.
If there is a pregnant female, then you should discuss with your treating obstetrician. If the patient is having active malignancy, then you have to weigh the risks and benefit, and then you take a call whether to give ESA or not.
Yes,
So
especially
these
you are
gray
anticipating a
areas.
cure, then
Yes.
you should be very cautious in giving ESAs to these patients, and you must discuss with the oncologist whether they are comfortable with that. Otherwise, blood transfusion is the second option for these patients if you don't want to use ESAs in those patients. Another is the cost. We did not mention that if you keep on using excessive doses of ESA, the cost of the treatment increases remarkably. And if you are missing some other causes and we keep on stressing on the increasing the dose of ESA, then again we miss the bus. And we don't get the response as we were expecting. So 50 to 150 units per kg is the recommended dose, and we'll come to the ESA resistance, what exactly that is. So I'll come to Dr. Yogesh again. What are the available ESAs you know of, and how you compare them, their effectiveness as well as the cost effectiveness?
If we are actually broadly classifying the erythropoietin available in India, we have erythropoietin alpha and beta, which are actually which have the shortest half-life. Then comes the darbepoetin, which can be given in a weekly formulation. And then comes the pegylated erythropoietin, which can be given in a once in a month formulation. And once we actually compare to the effectiveness, more or less the head-on trials between different ESAs have shown the equal efficiency. But by clinical experience, we would like to mention here that erythropoietin, short-acting erythropoietin or darbepoetin are good to increase the hemoglobin level in initial phase, but to maintain it, or specifically in a non-dialysis population, we prefer the pegylated erythropoietin, which can be given once in a month formulation. Specifically, if the patients are traveling, they can actually carry in a less form. That is actually quite helpful. But if we are actually talking about the cost, initially erythropoietin short-acting alpha and beta were quite cheaper as compared to darbepoetin, and specifically compared to the pegylated one. But now the cost is almost catching up, and we can see that most of the good companies have the cost is almost equivalent if we actually calculate the monthly treatment.
Yes, even the studies have been done, and they have found the pegylated sera, which we say as a pegylated erythropoietin, they are more cost effective because if you go in the long run, because in this ESA we keep on increasing the doses as well as the cost goes up. Secondly, there is a ease of administration, because once a month patient is very comfortable, only one injection in a month and his hemoglobin is maintained, rather than twice a week, 10,000, 4,000, and every time it's a pinch to him that one prick is more there for increasing my hemoglobin. So especially even if it is diabetic, they are getting their insulin daily done, but for the EPO, they don't get easily. So the reluctance of using EPO is very high in our CKD patients. They keep on asking for the tablet, they keep on asking for iron tablets, they keep on asking other nutritional, but don't start the EPO because it's a prick and we don't want to give it. So in that sense, once a month can definitely help us, because it's very easy. He can bring in your clinic, you can get it done once and then after forget it. And after 1 month again, he has to come back with one injection and you just give him. So that's why that is a more cost effective and better compliance. This is very important. So another questions, Dr. Abhishek, do all patients here where we start ESA, they respond? And what is ESA resistance?
Sir, not every patient will respond to ESA. And basically, I'll take up the resistance and hyperresponsiveness in the same way, because there is a lot of overlap between the same. So first of all, you have to be sure that you have ruled out other causes of anemia. And then if we are talking about dialysis patients, patients who are having inadequate dialysis, they will have a suboptimal response to EPO. If they're having iron deficiency, B12 deficiency, folic acid deficiency, they'll have a suboptimal response to ESA. Okay. If they're having an underlying state of inflammation, either because of CKD or because of any active infection, then again, they will have a suboptimal response to the erythropoietins. And the basic, we have already said that if you need to increase 2 increments in doses, like by 50%, 2 consecutive week, you have to increase. So that is a subtle sign that the ESA hyporesponsiveness is there, or ESA resistance is there.
Right.
And all the trials, they have shown that if you keep on increasing the dose in these patients, you will end up with more side effects, irrespective of rise in hemoglobin or not.
Right. Hyperparathyroidism is another, because
hyperparathyroid.
parathyroid hormone is a uremic, like a toxin to the bone marrow. FGF23 is a toxin to the bone marrow. They reduces the erythroid progenitor cells. So that needs to be taken care also, because that is correctable factor where which you can work. Reducing the inflammation is the malnutrition inflammation syndrome. That is another factor where you will get the ESA resistance. So taking care of nutrition is as important as taking off your ESA dose. So those things has to be taken. Hemoglobinopathies needs to be taken care of. Your patient is not responding. Myelofibrosis is one thing where your patient is not responding. So bone marrow can answer those things, but it needs to be kept in mind if you keep on increasing the doses of ESA. Now, it's a very quick question. What comes to your mind when you see a patient with anemia and rapidly progressive renal failure? Dr. S.K. Arora, sir. This is apart from the CKD. Patient has come with the rapidly progressive renal failure and anemia.
We have to look for other comorbidities like multiple myeloma.
Yes, sir. Right. And Dr. Manoj, once again.
Other things we can consider is like hemolytic uremic syndrome, ETP, and many microangiopathic diseases.
Yes, vasculitis, myelomas, and TMS. They should come to your mind once they come to you with the rapidly progressive renal failure and anemia is there. Now, what is oral ESA? We'll take 1 minute in that because it's a new thing. So I'd like Dr. Yogesh to answer, and I'll just display a slide to explain this, how it works.
Actually, the oral ESA is having a different mechanism altogether. It actually, it acts on HIF mechanism. The HIF has been recently awarded the Nobel Prize in 2019 for that. And if you see that HIF is a molecule which actually get broken by the prolyl hydrolase.
So we have displayed here.
Yes,
So
and in fact, if the pH is these inhibitors actually work on this prolyl hydrolase enzyme, and the HIF is stabilized, and which actually leads to further erythropoietin generation.
Right.
It is usually prevalent in hypoxic state, but with the help of these enzyme inhibitor, it is actually prevalent in most of the time, even without the hypoxia as well.
Right. So that is the enzyme which degrade this HIF complex. If we block that enzyme, so definitely there will be unstimulated, there will be continuous expression of the genes. So endogenous erythropoietin will be keep on secreting and transcription of genes will continue to happen. The good part is that they have a negative effect on the hepcidin gene also. So hepcidin gene gets suppressed. So there can be less inflammation with this. So the agent which is available in India is desidustat. I would like to answer, I asked Dr. Yogesh again. Now we have started it. What patient to choose for this oral ESA?
Actually, right now, one thing I would like to mention here is that this is the first molecule which has been introduced in India, and it has to be given thrice in a weekly doses. Usually we started with 100 mg thrice in a week, and that can be raised accordingly. But we have to be very, very cautious because there is still a paucity of data. We have to actually rule out if there's any proliferative diabetic retinopathy, first of all, before initiating that. We have to avoid in cases of malignancy. We have to avoid in cases with polycystic kidney disease. And it has also been associated with higher chances of hypertension, hyperkalemia, pulmonary hypertension. We have to be careful in these kind of the cases. And we have to be careful wherever there is liver dysfunction. And although the subset of the patient where we can give is quite less, but we maybe with the further data, we can actually have a further clarity on these kind of the molecules.
Also not to use in a patient where there is a proliferative diabetic retinopathy because it increases the EGF and it has been seen that that can be worsened. So these 4 or 5 things needs to be considered before you jump and start this oral ESA, or you can say the desidustat. Otherwise, there is a ease of administration. Thrice a week dose has to be taken in the night, 1 hour before and 2 hours after that. You don't have to eat anything. And the response rate they have found is equal to ESA. But with all if and buts, still it's a new molecule. We need more experience in that, and we need to choose our patients very rightly. And it has been seen in some patients that there can be increase in the malignancy or risk or something, but that has not to be proven up to mark. So you use it with caution. But yes, now there is alternative available, and I think thank you all for listening so calmly. And we try to make it only clinical, so there were no more slides. And if any question, we'll like to answer. All the panelists and me myself will definitely like to answer. Otherwise, let's conclude the session. So choose your patient rightly before jumping to ESA, rule out other defects, and then choose the ESA in a low dose and gradually increase it. And if your patient do not respond, please look for the other causes rather than increasing the doses to very high levels. That's how you should be manage the anemia in CKD, and it is very important to treat. Thank you. Thank you so much.
Thank you, Dr. Manoj. Thank you, chairpersons. May I request chairpersons to give memento to Dr. Manoj, and may I request Dr. Renu Agrawal, CDMO, to give memento to our chairpersons. And this is the last session before the lunch. Panel discussion journey of the original ARNI. For the next session, may I request Dr. Viveka Kumar, Principal Director and Chief of Cath Lab, Pan Max Cardiac Science. He is the moderator for the session, and panelists are Dr. Rahul Chandela. He is Associate Director, CTBS, Max Super Specialty Hospital, Saket. Dr. Gagandeep Chabda, Principal Consultant Nephrology, Max Super Specialty Hospital, Saket, and Dr. S.K. Mundra, Senior Consultant Physician, HOD, Department of Medicine, Saroj Hospital. And chairpersons are Dr. Sanjeev Agarwal, Dr. Sudesh Sehra, Dr. Devinder Sehra, and Dr. Vijay Arora.
Hello.
Good afternoon, friends. This is a cardiology session, and we are going to discuss about, I will not say new arrival, but this is a drug which has proved wonders in management of heart failure. So today I am going to discuss about the journey of original ARNI. The table of content is unmet need in heart failure management, the advent of paradigm HF trial. The results of paradigm HF trial were very encouraging. And the change in guidelines after decades, heart failure management was quite different a decade back. And now in last 5-6 years, there is a lot of change in heart failure management. And what are the further evidences do we have? And what is the cornerstone of guideline directed medical therapy? Many times we do not follow the guideline directed medical therapy in the management of our like heart failure. And what future lies with ARNI? Heart failure is a growing health problem with the unmet needs. You can see the heart failure with reduced ejection fraction. Despite the availability of several therapies established case in heart failure, the mortality rates remain very high. You see 5-year mortality. In heart failure, we talk of 5-year mortality. Like in cancer management, we always talk of mortality 5-year. What are the 5-year data, survival data? So here 5-year mortality is very high, 75%. And few patients with heart failure with reduced ejection fraction are treated with recommended doses of evidence-based therapies. In fact, most of the patients are not getting the recommended doses in heart failure management. And the proportion of patients receiving guideline-directed doses of ACE inhibitors or beta blockers is as low as 22% and 12%. Imagine, hardly 22% and 12% patients are getting beta blockers and ACE inhibitors in the recommended doses. Of course, heart failure, preserved ejection fraction, we do not have much options. Treatment is reliant on management of comorbidities and the symptoms, and moreover, cardiorenal syndrome, because there are no treatments have been identified which provide sufficient cardiovascular and renal protection. RAS inhibitors and diuretics can be beneficial, but can also worsen renal function. So ARNI has changed the face of heart failure management, the evolution of treatment of heart failure with reduced ejection fraction. You can see the trials, the different trials came in 1980 with vasodilators like hydrogen nitrate and ACE inhibitors. Then in 1990, many trials, CBS2, Merit, Copernicus, Rails, and Emphasis with beta blockers, mineral corticoid receptor antagonists. And then come the ICD and CRT devices with many trials. And 2010, then SIFT and Paradigm HF came later in 2014. And in 2020, SGLT2 inhibitors and other things came into the picture. So in 2014, sacubitril valsartan, the new class of drug comprising an angiotensin receptor and neprilysin inhibitor, ARNI, was tested against enalapril in heart failure with reduced ejection fraction patients. And this showed the new evidence for heart failure treatment with ARNI after a decade. This is the paradigm HF trial, and the rise of ARNI came through here. You can see the different trials and their year of publications of different trials. And the findings from paradigm HF confirm the importance of the natriuretic peptide pathway in heart failure with reduced ejection fraction. From ACE inhibitors or ARBs to ARNIs, this was a new paradigm shift in heart failure reduced ejection fraction therapy. The paradigm HF was a breakthrough trial showing ARNI superior to ACE inhibitors, using a completely novel approach to renin-angiotensin-aldosterone modulation based on neprilysin inhibition. Paradigm HF offers potential an agent which appears to have significantly beneficial action as compared to conventional therapies. And the addition of neprilysin inhibition to ARBs has been shown to be even more effective than ACE inhibitors alone in heart failure with reduced ejection fraction, marking an important milestone in heart failure management. So ARNI represents a more effective alternative to ACE inhibitors for patients for HFrEF. You can see the data, see the benefits in heart failure with reduced ejection fraction. It keeps patients out of hospital, reduces readmission rates, and helps them live longer. Here you can see very well 20% reduction you can see in the primary composite endpoint in patients who were treated with enalapril in comparison to sacubitril valsartan combination, and 20% reduction in cardiovascular death and 21% reduction in heart failure hospitalization was seen. The data is very impressive. And change in the guidelines after decades, you can see the guidelines. On your left, you can see the 2016 ESC, European Society of Cardiology guidelines for the diagnosis and treatment of acute and chronic heart failure. Here you can see the highlighted part, angiotensin receptor neprilysin inhibitor. This is came into the picture in the guidelines with the class of evidence class 1 and the level of evidence is 1B. Then came again in 2016 ACC, AHA and HFSA guidelines. This focused update on new pharmacological therapy for heart failure with reduced ejection fraction, and they also included ARNI in their guidelines. And then 2021 update on 2017 ACC expert consensus decision pathway. Again, they said answers to many of the questions which were till date unanswered. Because of the totality of data, direct to ARNI approach is now recommended even in de novo heart failure patients with reduced ejection fraction. Similarly, the guidelines with other bodies again came there, and they also included ARNI in place of ACE inhibitors or ARBs. Sacubitril valsartan improves the outcome across heart failure with reduced ejection fraction journey. You can see the Pioneer HF data again. The heart failure with reduced ejection fraction, 29% reduction in anti-proBNP levels, 34% reduction in the risk of mortality, and 44% reduction in the risk of heart failure rehospitalization. And on your right, you can see the transition study again showed that heart failure with reduced ejection fraction patients for acute decompensated heart failure, the progressive reduction in symptoms like edema and dyspnea on effort, and in both pre-discharge and post-discharge groups, you can see 11% reduction and incidence of time to first heart failure readmission. Sacubitril valsartan improves the outcome across the heart failure with reduced ejection fraction journey. This is the PROVE HF data. You can see the improvement in many of the echo parameters. Also, you can almost left atrial volume overload and left and diastolic volume index also was reduced. You can see very well. And evidence beyond reduced ejection fraction. In fact, heart failure with reduced ejection fraction, we know we have very encouraging data. But for patients with heart failure with preserved ejection fraction, these are the two trials, the Paramount HF and the Paragon HF trial with heart failure with preserved ejection fraction. Here also, they have shown some improvement with sacubitril valsartan. The anti-proBNP levels improve after 12 weeks, NYHA class at 36 weeks, and left atrial volume at 36 weeks. And there is a risk of hospitalization and cardiovascular death in Paragon HF trial, and the risk of readmission and cardiovascular death reduction also has been seen, and all-cause mortality also reduction is seen. And in India, the approval by DCGI was given for sacubitril/valsartan for congestive heart failure indication is now very clear in their recommendations. You can see the ARNI is the cornerstone of guideline-directed medical therapy for heart failure. You can see as the previous speaker has already alluded to regarding heart failure management with beta blocker, MRA, SGLT2 inhibitors, and on top of ARNI. So ARNI is still the first line for guideline-directed medical therapy. ARNI is preferred to RAS inhibitors alone, given because of the substantial mortality benefit, similar tolerability, and long-term cost effectiveness compared to ACE inhibitors or ARBs alone. ARNI is reshaping the modality of heart failure management. It is the first of its kind to be developed in addition to heart failure with reduced ejection fraction. It has shown significant efficacy in heart failure with preserved ejection fraction in similar studies. So ARNI remains the first line class 1 recommendation by ACC/AHA 2016 guidelines, and an update came in 2017 and recommended again as the first line choice by 2021 ACC and AHA update also. ACE inhibitors or ARBs alone, they lose focus because of the evidences which were seen in Paradigm HF. This is the pathophysiological mechanisms. I'll not go into the details because of shortage of time. And you can see the sacubitril/valsartan developed by Novartis offers an unmatched legacy of trust, 5 years of clinical experience, evaluated almost 230 clinical trials. Lot of patients, more than 3 lakh patients are already on this combination. 1,500 Indian patients were there in this global clinical trials, and the original and the imported ARNI is there for us to treat. And the future lies with ARNI. You can see the major ongoing sacubitril/valsartan registered studies. Lot of studies are already ongoing. So what the guidelines say, the guidelines recommended and approved for all heart failure with reduced ejection fraction patients. What do? They reverse cardiac remodeling, reduces risk of rehospitalization, and reduces mortality, improves quality of life, and they are superior to ACE inhibitors in all stages of heart failure with reduced ejection fraction. I think that's all from my side. Now I invite Dr. Viveka Kumar for conducting the panel discussions. Dr. Viveka, please.
Right. So I think that was a very nice lecture on introduction of ARNI and the journey of this molecule. So can we, so we'll be taking up the questions with different specialists. Dr. Rahul Chandra.
Or you can come here and conduct the session. It will be better.
Yeah, because I'll have to answer the questions.
Oh, simultaneously you can answer. No problem. No issues.
So let me come up there. Yeah.
वो आप अपना conduct कर लेंगे session में. Question answer है. Dr. Viveka Kumar. So questions आप बोले या मैं बोलूँ? जैसा आप बोलो. ठीक है. आप पहले करो. हाँ, आप बोल दो मैं आप ही बोलो.
Well, so I think first of all, I would like to know from Dr. Sarah and the chairpersons their perspective on this molecule, because it's been really a revolutionary molecule and has really shown the decrease in mortality on all types of heart failure. So over to Dr. Sarah, please.
Sir, I'll be talking as a physician because heart failure concept as such, treatment by a physician has been totally different. As physician, before this ARNI came into market, I was under the impression that heart failure is not that serious. But after reading about it, after knowing that the life expectancy has decreased so much, concentration towards treatment of heart failure should be much more than what a physician generally gives. Now, heart is basically an endocrine organ, and we do not discuss that much about it because atria secrete atrial natriuretic hormone, and ventricles secrete the hormone which is ventricular natriuretic hormone, which is called as BNP because it was initially diagnosed in brain of, I think, some animals, guinea pigs or so. Now, treatment of heart failure should include treatment of many things. Body is tricked into thinking that because perfusion is less, it is a case just like a case of shock. So RAS system is activated and neprolysin system is activated. And what we used to treat was giving diuretics, beta blocker for decreasing sympathetic activity, and giving, improving, acting upon RAS system. But it is just like a three-wheeler. We are not talking about the neprolysin activation. That is why the treatment of this heart failure was not that much, which we have come now. So most of the discussions of the cardiologists also, they have given very less importance on this. So our concentration should be that besides RAS activation action and besides diuretic, we should be concentrating also on neprolysin inhibition. And that is why all these studies have shown that this is a good drug. That is my viewpoint.
Dr. Sudhis, would you like to comment?
He is summarized beautifully, but the incidence of heart failure is increasing as diabetes is increasing day by day, and heart failure being one of the most common complications of diabetes. The incidence is increasing, and we are seeing around in our daily practices, the incidence of heart failure has increased. And as you said, around 1 to 2% of common people, general population has heart failure. And when I was a student, to give beta blockers to a patient was to offer heart failure was suicidal, because you could fail that examination. Because that time the concept was not of sympathetic stimulation in heart failure. Now the paradigm has shifted and we are going towards guideline-directed medical therapy. Dr. Nitin told us the 4 pillars of the cardiac failure, including MRAs, ARNI, and of course, after this paradigm heart failure, as you showed, that it is much superior to enalapril, which has been the hallmark of the ACE inhibitors. And of course, the guideline-directed management therapy, where the maximum tolerated doses of these medication are to be given as per the trials. And of course, we are much wiser after ARNI. So over to you, Dr. Viveka.
Yeah, now Dr. Viveka will elaborate on this.
Yeah, so I think that's a very interesting question. If you see that, both our chairpersons, Dr. Seras has said that there is a paradigm shift in managing the heart failure. But, the question is that before the era where the 4 pillars or, to start with, we had just ARNI to begin with, and we did not have any molecule before 2014. And then, how would you treat heart failure? So awareness was not there. People were, the average longevity, once you diagnose a heart failure, was not more than 50% would die within 5 years. It was much more serious than the cancer. So I would say that before 2000, before where we had nothing to offer significantly, only the ACE inhibitor would be given. As Dr. Sarah said, that it was a criminal offense to prescribe them beta blockers and all. So they were just based on diuretics. So we had to give them loop diuretics, we had to give them digitalis, that's it. So we did not have much to offer during that time, and that is why during that time the mortality was significantly higher. But if you look at the paradigm HF trial, that's a landmark trial, and that is why, as has also been nicely told in the previous lecture by my colleague, is that it's really made a sea change in managing the heart failure. So we have this molecule which not only improved the mortality of heart failure patient, but I would say that it did extra mile, it went extra mile ahead, and it created an awareness about heart failure. So the awareness, as the society is aware about it, as the physicians are aware about it, so your pickup rate goes up and you can salvage these patients. So, initially people did not know before the ARNI came that is there any, increased mortality by repeated hospitalization. Now we know that each hospitalization will add, adverse to the adverse prognosis of these patients. So definitely paradigm HF changed the whole scenario about the heart failure management, and accordingly we manage these patients. So the next question is that with the advent of ARNI, how has heart failure management changed? I think it's basically the same thing which we are saying, that apart from awareness, we had more studies and data about heart failure. Then we started studying about different type of heart failures, more importantly, heart failure with reduced ejection fraction. People did not have an idea that if the ejection fraction is normal, how can a person go in heart failure? So we started differentiating between heart rate failure with reduced ejection fraction, heart failure with mid-range ejection fraction, and also heart failure with preserved ejection fraction. So HFpEF, HFrEF, and mid-range ejection fraction, and all of them have got very severe bad prognosis. People did not believe that heart failure with preserved ejection fraction would have similar bad outcomes as compared to the reduced ejection fraction. People would say that, you know, if the heart failure is preserved ejection fraction is normal, then why should these people would die? Why would they? So, but you know, now the data suggests that preserved ejection fraction heart failure is also equally bad, and the prognosis is not good. So let's go to our nephrologist friend, Dr. Gagandeep Chawda, who works with us in Max Saket, and I'll ask Dr. Gagandeep that how has RAS inhibition impacted the treatment of renal dysfunction in heart failure patients?
So it's a pleasure to be here with among all of you. So as we already know that RAS inhibition plays the main role here, along with the increase in the natriuretic peptides. So once you increase the peptides, then there's a possibility of aldosterone going very high. So if the aldosterone going high, it creates the same problem again. The basics of the heart failure is that you have to throw the water out, you have to throw the sodium out. So basically what we are trying to do by suppressing the this neprilysin, or by increasing the peptides, and also by suppressing this RAS system, is to throw more water out, to throw more sodium out. That is natriuresis, as well as decreasing the water retention. So that's the purpose. Similarly, the RAS inhibition is important for that. Also, the RAS inhibition positive effects are known for the decreasing the preload in the heart, as well as the effects on the afterload. So RAS inhibition was the cornerstone, starting with the ACE. But I just want to add one thing here. If you are switching from an ACE to an ARNI, just wait for 36 to at least 48 hours because of the effects of bradykinin. ARB to ARNI can easily be done.
Yeah, so I think still we see that initially to begin with, we felt that, you know, ARNI would increase the, creatinine and worsen the renal function. And a lot of physicians and cardiologists also were wary of this fact that probably the patients would land up in renal failure. Now we see that the nephrologists are also a great proponent of ARNI. So, so what is the optimum way to use ARNI in worsening renal function? And because we know that because the cardiorenal syndrome, a lot of patients with heart failure would have renal dysfunction. So what is your approach, Dr. Gagandeep?
So the interesting point was the cutoff of 30. Actually, 30 came because, CKD stage 3, 3A, 3B ended with 30, and the CKD stage 4 started after 30. So everybody was saying 30, 30, less than 30 ml per hour GFR is safe. Yes, definitely less than 30 ml per GFR. Everybody knows that it's a safe zone. You can easily start and monitor the both ACE-ARBs as well as the ARNIs because of the recent ARNI first guide. AC, this American cardiology as well as European cardiology saying ARNI first. So 30 is a magic figure here. But if you go beyond 30, you see there was a trial which ejection fraction as low as 20. So if you can study this, you understand that once you add a patient on ARNI, sometimes what happens, the GFR starts improving because the cardiac function starts improving. So if the GFR starts improving, you actually have a better renal function because the cardiac output has increased. And this adds to the positive effect. So from what I would say, as far as the clinical experience and theoretically being safe, yes, 20, you can go ahead, but be very watchful between a GFR of 20 and 30. Now, there are certain interesting studies which have been done. And I would like to add a point here, taking 1 minute extra of yours, was what to do with the CKD stage 4 and CKD stage 5 and CKD stage 5D. 5D means once on dialysis. Now, 4 studies have shown to have benefits in the cardiovascular mortality as well as the MACE endpoints. But the problem was that these patients went to a dialysis a little faster, but they were saved from the cardiac mortality.
as well as the events, cardiac events. So that was the added advantage, but the problem was going to the dialysis faster. Then CKD stage 5, everybody is scared. Even I am scared to add any ACRB or ARNI at that point. But 5D is again a very interesting population because here you are already on dialysis and you could actually save your patients from the cardiovascular mortality on 5D. So studies have been coming up in which they have shown that these molecules are okay, no extra hyperkalemias, and have been showing benefits in the patients of CKD 5D, but it's not in the guidelines still. The studies are there. So for the time being, 20 to 30, be cautious, and above 30, as we all know, we can use it easily.
Yeah, so I think that's right, that the envelope has been pushed further for the uses of ARNI in this indication.
So
but
before that, I would like to ask or add something. Like he said, in stage 4, when the eGFR is less than 30, it is easier said than done. Because you see that initially the eGFR goes down and you are subjecting a patient from going from stage 3 to stage 4, maybe from stage 4 to stage 5. So at what levels of creatinine? Because the conventional treatment is that if eGFR goes down by 20 to 30%, then you stop. Or if your creatinine level rises more than 20 to 30% from the baseline, I'm not talking of potassium, which is a well-known. So at what level should you observe and say, no, now it is not the time, I have to stop ARNI or ACE inhibitor?
So the answer lies, sir, to the point, who is scared? Either the physician or the patient. If the physician is not scared, I think you can just watch it. After a week's time, it will increase by some amount, we all know. But if it stabilizes after that and the patient doesn't have a side effects of a hyperkalemia and other side effects, you can just watch. Yes, if it goes beyond that value of 30% rise, and you see that, yes, another value after a week's interval has shown further increase, definitely we are scared, patient is scared, then you can stop, and it's a reversible effect. Most of the time it will reverse back. And then, sir, there's an important point, there are other factors playing a role in that, because most of these patients are on diuretics. So if you see that there are on multiple molecules, SGLT2 inhibitors are coming in a long, very aggressive way in treating these patients. Those have diuresis effects. These patients are on diator, diuretics, torsemide, all this stuff is there. So those can be the ones which could actually be causing the rise in creatinine rather than your ARNI. So first, address the hydration status. Look for the other factors which could have contributed to the ARNI. Is there a MRA sitting aside which is causing the hyperkalemia? Is there a diuretic which is causing the rise of the creatinine? Withdraw those. Get the patient in a euvolemic space and then withdraw ARNI, because this molecule is important.
So
yeah, so I think a word about potassium
Just
also.
what I practically do in borderline cases where you and me, whoso is scared, I start with only 50 milligram of this Vimada and give it for about 4 or 5 days and look for GFR. If it starts improving, I continue. If it starts decreasing, I just give a test dose or a challenge dose as a physician.
So rightly said, sir, as per the guidelines, the GFR below 30, you start with 50 BD, but practically speaking, I have even started with 1/4 of a dose. Half of a tablet, 50 BD, we have started with, and we have monitored weekly intervals, the creatinine values and the potassium values, kept the patient, try and avoid the diuretics if possible. Creatinine will come down at its place. And sometimes you see there's an improvement also. So fully agreed, lower dose is the key point here, and monitoring is the second key point. As well as the hyperkalemia is concerned, Dr. Veka just asked, yes, you watch for the potassium, a figure of 5.5 must arrange, put an alarm in your settings. Yes, this is now 5.5. We have to reduce the dose if it is on the higher side. Watch it again. Then there's a concept that, yes, the other molecules which are adding to it, maybe it's an aldosterone antagonist which is going on. You watch that. Try and withdraw that if possible. Keep him only on the ARNI. And then new concepts, I would add one more thing, that people are now using potassium binders along with, these molecules. That concept is not theoretically as per guidelines still, but there have been trials which are going on with the safer potassium binders along with the ACE-ARBs. Maybe that's the future.
One more thing I would like to add, as a physician, most of these patients are diabetics, and somehow many doctors, many physicians keep on giving DPP-4 inhibitors. DPP-4 inhibitors are known to decrease glucagon levels, and glucagon is very helpful in treating heart failure. In 1970s, when there were not much drugs, we used to get subcutaneous glucagon for improvement of heart failure. And later by on-glycer has gone into disrepute. One of the things which should be done, whether you talk of this SGLT2 is different. Stop and do not give DPP-4 inhibitors to ICU patients. That is my point.
Thank you. Thank you for those comments. I must congratulate Dr. Viveka and Dr. Gagandeep also for such a interesting discussion, and Dr. Sehra, Dr. Devender, and Dr. Sudhish Sehra also.
So before you wind up, I have a question. The newer molecule vericiguat has come. Where do you keep it in the armamentarium of 4 pillars? Is it the fifth pillar? So when should you add vericiguat in the management of heart failure?
Yeah, so as of now, vericiguat is not yet the 5th pillar. It's been indicated for worsening heart failure. So if the patient's being on the optimal medical therapy is still heart failure worsening, meaning thereby that he's needing more diuretics, more repeated hospitalization, then the vericiguat has clearly shown that it improves the outcome. So I think there is 2 important large trials going on, and the results are expected to be in March will be announced in ACC meeting, and probably then it will become the 5th pillar. But as of now, we have only 4 pillars.
Thank you. Thank you for those comments. Thank you. Please join us on your right side of the dais for felicitation ceremony. Dr. Viveka, please.
Chairpersons, please honor Dr. Viveka and Dr. Mundra to honor chairpersons. There's a few announcements. One announcement, there's going to be quiz poster presentation award ceremony, and I invite Dr. Anil Gombar and Dr. Rajiv Gupta to please conduct this. After that, I invite, what after that I will tell you.
Well, thank you, Dr. Jha. See, this time we introduce a new activity, which was poster presentation by postgraduate students. And we had 5 participants, e-posters. Huh?
We had 7.
We had 7, 2 didn't make it. And the criteria for judging the posters were relevance to the topic, content of the poster, presentation style, adherence, and finally discussion. We have eminent judges, and the final results.
Before that, we had 2 judges, including us. We both were there on the this poster presentation. Dr. Richa Dewan, I'm thankful to Dr. Richa Dewan. I'm thankful to Dr. Mukesh Bhatia. Thank you for my chairperson here, Dr. Rajiv Gupta, and myself, that we decided for few names which are coming as first, second, third for NDPF poster presentation. This is a first very interesting posters presentations were done. All were very charged buddies, and I would like to invite as the first paper poster presentation to
the first prize goes to Ishan Aneja.
Ishan Aneja.
Now, with this certificate of the certificate, we are also
Give him a big hand.
We are giving monetary incentive so that they continue to do better. Mr. Ishan, are you here?
Is he there? Ishan Aneja. Or he can collect the...
You can collect it later.
Later.
Second,
okay. The second prize goes to...
Himanshi, Dr. Himanshi. She gets the second prize. Excellent poster and excellent way of presenting.
No.
She gets a check of 3,100. These are young doctors. They must be congratulated and they must be encouraged. Kindly give them a good hand. The third prize goes to Dr. Prabhat Vashne. Prabhat Vashne.
Prabhat Vashne.
Prabhat
Vashne.
Prabhat Vashne.
ये दे दो तुम आओ आ गया
Now
All
there are
the
two
participants have done
participants.
very well, and I appreciate this new poster presentations to NDPF midterm hybrid conference. So I would like to give all the certificates to all the participants. Please collect your participant certificates of poster presentation by everybody from the organizer.
Adish is coming. Adish is coming.
They can come up. Whosoever has done a poster presentation to us, please come.
We are all invited for the lunch. I will be back in another half an hour. That is about 2:35. 2:35 will be. At 2:35, we are going to assemble again. Thank you. आवाज आवाज Attention, please. In another 5 minutes, we're going to start the session, post-lunch session. So please finish up your lunch as early as possible. And after 5 minutes, lunch will be served outside, not inside the hall. So please do it fast. बढ़िया बढ़िया So should we start now? यार बीच बंद क्यों कर देता है यार? Hello? Hello? Where's the photographer, please? Photographer, please. So welcome on the post-lunch session, and this is the neurology session. And the topic is clinical approach to a case of headache in OPD. And the moderator is Dr. Manoj Khanal. He is the director and senior consultant, Max Shalimar Bagh. And we have got chairpersons come panelists, Dr. Rajiv Anand. Dr. Rajiv Anand, please. Dr. Rajiv Anand is very senior neurophysician. He is presently director and head neurology at BLK Max. Then Dr. Jaideep Bansal. Jaideep Bansal, very senior neurologist, is well known in this area and among the neurologists. He is presently senior consultant and head neurology at Fortis Shalimar Bagh as well as Saroj Superspecialty Hospital. Then I've got Dr. Sandeep Miglani. He is the director, the Health Services Delhi, Dr. Miglani. And Dr. B.B. Rewari. He's on the way, he's coming, he'll be joining. And concluding remarks will be by Dr. Manmohan Mehdi Ratta. He's a senior neurologist at BLK Max. He has been head of department of neurology at GV Pant Hospital. Dr. Mehdi Ratta. Now I request the chairpersons to introduce the speaker and the topic and start the proceedings. Thank you.
Excuse me. जो पीछे खाना खा रहे हैं, प्लीज खाना बाहर कर दिया है, अपना खाने थाली के लेके आप बाहर जा सकते हैं, प्लीज. हाँ, थैंक यू वेरी मच.
Dr. Manoj, I think you are supposed to moderate the session. And I invite Dr. Manoj, who is the moderator and a well-known local authority on neurology. He is in Max Shalimar Bagh. And I have known him for many years. And he's a young, enthusiastic person who is going to take us in next 25 minutes through a journey into how to approach headache. Manoj.
Thank you, sir. So I would like to thank the organizers. So good afternoon, friends, colleagues, seniors, ladies and gentlemen. I would like to first of all thank the organizers that they have made a session which is very interesting, because it is very rare to find lot of neurologists on the same dais, particularly senior neurologists like Dr. Rajiv Anand, Dr. Mehdi Ratta, and Dr. Jaideep Bansal, including senior physician like Dr. Miglani. So before going into the details, friends, we know that headache is a very common symptom of not only in clinical practice, but since MBBS days, even in MBBS days when we used to go for rounds, our seniors used to, and our professors used to tell us, so we used to just say, sir, isko headache hai. So headache is such a common symptom that it can be a manifestation of disease. Gradually, as I did my MD and then my DM, I came to know that headache is also a neurological disorder. So we should not neglect any patient who has presented to us with headache. Headache can be even deadly to a patient if it is some sinister cause, or it can be a manifestation of lot of neurological disorders, including medicinal problems also. So I would like to start with a simple case which presented to me in the OPD, a 53-year-old female who had comorbidities like diabetes, hypertension, hypothyroidism on treatment, which is very common nowadays. Her presenting symptoms were headache left-sided hemicranial, sometimes mixed, throbbing, dull ache, continuous. Sometimes the patient will confuse you. They will tell you that कभी throbbing होता है, कभी holocranial होता है, कभी अजीब type सा सिर दर्द लगती है. So every history is very important. In clinical medicine, including neurology, the most important part is history. So whatever patient tells you, just scribble down, just write it down. Later on, you analyze whether this fits into your history or not. That is very important. Orbital, sometimes occipital pain, associated features were there like nausea, photophobia, phonophobia, and occasional neck pain, which was there for last 5-6 months. And since last 2-3 days, why she came to the OPD, neurology OPD, because it has started to happen on the right side also, right side hemicranial. So when you get this sort of rough history, what are the possibilities, clinical possibilities that come to your mind? So my first question will be to Dr. Rajiv Anand. If with this simple history, rough history, if the patient presents to you, what are the clinical possibilities, say 1 to first and second? What are the clinical possibilities you will think about? On OPD basis, looking at just rough history.
So a job sitting in OPD is, as Manoj has told.
Sir, you are not audible, sir.
A job sitting in the OPD is to first ascertain the cause of headache, whether this cause is sinister cause or a primary headache. And so we have to see what is the emergency. So I will go one by one. I can't, so you have already written the causes.
No.
So at 53, I will be if the patient has 53 years of age and approaching to me, even with hemicranial headache, with orbital, occipital, I am very much inclined to rule out a secondary headache.
Sir, you are not audible. I think your mic.
My mic is on.
Volume.
Hello, can you hear me? So let's go with everything. Patient is 53 years, female patient. She is type 2 diabetic, hypertensive, hypothyroidism. And if it is a new onset of headache in 53 years old female, then the first I think of a secondary headache. I don't think of a primary headache. Because when we are taught about headache, any headache above 50 years of age, you need to think of secondary causes. And she has also got, you have written all hemicranial. So it has shifted side also. So for me, it is a patient whom I'll examine in detail. I'll not think of migraine. I'm not thinking of TAC. These are the two primary headache you think of. I am thinking of a secondary cause. And I
what secondary cause, sir?
So if you have a shifting headache from one side of the hemicranium to the other side of the hemicranium, I am thinking of a retroorbital pathology which can go to other side. So I'll immediately go for a imaging study. It's not a primary headache. And I want to know more information, fever, neck stiffness, proceeding, and does her diabetes is controlled. Many of my colleagues during COVID time had mucor presenting like this.
Yes.
So it's a good enough history for me to investigate the patient further for a secondary cause of headache. So if it has gone from one side to other side, I want to see the brain.
So your first possibility is that of a secondary headache. So Dr. Jaideep Bansal, your take on it?
This is absolutely right. Otherwise, history, if we ignore the age, if we don't see the age, it is a typical history of 5 months.
Comorbidities, is there any role of comorbidities like diabetes, hypertension?
Yeah, definitely there is there. And as the age is 53, the secondary causes is to be ruled out, just like means any structural lesion or the fungal, the mucormycosis or the posterior fossa mass and the meningitis. And as the patient is also having diabetes, sometimes the meningitis and the fungal infections, they are quite commonly seen when particularly in COVID scenario. And if we see this patient is 30 years of age and no either the comorbidity is there or not, then the migraine or primary headache is to be thought first. But definitely with the hemicranial type of headache, the imaging is to be done. And if the patient is more than
50 plus, then temporal arteries is also one of the possibilities. Usually it is 60 plus, but after 50, you should keep the possibility of that also.
So I would like to ask Dr. Miglani, what is the take on, say, medical, non-neurological causes of headache?
Basically, in this case and this very age, like in addition, hypertension itself can cause headache. And otherwise, secondary causes, though not at this very age, like pheocytochroma, that comparatively in the younger age is usually detective. In this case, diabetes is also there. Drug induced can also be there in certain drugs, which can cause, like especially antibiotic quinolones or even antidepressant. But in addition to this, at this very age, like in this case, photophobia is there. So like glaucoma should be ruled out. Basically, like sometimes patient clear, like colored halos, orbital pain, conjunctival congestion can be there both in hypertension and in like migraine and also in glaucoma. So at least refractive errors and secondary intraocular tension, convergence insufficiency at 53 may not be relevant, though people are using mobile nowadays for a lot of hours.
So let's proceed with the case. So simple clinical possibilities as we are discussing now. So when we see a history of which is more likely to be a chronic cause of headache, because more than 3 months duration has passed, the patient has now started having symptom also on the right side of the right hemicranial headache. So first, when we see such a patient, what are the possibilities? So when we see in OPD basis, a stable patient who has no other symptoms, no fever, no weight loss, no other cranial nerve symptoms, no transient visual obscurations. We look for long track signs, no sensory loss, no history of loss of consciousness. So there is only simple history of headache. As
Manoj,
rightly,
can I? So you are slightly unfair to the panelist.
No,
You
no,
should
I
have
will-
given these symptoms before. So this
I'm
is
going to again.
no. So this is, you should have given the first history and these symptoms before. So these are the very symptoms I asked you.
That is why I hide it from you, because if I give this symptom, you will straightforward go to a diagnosis. But why it is important? That is what clinical neurology is important. From the history itself, we can make out that there is something sinister going on. It is not a primary type of headache. It has to be secondary headache. Whatever examination findings you may get, sometimes we are misguided by examination findings. We may not get any fever. We may not get any other ancillary symptoms other than headache. General examination, there was no pallor, there was no lymphadenopathy, no hepatosplenomegaly, but there was mild parotid swelling. So it is very important in a patient with headache to look for swelling, either in the parotid gland, submandibular gland, because this way can help us to reaching a diagnosis. The neurological examination, the higher mental function, speech was normal. Cranial nerve was normal, fundus examination was normal, the motor system was normal, the sensory system showed only posterior column impairment, which may be because of diabetes. There were no meningeal signs, and the reflexes were showing ankle jerks bilaterally absent, which can be again because of long-standing diabetes. Now, sir, what is your possibility? Dr. Rajiv Anand, sir. After I have given you a hint, now what will be your possibility?
So the only clue you are giving is a parotid swelling. Otherwise, it is fitting into primary headache. And with parotid swelling.
Will you change your diagnosis? Because you were right that a patient with diabetes, hypertension has presented to us with a classical history which appears to be a secondary headache because it has spread to the right side also. If 5 months the patient has suffered, that means the patient has gone to a lot of doctors or physicians. He might have taken a lot of painkillers or other medicines also. So in a way, from clinical history, you were right. So after looking into the examination points, will you change your diagnosis from secondary headache to primary
There is only
headache?
one clue you are giving in examination, but I will still not rule it out to be secondary headache until unless I do a imaging study. If patient 50 years.
So
plus-
indirectly, I mean to say, sir, in this case, is MRI mandatory or not?
100%.
100%. That is.
And some autoimmune studies also in view of
Yes.
parotid swelling. So when you are
So
talking of
Dr.
parotid, I'll
Mendiratta,
do
sir-
A's and I'll do other levels also.
Mendiratta, sir, wants to add something?
Manoj, when we are seeing, I'll give a concluding remark, we must see the neighborhood area. One of the neighborhood area is the gland, which you have said. So we have to see ENT, eye, dental also. In this case, it may not apply. Second, you have given the examination, but you have not told us about exocular movements and fundoscopy.
Fundoscopy is normal, sir.
Fundus, because it's very, was it
Radial
seen by
lung is normal.
ophthalmologist also? Okay.
So the patient was treated outside as primary headache. And most commonly what we do, any patient, any lady presents to us with headache, we treat as a migraine and started on treatment, but no response was done. And contrast CT was showing a normal study. Now this type of patient, what happens when they come to the OPD, they always say we have some form of insurance. So sir, please admit us. We have been suffering for last 5 months. So we did an MRI contrast of the brain, as rightly said by Dr. Anand, to rule out secondary causes of headache. I have given just to the point only. So on MRI images, what we see, I have given only 3 images I could get. This was showing an abnormal subdural signal along the left cerebral convexity with a smooth, thick pachymeningeal enhancement. And in the paracerebellar region also, there was a thick pachymeningeal enhancement. I discussed with the radiologists. They said that this might be possibly what is known as hypertrophic pachymeningitis. So one of the cause, as you rightly said, so most important thing is the clue lies in the history. Sometimes even general examination, neurological examination, even ophthalmological examination, as said by Mendiratta sir, may not show anything. So we did a CSF analysis of the patient.
Dr. Manoj, one history is very important. Nasal discharge was there or not? CSF leak?
No, there was no
That
history
is,
of any.
that is also very important.
Yes, that when we did look out for any causes, we did that. And CSF was aseptic. Now, when we see such a picture, what are the possibilities? Dr. Jaideep Bansal, you will look into. What are the basic causes when we look a patient who appears to be aseptic, has a hypertrophic pachymeningitis, a chronic type of meningitis? What are the things you normally look for?
Again, this is one is the idiopathic hypertrophic pachymeningitis, and second is
No,
the very
before
important.
terming somebody as idiopathic, you have
Before
to look for the
before
other
that,
causes.
we would just like to rule out the CSF leak also. That is also hypertension.
There is no history of CSF leak.
That also is to be seen as cysternography maybe needed.
And the patient was not toxic. The patient was completely aseptic. So what will be your, before declaring somebody as idiopathic hypertrophic pachymeningitis?
The vascular profile is to be done, and all the vascular profile can also SLE and rheumatoid arthritis, and these are the
So
things which
we need to rule out vasculitis, sarcoidosis, even tuberculosis. Tuberculosis, fungal, as was discussed, some viral, malignant, and lymphomatous meningitis. So these are the all possibilities you need to rule out. Once you have ruled out, the final diagnosis is, you call it as a idiopathic hypertrophic pachymeningitis. But I want to tell you something. Whenever you say idiopathic, then you have to think about some rare causes. And one of the rare causes of meningitis is IgG4 disease or IgG4 associated hypertrophic pachymeningitis. I then reviewed the literature because I have seen only IgG4 disease in last 11 in PG. I have seen 2 patients, and here I have seen only 2 patients. So I wanted to review the literature whether there is any something like hypertrophic pachymeningitis only involving the meninges, which is not involving any other organs. So IgG4 related disease is basically an immune mediated disease like rheumatoid arthritis and SLE. It is basically because of dysregulated autoimmune system, most commonly presents in the middle age to elderly, and male are more commonly affected. Multiple organs can be affected. So most commonly they present to rheumatologist, with involvement of say different systems. Say pancreas is involved, then they will present to the surgeon. Bile ducts, lacrimal gland, major salivary glands, lung, kidney. In this case, only the meninges were involved. Then I did a CT chest, abdomen. We even did a PET scan of the whole body PET scan, but we didn't find any other involvement other than the meningeal involvement. So then I saw that what is the possibility? Because in this patient, around 20 times elevation of IgG4 was there. No other cause could be found. When I reviewed the literature, active disease can happen even with no signs and symptoms for even months to years before diagnosis is made. And diagnosis is usually before serious multiple organ damage. And in this patient usually responds well to treatment. The most important thing is that early detection is important. The most important thing is that recognized first in Japan, and they presented cases like sclerosing autoimmune pancreatitis with multiple organ involvement. One or more organs are affected, and depending upon the organs that can be affected, like in this patient meninges, the early detection. But one thing was worrisome, that this patient did not have any cranial nerve involvement. The fundus was normal. So that was the thing that was worrying us. But otherwise, there was no other cause. Orbits can be involved. Lacrimal glands and major salivary glands can be involved. Thyroid gland can involve. The patient may present with Riddle's thyroiditis, lung allergies in the form of shortness of breath, and even silent disease in the aorta can be involved. And aortic aneurysm surgery or during hydronephrosis presenting to urologists, this can be even silent disease in kidney patients and misdiagnosed as renal cell carcinoma. One thing for diabetologists is that one of the cause, very rare cause, that the patient may have endocrine failure and present with diabetes, exocrine failure with substantial weight loss. So one possibility which I want to give is that of an IgG4 disease, which is very rare otherwise. So clinical findings which gives a clue, that small, that parotid gland swelling, which later on retrospectively, which if we think might be one clue, elevated serum IgG levels. There was no sausage shaped pancreas, and biopsy of organs is required. So correct diagnosis is only by diagnosis of exclusion. And what we do is we give steroid pulse therapy, but 40% can have relapse despite steroids. Role of DMRDs are not clear. I saw one study from Japan in which they gave rituximab. There are now upcoming studies in rheumatology journal also, where they gave rituximab was a very good option in those patients. But in our index patient, there was only meningeal involvement. I don't know whether in future she will have other organs may be involved, but right now, and the salivary, the parotid gland was mild swelling, and solomedrol pulse we gave, and the patient was kept for regular follow-up. So this type of patient sometimes require multiple disciplinary approach, and we should look for fresh symptoms and potential complication of disease and disease recurrence. And most important thing is that when we think about rare possibilities, we have to rule out all common possibilities, fungal, tubercular, as rightly said by Dr. Rajiv Anand, the other secondary causes, everything you need to rule out. So when we think about a rare possibility, there is always a chance that you are wrong. There is more possibility that you are wrong. So you have to rule out all common possibilities in a scenario in Asian countries like India. You have to rule out all infective etiology, all vasculitis, sarcoidosis, tuberculosis, whatever fungal, you have to rule out everything, then only think about a rare possibility. And when we think about rare possibility, always review the literature. Whether in literature there is some patient who has presented to similar symptoms or not. I would like to ask Dr. Mendiratta to have his concluding remark.
Was HIV done or not?
Yes, HIV was negative.
And
So we have ruled out all other possibilities.
it was a chance detection of IgG4 or it was thought of?
When we saw that we didn't find any cause.
Okay.
So in cases of idiopathic hypertrophic pachymeningitis, when I reviewed the literature, in 2 patients I have detected last 11 years. I've sent a lot of patients who presented with hypertrophic pachymeningitis, but these were the only 2 patients who, this was one, and another I am following up the patient, but right now she does not have any relapse. She's on 5 mg dose of solomedrol for last 3 years. But whenever I give her any form of DMRD, she was not ready for rituximab therapy. So I think that whenever you think about some rare possibilities, sir, there is always a chance that you might be wrong. So best way is the guidance can be from review of literature only.
So, one of the thing is blood dyscrasia. Sometimes lymphomatosis is also one of the causes.
We took a hematologist opinion also.
Yeah.
Before, so they said there is no
Leukemias and lymphomas.
Yes,
they
yes.
can also
They
cause.
have ruled out
Bone
that.
marrow.
We did a whole body PET scan also in the patient.
The bone marrow is also one of the.
No, they
modalities.
said that right now they don't have any.
The
this
mature
sort of
cells or
features.
other things.
Yes.
The peripheral smear is also very informative of that.
Yes.
That is a very simple test and that gives us some clue regarding the
Peripheral
breast.
smear was done. That was
That was normal.
That was normal.
Good.
It's very interesting case and congratulate Manoj for presenting this rare. These days in neurology, 2 aspects IgG4 and autoimmune component, autoimmune encephalitis in particular, one must keep in mind when dealing with the odd cases. Can you close this? I'll take care rest. Don't control from remote. I'll take care here. So wish to thank Dr. Chabda for giving me an opportunity to give the concluding remarks with my colleagues on the dais. Can somebody help me? This is not opening. Can audiovisual people help me here? It's not opening from here. Yeah. Okay, second one, second. Yeah, this one. Thank you. So headache is really a troublesome problem in the outpatient. Can you maximize? Thank you. This was I did moderate a session when President of Royal College of Physicians, Glasgow, was in India Habitat Center. He was chairing that session. And it was in 2003. So I dug out those slides. These are still valid, except two recent videos I have added of my patient, which are also 2006. So headache is a unique syndrome in medicine, as has been presented in this case, not easy to reach. 3 cases of pachymeningitis have been reported from PGI Chandigarh by Dr. Prabhakar, but at that time those were labeled as idiopathic because maybe IgG4 was not available. Rest all causes were ruled out. And this has been termed the most common medical complaint of civilized people. Yet severe headache is only infrequently caused by organic disease, as amply highlighted by my colleagues, Dr. Rajiv Anand, Dr. Jaideep Bansal, Dr. Miglani, and Dr. Manoj. Now, 90% of men and 95% of women have unprovoked headaches. This was a provoked headache. And universal experience with 1 year period prevalence of 90% and lifetime prevalence 99%. As Mahatma Buddha said, go to a home where there had been no mortality in the family. Can anybody raise hand that he never experienced headache in life? Is very, very unlikely. Small gathering or large gatherings. Now, gold standard in the evaluation of headache, as Dr. Rajiv also mentioned that we want to know more about it, is history. And I experienced myself when we ask the patient, sometimes it may be so difficult. Headache, आपको कब से है? सरदर्द कब से है? ये हेडेक बहुत साल से है. कितने साल से है? जब पप्पू पैदा हुआ था. पप्पू कब पैदा हुआ था? होली वाले दिन पैदा हुआ था. वो होली कौन से साल में थी? That will never be told. So these are the situations where really taking history of headache causes headache in the physician. I'll tell you how, if this works. Not working. Yeah. Can you give me audios, please, sir? I have asked for audio jack. Audio people, can you put the jack? Jack is here, but. So she was not specific about headache. You ask headache, she will tell, I have vertigo. Thank you so much. I'll show just 30-second 2 videos, but these are very informative in my opinion. This was also recorded in 2003. Volume, please. Volume. Here it is almost 57%. Can you increase the volume? So these are the 2 videos. One I will show where doctor had to really exert very heavy to take out the history. And second is doctor had been too sophisticated to ask the history, and doctor should ask the history in a very layman term. Not working. I've asked before, even at around 1:30, I asked for this. Anyhow,
थोड़ा वॉल्यूम बढ़ा दीजिए।
क्या लगता है बड़ा बन रहा है?
अब भी दर्द हो रहा है। अब भी दर्द हो
मन कैसा है?
वो तो अब तक ठीक से
Look at her face, mask
can
like
see.
faces, no expressions. She looks little low mood.
मन चाट तो नहीं रहता?
नहीं चाट तो नहीं होता।
तो कुछ आप कह रहे थे, क्या तकलीफ है आपको उसको बताओ।
Okay, I'll go to the next. Now, history taking doctor, whosoever is doctor taking the history, whether MBBS level, MD level or DM, should use simple layman language. This is very interesting. She came from
Yes, please tell me about your complaints
Kashmir.
regarding
Siddharth,
headache.
our resident, is asking the history.
मेरा headache एक साथ start हो गया।
As I was saying, neighborhood area, she had been to eye, she had been to ENT, and then she was referred to neurology from Lok Naik Hospital in GB
And
Pan.
it's that bad. I can feel that something will burst. And in a week it comes twice and it lasts for 2 weeks. And I feel very pukish at that time.
Classical migraine was being treated for sinusitis, can happen.
Is it associated with nausea or vomiting? Yes, always?
Yeah. always.
How it is get relieved then?
Then I take painkillers, double dosage.
What sort of headache is like? It is throbbing or a constricting type?
Constructive.
Look at the constricting type
Constricting,
word,
like
she doesn't know.
I
Why? She thought construction doctor is talking about. Patient will not know what is constricting type. So we should use simple language. As we asked, the history should be in patient word. It's done. Differential diagnosis headache is one of the longest in medicine and more with more than different causes. Although most headaches are benign, 95%, and still poorly understood origin, like even migraine, some secondary headaches may have serious underlying causes. See, these are the various you should ask the history. I will not go in detail. Time will not permit. Diagnosis, most of it has been discussed. Nonetheless, headache may be the presenting complaint in catastrophic illness. This was not catastrophic, but secondary cause, such as brain tumor, or this is one of the. Now, this may be hypertensive. This may be AVM. This may be traumatic. So one should keep in mind, and there's marked midline shift. Now, one of my residents, when he took the history, this was a gentleman who used to come to me. He had migrainous headache, and whole family was disturbed. Now, wife had chronic tension headache because of husband's migrainous headache. They were so frequent, the loss of man days, just 30 seconds. Then the daughter had migraine, classical history. Now the son has got headache for 2 years. My resident, I'll not name, Dr. K, saw the patient, came to me, sir, this patient also probably has migraine. There's strong family history of migraine. I said, how come? Have you seen fundus? No, sir. Have you taken the blood pressure? No, sir. These two must be done in each and every patient of headache. Look at this. I saw the fundus, took the picture. There was papilledema, frank papilledema. And this was a craniopharyngioma in this child. So should not be in a hurry. We have to devote time. This is the last concluding slide, which I said I made in 2003 and still valid. History is still of paramount importance, even this era of e-medicine. Careful and detailed examination needs to be supplemented with investigation. Not that we should rush for all the investigation possible on this earth. A bag full of, or few bags full of black films and printouts can only rarely replace a good clinical diagnosis. Thank you so much for the kind attention.
Thank you, sir. So, after this interesting topic, I think the audience would have got hold of the subject, that is headache is not only headache. It is headache of not only the physician, but also neurologists, neurosurgeons. Lot of multidisciplinary approach also is important. In this era of COVID, where lot of us used to do video consultation. In this era, one thing has to be kept in mind, that short history, even on video consultation also, if we think about secondary cause, always do an MRI brain. So at the end, I would like to thank in the dais, Dr. Rajiv Anand, Dr. Mendiratta sir, Dr. Jaideep Bansal, Dr. Sadim Milani, Dr. V.V. Revari, and the audience who had a very patient hearing. Thank you all.
Thank you, Dr. Manoj. Now I request the chairpersons to honor Dr. Manoj Khanal. And I invite Dr. Naresh Chawla, he is the Vice President of Delhi Medical Council, to honor the chairperson. Dr. Naresh Chawla, sir, please. And there's two announcements. One announcement is there is a lucky draw at the end of the session by Systopic Company. There will be 3 prizes that will happen at the end of the session. And second announcement is, as we all know, you must be aware, Mr. Arav Bhardwaj, son of Dr. Atul Bhardwaj, orthopedic surgeon, presently practicing in Saroj Hospital. His son completed about more than 2,600 kilometers in 32 days from Manipur to Netaji Subhas, or what we call to India Gate, Netaji Memorial. And there is a function for this. Dr. Bhardwaj is going to invite you all and say a few words. Dr. Bhardwaj, please.
Good afternoon, respected seniors and friends. I'm Dr. Atul Bhardwaj. I think few of you would be aware of the event, some maybe not. So just to tell you in brief, my 10-year-old son, Arav Bhardwaj, he did a 2,600 kilometers bicycle yatra from INA Memorial, Moirang, Manipur to National War Memorial, New Delhi. He started this yatra on 14th April 2022 from INA Memorial, Moirang, Manipur. The reason to start this yatra from there was that in 1944, 14th April, it was Netaji Subhash Chandra Bose INA who hoisted the INA tricolor for the first time on the Indian soil. And he concluded the yatra at the National War Memorial, New Delhi. So throughout this yatra, he visited 8 states and paid tribute to the heroes of independence at Red Hill, Kakori, Champaran, Chauri Chaura, Meerut Shahid Samarak, and Gumnai Baba Samadhi. After this, his name came also in the Asia Book of Records for the longest cycling trip by a child, 10-year-old child. So to inspire more children of his age, we made a documentary on the same